Well, good morning, everybody. Hope everybody had a good evening and a good restful night. Um, have your cup of coffee and you're comfortable for this morning. Life is much better in Saratoga Springs this morning. We are back at home and with internet, and so we are ready to go. Before I start the section on atypicals, I'm going to take the opportunity to just answer a few questions that came in yesterday. One from Fred asks, if anyone knows, I'm curious. We talk about a 5.07 filament for sensation testing, but I've never been able to find out what units of measurement the 5.07 represents. Is it some conventional measurement of units or a unique scale or something else? Well, interesting question and a little bit esoteric. It turns out that the 5.07 gauge, the unit of measure gauge is 10 times the diameter of a wire. This came about, probably 200 years ago when wire was being drawn by hand, and they used this term gauge. So 5.07 gauge roughly means that the diameter of the monofilament is 0.5 millimeter. And then sometimes it's confusing because it's called a 10-gram monofilament, and that's not really the case. It's a 5.07 gauge monofilament that bends with 10 grams of pressure. That was the standardized unit. And this, when Sims and Weinstein initially developed this scale, it was developed for folks with leprosy. So, and then it was transposed and validated for the diabetic population. So there's a couple of other variations on that, but that basically is the deal. It is a 0.5 millimeter filament that bends with 10 grams of pressure. And another question from the same gentleman, do any of you have any personal experience using the T-brace anti-gravity device? Looks like it may be a high risk for falls, even though the most offloading. Yeah, Fred, I have tried this a couple of times. I'm assuming what you mean is the patellar tendon bearing brace that actually suspends the foot off the floor. I've tried it a couple of times, and on both occasions, it has proven cumbersome and frankly dangerous for the people that I tried it on. So I don't have anything worthwhile to tell you about that. There were a couple of other questions that appear to be patient specific, and what we've decided to do is we're going to answer those individually by email rather than for the entire group. So, okay, pre-malignant and malignant skin tumors, we're going to get started here, and we'll start with the skin cancers. So, as it turns out, basal cell carcinomas are the most common form of primary skin malignancy. They tend to be very slow growing, locally destructive. They're common after the age of 40, and of course, they're most common in people who have had prior exposure to sun or some other form of ionizing radiation. There are multiple variants of basal cells. You don't need to be responsible for those variants. Remember that the treatment of a basal cell is excisional biopsy. I've seen questions that are a little tricky where one of the answers might be incisional biopsy. You don't want to incise these, you want to excise them and close them primarily. I will share with you that basal cells and squamous cells are quite common on the lower extremities. So given that those of us in wound care spend a lot of our time looking at the lower extremities, have a fairly high sensitivity for spotting these things. And, you know, as I've always told our residents, if something looks funny, it's probably funny. And a biopsy would be in order. Squamous cell carcinomas, they are a more invasive form of skin cancer, most commonly, again, found in sun, ultraviolet exposed areas. They can develop as a precursor from something called an actinic keratosis or arise de novo just as a squamous cell. Yes, as a squamous cell cancer. The treatment, again, like basal cells, is excisional biopsy. Squamous cell cancers do have a slightly higher risk of metastasis. Actinic keratoses, these are these little sandpapery, rough lesions that can lead to squamous cell cancers if they are not dealt with in their early forms. Again, on sun-exposed areas, treatment for these oftentimes would be liquid nitrogen cryotherapy or topical 5-FU, 5-fluorouracil. Marjolain's ulcer, I want you to be aware of this, this particular type. This, of course, is an eponym named after Marjolain. So this French surgeon, Jean-Louis Marjolain, back in the 1800s, initially described the ulcer as a squamous cell carcinoma arising in an area of prior skin damage. We have colloquially called them scar carcinomas, burn carcinomas, but the point is that we should have a high suspicion of malignancy with any unusual looking lesion that occurs in an area of prior scarring, injury, or burn. This picture is a patient of mine from back in Buffalo that came initially with a large venous leg ulcer. And we initiated multi-layer compression therapy. She was mobility challenged, so we set her up for wound care at home. And she came back to see us about a month later, and this very odd-looking thing had developed in the superior aspect of the wound. I biopsied it on that day, and it was a squamous cell carcinoma. So this really fulfills the criteria for a Marjolain's ulcer. This is a squamous cell cancer that arose in an area of prior skin damage, and the prior skin damage for her had been this recurring venous leg ulcer for many years. So be suspicious. Melanomas, of course, these are the ones that we worry about the most. These are potentially the most lethal form of skin cancer, but also one of the forms that has seen the most positive development in terms of treatment over recent years. The lethality and mortality from malignant melanoma is far lower than it was years ago. These can occur anywhere. There are multiple types. Up until maybe 5 or 6 years ago, the Breslow's depth and Clark's level were used to describe melanomas. And we'll see in just a little bit that now most centers and most pathologists have gone to describing melanoma according to the American Cancer Society definitions, the TNM series. But this is new enough that you may still see Breslow's depth and Clark's level on an exam, and we'll explain that in a little more depth. So here's just a pictorial illustration of the characteristics of benign versus malignant pigmented nevi or pigmented moles. And you'll see that the malignant melanomas tend to be more asymmetric. They have uneven edges. They have 2 or more shades, and they tend to be larger than 6 millimeters. This is a bone scan showing skeletal metastases from this deep malignant melanoma on the great toe of this 99-year-old lady. This had been described as Clark's level at least 4 with Breslow's depth of invasion measured to 5.1. So here are Clark and Breslow. These guys both developed these schemes independently in the late 1960s, and Clark's level was graded as 1 through 4 and was graded based on the depth of penetration into the skin in terms of levels of the skin, epidermis, dermis, levels of the dermis subcu. So the depth of penetration into the levels of the skin was predictive of the risk of lymph node metastases. Breslow's depth, on the other hand, was the actual measured depth of the lesion, or the measured thickness of the lesion with a micrometer, and this was used as a prognostic indicator for survival. So Clark's level, Breslow's depth, just be familiar with them on a superficial level. And again, the TNM system is presently the most popular scheme on American Cancer Society format. Merkel cell carcinomas, these are very rare. Only about 200,000 cases ever reported in the literature. They tend to be very aggressive, and overall the prognosis is poor for any lesion over 1 centimeter. They are tumors of the touch receptors of the skin. Let's move now and talk a little bit about hypersensitivity syndromes and vasculitis. So this picture on the right, if you see that, it's vasculitis until you prove it's not. And biopsy, of course, is the way to prove. Vasculitis is a pathologic process of inflammation and destruction of blood vessels. The clinical presentation is really variable. Diagnosis is made based on biopsy. And when you biopsy, you want to try to biopsy one of the newer lesions rather than the ones that have already become very dark. Vasculitis can impact any organ system. However, the skin is the most common organ system, and the bilateral lower leg is the most common skin presentation. So, you know, like so many things that we deal with, they happen on the lower legs. So we really have to have a broad understanding of things that can happen, especially down below the knees. The classic description of vasculitic lesions on the skin is the 3 Ps: painful, palpable, purpura. If you have further interest in vasculitis, I would direct you to this 2012 International Chapel Hill Consensus Conference, where they came up with this schematic, basically describing and localizing different forms of vasculitis based on the size of the vessel. Certainly beyond the scope of what we're doing today, but be aware that that's there. It was really a pretty elegant piece of work. And this is a close-up of that same guy that I showed you pictures of. And these palpable purpura are very painful. Leukocytoclastic or hypersensitivity vasculitis is the most common of the skin vasculitides. And this is a related and heterogeneous group, including all of the following. This type of vasculitis can be associated with infection, chemical, drug exposure, and there are multiple other names: Henoch-Schönlein syndrome, typically in children, cryoglobulinemia, Church-Strauss, Wegener's granulomatosis. There are a number of others, but they are all in the family of vasculitis. So again, the clinical presentation tends to be painful, palpable purpura lesions, most commonly on the lower extremities. They're round and usually regular, well-defined in appearance, and they also can have a nodular appearance. Histology, I don't think that you're going to need to describe or regurgitate anything about the histology, but in terms of the pathogenesis, I've seen questions about the circulating immune complexes. So I think I would put in the back of your head that the pathogenesis or the development of vasculitis is based on deposition of immune complexes that activate the complement pathways. All right, bullous or blistering diseases. The first here is pemphigus vulgaris. This is a very specific blistering disorder that is caused by autoantibodies. So this is an autoimmune phenomenon. Autoantibodies which disrupt the connections between the squamous cells of the epidermis. It's the most common type of pemphigus, primarily in middle to late-aged adults. Great big bullae that burst easily. Now, we'll see on the next slide an entity known as bullous pemphigoid. And the historical distinction between pemphigus vulgaris and bullous pemphigoid is that pemphigus vulgaris, as you can see in the third bullet from the bottom, presents initially with an intraoral lesion and then skin. The diagnosis of pemphigus vulgaris as well as bullous pemphigoid is based on biopsy for immunofluorescence. And the treatment of all of these is with immunosuppressive agents, typically systemic corticosteroids for one. So here is, this is what pemphigus vulgaris looks like. These are lesions on the back. These are the anterior chest. The silver, where you see the silver here, this is silver that has leached out of silver wound dressings onto the wounds. And this is the intraoral lesion up in the upper left. Bullous pemphigoid. This is the most common autoimmune dermatosis. And again, this is an autoimmune attack on components of the skin, particularly the basement membrane in this case. Dot spoke with you yesterday about the basement membrane and the hemidesmosomes. And this autoimmune reaction really can be thought of as a type of allergy to your own skin. And again, biopsy for immunofluorescence is how the diagnosis is made, and treatment with immunosuppressive agents. And this is just really a garden variety picture of what bullous pemphigoid looks like. And a few more pictures. The question is commonly asked, what do we do about these blisters when we see these in the clinic? Well, you know, there's nothing actually written in stone about what to do with these blisters, but my editorial about this, if you will, is that a blister really is nature's best dressing. It is warm, it's moist, and it's sterile, and if the blister remains intact long enough, the wound will be re-epithelialized underneath by the time the blister cap falls off. That's all well and good, but when we see blisters like this on the ankle and feet, areas that are at high risk for trauma, I will elect to evacuate these blisters because I just have such a strong feeling that these people will get home and they'll bang their foot on something, or the dog or the cat will scratch it open and then raise the risk for infection. So I will unroof these and dress them as the partial thickness wounds that they are. Connective tissue diseases, systemic lupus erythematosus, or SLE. 85% roughly of these folks have skin manifestations, and the manifestations include a malar rash. So if you can see me out there sort of drawing a picture on my face, it's a very typical red butterfly-shaped rash on the cheeks. There also tend to be these plaques on the dorsum of the hands and the fingers that you can see in this photo. These lesions are extraordinarily photosensitive. They don't do well with sunshine at all. There are mucous membrane lesions. They itch. And then in the variant called discoid lupus, there are scalp lesions as well. Just a few percent of folks with lupus will develop leg ulcers in the course of their disease. And again, like so many other things that we take care of, the location is on the lower legs, around the ankles, around the malleoli. They tend to be very painful. a punched out purulent appearance, variable granulation. And for any of these, there's really no magic in terms of wound care. It's based on what you see in the wound bed, keeping a clean and granular wound bed, maintaining moist wound healing, all of the things that you already know. So lupus, again, is a form of vasculitis, and there are tests, blood tests available to test for systemic lupus. You may be asked about drug-induced lupus. There were originally about 46 medications that were potentially implicated with drug-induced SLE or a false positive anti-nuclear antibody. Of those 46, the only 3 that occurred or that caused this problem with any regularity were procainamide, hydralazine, and quinidine. Procainamide and quinidine, sort of old school cardiac antidysrhythmics. Hydralazine, an alpha blocking antihypertensive that is still used. Scleroderma, also sometimes known as progressive systemic sclerosis. This is a condition caused by excess proliferation of fibroblasts, excess collagen proteins, and 35 or 40% of people will develop skin ulcers during the course of their disease. The most common form of scleroderma is the CREST variant, and CREST stands for, the C stands for calcinosis, which you see in the periphery of this wound, the top portion of this wound. That is rock hard calcium. And this is called calcinosis cutis. And if you see that around the edge of the wound, start asking more questions about scleroderma and CREST. These folks also may have, accompanying the calcinosis, Raynaud's phenomenon, esophageal or swallowing problems, sclerodactyly, and I'll show you a picture of sclerodactyly in just a minute, and then telangiectasias, these tiny clusters of capillaries around the skin surface. There is a systemic type of scleroderma, and then there is a localized type with no organ involvement, simply involving the skin. Linear scleroderma, this most often occurs in the first couple decades of life, and during the growth phases, it can lead to bad orthopedic deficits. And this is what sclerodactyly looks like. People that have this type of involvement with their scleroderma, it tends to lead to a palmar deformity and tight skin over the proximal interphalangeal joints that lead to this type of ulceration. Of course, rheumatology is always on board for these folks with these types of problems. And anecdotally, I'll share with you that I have had some limited success using the anti-calcineurin agents such as tacrolimus. You may recognize the brand name Protopic, but tacrolimus applied topically for these has, at least for me, been of some benefit with a few of these people. All right, skin manifestations of internal disease, sickle cell disease. This is the most common form of hemoglobinopathy in the world. It's an autosomal recessive trait that tends to occur primarily in if not exclusively, in the African American population. And the red blood cells genetically form as in a shape of a sickle rather than as a sphere or a disc. Usually, folks with the expressed form of this disease will manifest early in childhood and the most a common presenting syndrome or symptom is abdominal pain in these poor babies due to the sequestering or loading of these sickled cells in the spleen. So basically, if you can imagine a big chute, and you know, you dump a bucket full of baseballs down that chute, they're going to tumble and roll and come out the other end. If you dump a bucket full of anything shaped like sickles into that tube, they're going to get bunched up and they're going to jam up somewhere in there, and that's exactly what happens in the vasculature. So the resulting event is a painful ischemic event. Sickle cell disease diagnosis usually is made on prenatal genetic testing, and also can be postnatal detection in with a blood test looking for hemoglobin S. Again, generally diagnosed in the first year of life. Sickle cell ulcers, these again occur on the distal lower extremities. And they're sort of wet and purulent looking ulcers. They are exquisitely painful. And most folks agree that compression, multi-layer compression therapy, similar to what we would do with venous leg ulcers, is the most effective treatment. All right. Factor V Leiden, this is due to protein C resistance, and factor V leads to progressive thrombosis, more venous than arterial. This diagnosis is commonly not made until sometime in middle age, when an individual develops a apparently completely undeserved deep venous thrombosis. I had a brand new patient last week that had his first DVT 5 years ago, his second DVT 3 years ago, and ultimately it was realized that this was secondary to factor V Leiden, and he is on lifelong anticoagulation. But he now has venous leg ulcers as a result of his impaired venous circulation. Moist wound care, multi-layer compression, lifelong anticoagulation. Necrobiosis lipoidica. This is a fairly poorly understood idiopathic inflammatory condition characterized by collagen degeneration associated with diabetes, sometimes called NLD, necrobiosis lipoidica diabeticorum. NLD is much easier. So more than 50% of folks with necrobiosis will have type 1 diabetes. However, less than 1% of patients with diabetes will develop NLD. It's fairly rare. Lesions develop slowly. Frequently, they are asymptomatic, like the ones you see in the picture here. Common location, once again, the lower leg, anterior tibial ridge. This lady was from my clinic in Buffalo from a couple of summers ago. She came in with a wound on her arm that she wanted us to help her with, but it was nice out, even in Buffalo, and she had shorts on. And so I asked her some questions about these lesions, asked her if I could take a picture of them because they were such a good picture of necrobiosis, but these were completely asymptomatic for her. So sometimes they ulcerate. This is also from our clinic in Buffalo. This young lady in her 40s with type 2 diabetes and well controlled came in, and she had these on one leg and the open ulcers on the other leg. So we treated her with systemic corticosteroids as well as intralesional injections of corticosteroids. And of course, steroids in the diabetic population is potentially problematic because of problems with glycemic control when they're on the steroids. Bullosus diabeticorum. This is also in the category of wound trivia, similar to the corona phlebitictica I showed you yesterday. So this is a spontaneous, non-traumatic, non-inflammatory blistering condition that is unique to patients with diabetes. It tends to arise in folks that have had diabetes for a long time, and the literature tells us that definitive explanation awaits elucidation. But just so you know, if one of your patients says, geez, I woke up this morning and I had this blister on my foot and I didn't do anything, so be aware that this slightly oddball entity, Bullosus diabeticorum, is out there. Pyoderma gangrenosum, you know, this is in the category of atypicals, but to me, this is the most typical of the atypicals. A fairly poorly understood pathophysiology. These ulcers tend to enlarge fairly rapidly. They're nasty looking ulcers. And when you look at them, you say, oh my gosh, that really needs to be debrided. So it is very important that you understand this term pathergy. Pathergy is the term applied to the enlargement of the lesion with any associated trauma. So characteristically, pyoderma gangrenosum, if you sharply debride these aggressively, they will grow larger. And then you debride it again, and it gets bigger yet. So pathergy is the enlargement of the lesion with mechanical trauma. I can almost guarantee that if you're going to take a test on wound care, there's going to be a question about pyoderma gangrenosum and pathergy. Also realize that pyoderma gangrenosum can be associated with underlying conditions such, and the most common of them would be ulcerative colitis or Crohn's disease. That's the most common connection, but there can be association with other autoimmune diseases as well as malignancies. Sometimes a post-surgical pyoderma may present initially as a wound dehiscence or infection. And again, the most common site is on the lower legs. This is a young man from our clinic in Buffalo in his early 30s, and all of these scars represent previously healed pyodermas. Treatment, moist wound care, protect the lesions, sometimes intralesional injections with corticosteroids. Topical steroids sometimes are of benefit. Systemic corticosteroids such as prednisone, immunosuppressive drugs such as cyclosporin. Again, commonly I will ask for rheumatology to get involved with me in the treatment of these. People have a genetic predisposition to pyoderma, and there will be recurrence in about a third of patients. And this is a good opportunity to remind you that when you're biopsying these slightly atypical lesions, or even if you're biopsying what you suspect to be a skin cancer, you're well advised to send your specimens to a specialized dermatopathologist. The dermatopathologists are accustomed to looking at odd things on the skin, and in our experience, you'll get a little bit better return on unusual diagnoses from dermatopathology than you will from a general pathologist. And this is what they look like. So pyoderma, pyo meaning purulent, you get that from looking within the wound bed, and then the gangrenosum because the periphery tends to be sort of a dark purple. Calciphylaxis, also known as calcific uremic arteriopathy, relatively uncommon. The link here that you should know about is that this condition is by far most common in patients with end-stage renal failure on either hemodialysis or peritoneal dialysis. So end-stage renal failure typically is associated with hyperparathyroidism, therefore abnormal calcium metabolism, and that tends to be the predisposing condition for calciphylaxis. But again, I think you'll be asked about the relationship between calciphylaxis and end-stage renal failure. Tends to be what's known as an acral distribution, meaning fingers, toes, tongue, penis, peripheral distribution of lesions. These represent or resemble a vasculitic process and can look like peripheral vascular disease. And it is actually an acute infarct of the sub-Q tissue and overlying skin. Treatment, lowering serum phosphorus, lowering serum calcium. One of the most important active treatments that can be done is the administration of sodium thiosulfate with dialysis treatment. Sodium thiosulfate can be mixed with the dialysate and can be quite effective in the treatment of calciphylaxis. Just had one of these a couple of weeks ago, actually in a patient undergoing peritoneal dialysis, and the nephrologist is in the process of converting her over to hemodialysis so that we can get sodium thiosulfate into her. There is a loose recommendation for hyperbaric oxygen therapy. It is not an approved indication, but there's some anecdotal evidence that hyperbaric oxygen therapy can be beneficial for calciphylaxis. Toxic epidermal necrolysis. This is a potentially life-threatening dermatologic disorder because of the area of skin and the desquamation that can take place. So this is characterized by widespread erythema and a necrotic and bullous detachment of the skin, resulting in extensive exfoliation and possible sepsis and death due to that exfoliation. Stevens-Johnson syndrome is a similar disorder. However, Stevens-Johnson's tends to occupy less than 10% of the body surface area, where toxic epidermal necrolysis is greater than 30. There is, of course, just to confuse things, there is an overlap syndrome that involves both TEN and SJS, and that's characterized by widespread, irregularly shaped reddish or purple macules with blistering. Epidermolysis bullosa, a tragic, poorly understood condition with presently no treatment. It is a genetic skin disorder, almost always discovered in infancy and childhood, and results in blister formation from mechanical trauma. This is sort of that classic child in a bubble. They have to be so carefully protected that even the friction from putting a shirt on over the shoulders and arms can lead to blistering. There are 4 main types with additional subtypes. The spectrum can be very mild to severe, disabling, and fatal. Factitious disorders, these described by a variety of terms, but basically self-inflicted wounds. NSSI, non-suicidal skin injury, SISL, self-inflicted skin lesions, self-mutilation disorder, factitious disorder, whatever you call it, these are manifestations, of course, of an underlying psychiatric difficulty. So counseling, psychotherapy is an important part of this treatment. The leg on the far left, this is a young lady shaving shaving skin off her leg with a razor blade. The picture in the middle is cigarette burns, and the thigh on the far right is skin picking of the thigh. So again, a somatoform disorder accompanying various psychiatric illnesses. When you see this, you will see lesions in various stages of healing. They will have well-circumscribed borders because they have been dug out, typically by the fingernails or some instrument. They will always be located in areas accessible to the hands and where they can reach. So if you see this, ask to look at their back, and you typically will not see any lesions in the middle of their back where they can't reach. The difficulty and the challenge is not necessarily in the wound care, it's in building the confidence and trust with the patient to allow them to accept the fact that they are doing this to themselves. These two pictures are from a young lady in our practice in Buffalo, and these lesions were on her bilateral temples. More pictures of the same. So, self-mutilation disorder defined as a psychiatric disorder characterized by deliberately harming one's own body. There is quite a bit of literature out there and quite a few books written on this topic. But the bottom line is this self-mutilation satisfies some part of a troubling psychiatric cycle of events, and they can't help it. So this is not the condition where you look at your patient and say, well, the answer is simple, don't do that. That's not the answer. So Johnston, who has written quite a bit on this, says, let me be clear, self-injury is not a healthy behavior, but neither is it inherently suicidal. For many, it is primarily a coping method used to deal with disturbing thoughts or emotions. And that's in his publication, Patients Who Self-Injure, They're Not as Dangerous to Themselves as You Might Think. Whoop, sorry. Okay. Cat bite. I don't know who posed for that picture, but I can't figure out whether that's a real cat or a fake cat. But anyway, it's a good picture of a impending cat bite. For cat bites, dog bites, human bites, any kind of bite, always remember tetanus prophylaxis. And I point that out because many of us in our wound care settings, we don't have tetanus injections in our clinics. So we have to remember to send them someplace for tetanus. Cat bites, a very high infection rate due to the depth of the length of the teeth and the depth of penetration. Common bacteria are Pasteurella multicida and Eikenella corrodens. And you will probably have a question, something like, what is the most appropriate antibiotic treatment for a non-penicillin allergic patient with a cat bite or a dog bite? And the answer is amoxicillin clavulanate or Augmentin. So I will remind the audience at this point that any of you who are taking the CWSP exam, the physician exam, you will be responsible for some prescriptive knowledge such as antibiotics and dosing and so on and so forth. Those of you who are taking the CWS exam without the P, you will not be responsible for questions regarding antibiotics. And for the penicillin allergic patients, doxycycline, cefuroxime, cefpodoxime, there are other regimens. But remember the amoxicillin clavulanate. Dog bite, similar story, only we have to be careful to remember about rabies. So the animal needs to be quarantined and observed. Most common organism, Pasteurella canis, similar to Pasteurella multicida. And again, in the non-penicillin allergic patient, amoxiclav or Augmentin is the appropriate treatment. Human bites. These really are the most dangerous of all. not only do we introduce skin flora such as Staph aureus, Staph epi, Strep viridans, but we also have in our mouths anaerobic bacteria such as Corynebacterium and Bacteroides fragilis. So these should not be closed or sutured. They should be cleansed, irrigated, and debrided. And in the non-penicillin allergic patient, amoxicillin clavulanate plus anaerobic coverage such as metronidazole. Penicillin allergic patient, moxifloxacin. Snake bites. At the end of the day, antivenom is the only appropriate treatment. And again, don't forget tetanus prophylaxis. We don't ice these because it increases local skin necrosis. We don't heat the area because it increases vasodilatation and a spread of the venom. So if antivenom is given in adequate doses and in a reasonable time frame, debridement is rarely necessary. Spider bites. Black widows are not infectious, but they can lead to a tetanic form, not titanic, but tetanic as in tetanus, an extraordinarily painful muscular spasm of the chest and abdominal wall muscles. And again, don't forget tetanus prophylaxis. Brown recluse spiders, way overdiagnosed. But oftentimes people that develop community-acquired MRSA lesions will believe those to have been spider bites. So the rule of thumb, unless somebody remembers and has seen themselves being bit by a spider, usually it's not going to be a spider. Most cases it's going to be MRSA. And when we get into the bioburden section a little bit later, I'll have some more pictures about this. Controversial treatment of brown recluse spider bites, excision and primary closure, or agents such as dapsone. But these can tend to be severe and necrotic lesions. Let me just check a text to make sure what Frank is telling me. Okay, all right, I'm just about done, and then I'll tell you what's in that message. After this is the self-study section regarding atypical wounds. Pay particular attention in this section regarding the difference between a bulla and a vesicle. All right, the difference between a bulla and a vesicle. So that is the end of that. So Frank, if you'll allow me to click on the questions, I will do that. And following the questions, then Tiffany will have some updates regarding the exhibit hall. No? Okay. All right. Never mind. Carol asks, how is vasculitis treated, and does it change for someone on palliative care? Well, good question. Typically, vasculitis is treated with initially systemic corticosteroids. And I think the answer to the question on palliative, for a patient in palliative care, is whether the vasculitis is in some way adversely impacting their quality of life, because of course, palliation is about comfort. So I would say, editorially speaking, that your treatment would be directed at relieving the discomfort of vasculitis, if there is any. Ellen asks, for the blisters, why not do a needle aspiration and leave the roof in place? Again, there is nothing written in stone about this. You are not wrong to do a needle aspiration and leave the roof in place. And, you know, the sort of goes in and out of favor, whether you completely unroof the blister and treat it as a partial thickness wound, or whether you do a needle aspiration and leave the roof in place, believing that it may function as a split thickness skin graft. So no perfect answer to that, and there doesn't need to be. Ellen also asks, pyoderma gangrenosum, perhaps sharp debridement increases the oxygen tension sufficiently that spores can germinate. Spores, I'm not sure what you mean by spores. When I think about spores, I think about something like Clostridium perfringens and gas gangrene. I'm not aware that spores are associated with pyoderma gangrenosum, but we can answer that question as a one-off as an email if you've got some more information there. Fred asks, in the leg example of factitious wound photo, tell us when you suspected self-inflicted. Well, that was an interesting case on one of the ones of the leg. In fact, the legs and the lower abdomen. That patient, interestingly, was a psychiatric social worker. And I was suspicious of that on her initial visit, that these were self-inflicted. And I tried very, very gently and tactfully to broach that subject. And she got angry with me and got up and left the clinic. So told me she was going to go for a second opinion. And I certainly wish I could have known what that second opinion was, but it was on the first visit. Ellen asks, what are your thoughts on worm therapy for some of the autoimmune disorders you've described? Well, Ellen, you've got me on that one. I don't know anything about worm therapy. We sometimes discuss maggot larvae in wound care, and sometimes we discuss leeches. But again, share with us via email what you mean by worm therapy, and we will see if we can come up with an answer. John asks, sorry, I think I missed you saying an antibiotic to give to treat human bites in addition to augmentin. Oh, yes, something for anaerobic coverage, such as metronidazole or flagyl. So that is the end of the questions for this session.
We're going to take a break.
And we're going to take a break for how many minutes?
Until 9 o'clock.
All right, we're going to take a break for 9 o'clock, which according to my watch is 6 or 7 minutes. Thanks everybody, and Dot will see you back in a few minutes to do her next session.
And when you're on your break, remember that we have 4 exhibitors in the virtual exhibit hall. So give them a quick visit, and remember, if you sign up with them and get their information, you are eligible for a gift card. So anyway, enjoy the break. We'll see you back in a few. All right, well, welcome back from the break, and we'll get started again. This is actually one of my favorite lectures because wound care, as you know, is so visual that that's all of what it's all about in terms of deciding if what we're using is working or if we need to move on to something else. So we'll go ahead and get started on this lecture. So anyways, the first thing we're going to document is the degree of tissue destruction. And this is, in so many cases, very wound type specific. It's not universally utilized, though, all these different staging systems, for example, like the CEAP that we described yesterday, you don't see that outside of maybe vascular surgery offices. So it can cause a little bit of confusion. For example, if in a wound care center, we send a diabetic fit back and say that it's a Wagner grade 3, that's one that goes into the joint. If it's a pressure injury stage 3, then that goes just into subcutaneous tissue. So we want to be very specific and know that the person that we're sending this information to also can utilize it. So it can present a little bit of a barrier to documentation, but not so much. So these are the systems that we went through yesterday. And so you have all of those. And so if we don't use this or you're not sure, then we can just use partial or full thickness. Partial thickness being into the dermis, but not all the way through the dermis, like our abrasions, skin tears, blisters. This is how deep a split thickness skin graft goes, for example. And then everything else is full thickness. Now, I mentioned this yesterday. So here are two wounds. The one on the left is, he's a gentleman that fell against a chair in his kitchen. And then that was when we first saw him. Then he was debrided, and the one on the right is a little bit down the road. And then this is after a period of time. But my point yesterday was if you receive this wound and you see the one in the middle and it's completely filled in, but you see that granulation tissue, you know at some point in time it was full thickness. So you would definitely want to consider that a full thickness wound. We're going to do a general skin assessment, looking at some of the things that were described yesterday. Our skin is normally warm to touch, and so if it's much warmer, it could mean it's inflamed or infected. If it's very cool, it could indicate some problem with the blood flow. We look at color for signs of specific diagnoses like hemosiderin staining. As you see here, the atrophy blanche that you see there on the right-hand side. So those kind of things can give us some clues into what the diagnosis may be. We look at, general skin issues, and many of these are dermatology issues. I think everyone in wound healing, especially in wound care centers, should have some sort of a really good dermatology book, because a lot of times we get the rashes and the weird skin things that, frankly, in a lot of communities, it's easier to get into a wound care center than into dermatologists. So, many of them are things we see frequently and we can go ahead and treat, but obviously we would have to refer on if they needed a lot more testing, et cetera. And then we just look at the general condition of the skin, if it's overly dry or, things that we can make recommendations to make it more soft and supple and less prone to injury. And then just looking at what's the difference between, younger skin and older skin, there are certain changes that we look for. So our assessment is going to be our foundation for developing a goal. We can't, wound care is not one size fits all. So we're not going to be able to use the same dressing on every patient. And so we need to do the assessment to figure out not only what we're going to do topically, but also why the wound is there in the first place. But from the standpoint of treatment, the wound assessment is definitely what drives it. It helps us to look at changes from the previous assessment to tell if it's better, if it's worse. We know that wounds are dynamic, that they can change. And this has happened to everyone. You make an assessment one week, and you have to sometimes decide or get from the patient how much drainage is there really. They may feel like it's draining a lot, so you use something that absorbs a tremendous amount, like a fiber type of dressing, like I say, calcium alginate, and the next week you find out that it's been sticking all week. So we have to sometimes change things around a little bit. But if we do a good assessment, most of the time, whatever our dressing is that we select will be the correct one. And I'll be talking about dressings later on. So as we do this wound assessment, it's important that we have a common language. And I'll say this a few times. And that language needs to especially be utilized amongst our own treatment group, and so that we don't have variations. And I'll mention those as we go along. So we usually do this assessment weekly. You can, certainly when somebody comes into our center twice a week, then we do a mid-assessment, and we still measure because that's just what our documentation calls for. But to change treatments in 2 or 3 days based on measurements, really not given it enough time to see if something's going to work. So we evaluated every dressing change, but I think measurements and overall global assessment done weekly is probably adequate. And then you're going to document by your facility or your agency protocol. Of course, we all have different documentation systems. Some are very wound specific. Some have been created by the person like Epic or Cerner or whoever our documentation system is for our hospital, or built like ours right now by our IT department. So we want to make sure, again, there's consistency amongst our group who are looking at the same patient. So we're going to look at the general condition of the wound. Does it look like it's getting better? Is it smaller? Are there subtle goals that are being met? Is there less necrotic tissue, more granulation? Is the drainage less? Is the pain improved? Those short-term goals, if you've met those, then that's progress. So we don't have to be jumping around and changing the dressings that we're using. Or are things not going well? Is there irritation on the surrounding skin? Did they react negatively to the dressing? Is the exudate not being managed adequately? Does the patient have pain with their dressing change? And I'm here to tell you, one of my biggest soapboxes is that we can't hurt patients. If we can change, they come to us with their own pain, but if we can change the dressing or add maybe a contact layer so that it's not exquisitely painful when the dressing is done, we'll have a much more satisfied and happy patient. That is so stressful for them to know that they're going to come, either the nurse is going to come to them, the treatment nurse is making rounds, they're coming to the wound care center, and know that they're looking at exquisite pain. So doing everything we can to mitigate that is, of course, important. And this afternoon when I talk about dressings, then I'll have a couple of other suggestions for that. So these next couple of slides are just to let you know that there are a couple of tools that were developed that assess healing. We know that we have a tool to assess risk for pressure injury, but there are a couple of validated tools that are in the literature. There's several actually, but the ones that you see most often are the push tool and the Bates-Jensen wound assessment tool. So let me show those to you. Now, the push tool was developed by the National Pressure Ulcer Advisory Panel, now National Pressure Injury Advisory Panel, many years ago. And I got to tell you, when I first saw this, I received it in order to help validate it. And I thought, this is just looking at surface area, exudate, and tissue type. That can't really tell me if my wound is healing. Well, you know what? It does. It validated out. And so it's a weighted score. And so as your numbers go down, meaning your wound is getting smaller, the exudate is getting less, the tissue type is improving, then it shows that what you're doing is working, and it does show healing. Now this one I know is quite an eye chart, but the Bates-Jensen, Barbara Bates-Jensen is a doctorate in nursing who is in UCLA. And this is just a very extensive 13-point assessment tool that again is weighted. And so if you have numbers that are going up, it indicates that the wound is degenerating, and that the numbers are going down, the wound is improving. So I would just not know what's in these tools, but just recognize that Bates-Jensen wound assessment and the push tool are validated tools for healing. So as we start to document, we're going to document where it is. Ideally, our systems would let us number the wounds. Sometimes they don't. And so we want to be as descriptive as we can, because people come in obviously with more than one, and we want to be able to determine which is which as we go to measure them. And so we use the common terms that we become comfortable with: proximal, distal, or superior, inferior, medial, lateral, anterior, posterior, those kinds of things, to be, again, as specific as we can, especially in the presence of more than one ulcer or wound. So when we're talking pressure injury specifically, we definitely want to use the bony prominence that's involved. So if you look at this poor soul, she's got two lesions, two ulcers on her hip area. So we don't want to call that the hip. We want to say left trochanter, left iliac crest, up in her shoulder area. We don't want to just say back. I would say left scapula. If it was, wherever the bone is, name the bone, and that will be very specific to the reader. So as we look at location, we can do proximal distal or superior inferior. On the feet, it's best and most specific to use the digits and the metatarsal heads in a forefoot ulcer, especially, obviously. So we would say fifth toe, and you could say fifth plantar toe, fourth metatarsal head, third toe, second metatarsal head, etc. If we're looking in the midfoot, then we say medial or lateral midfoot, and of course, plantar heel, posterior heel, or left or right lateral heel. And then keeping in mind that we own two of a lot of things, we want to be real careful when we're measuring bilateral anything, because it's very easy for someone to switch them, and then that's going to throw off your healing trajectory. So let's just say it's, we've got two heels, but let's say they only have an ulcer. You go back to wherever you're going to chart and you say, was that right or left? You're going to say, okay, they were laying on their side, they were facing the window, that must be left. Well, if you're not sure, look again. Sometimes I'm right in the room where I'm documenting with this person, but my back may be to them, and I say, was that right or left? I still have to turn around and look, even though I just did the dressing. So let's just make sure that we're very specific on that. Wound dimensions are so critically important because reduction in surface area is what tells us that what we're doing is working. And surface area is determined by the length times the width, and you just multiply the two together. Recognizing that when we do that, we are measuring a rectangle. So you will be accounting for some space that is not necessarily wounded, but that's a very acceptable way to measure. There are now cameras, as you see on the right, that are, that are smart. They have chip technology that they have been taught, what is red, what is yellow, and can give us a nice percentage of the different types of tissue in the wound, but also be able to measure that wound for us. So we're going to do the length times the width, and then we, of course, measure depth, and we'll look at that next. But, there's different ways that people do depth. Let's say you're looking at a wound that's completely filled in, and there's no depth to be measured. So you can do, let's say it's 5 by 7 or whatever. And if you put it times 0, that's fine for length times width. But I will just warn you that if you're sending out documentation for a patient to get dressings and things, they need to have a depth, because their computer is going to add that 0 into the equation, and anything times 0 is 0. So they will come up with a 0. Their computer is going to say, there's no wound there. They don't need dressing. So most people will put a 0.1, just indicating that it is an open wound or there is a lesion there, and it's not really adding too much space to it, but it does tell any computer system that's calculating either volume or for dressing surface area that there is actually a wound there. And that little measurement excerpt that you see down there is just showing the area, but it's also showing the volume, and that's a calculation that computers do. So we're going to measure the length times the width, and the length of the recommendation, but again, this is where your group needs to just decide. So most will use head to toe, or 12 to 6 as the length, and then the perpendicular to that as the width. Now, for some people, that just doesn't make intuitive sense to them. To have a length, like in this transverse incision, having a length that's smaller than the width just doesn't look right. So it doesn't matter, because when you multiply the two numbers, it's going to be the same. So just decide for consistency amongst your group how that is going to be done. Now, many times we also have wounds that are on a more of an oblique angle, and maybe this isn't as dramatic of one, but when you try in a wound that's a little cockeyed like this, to try to keep and maintain length times width, all I would need to do is move my little measuring guide over a little bit, and I'm going to get a totally different measurement than here. So what I recommend is that if it's on an oblique like that, still find the area that's closest to 12 and the closest to the foot or the 6, and then use that as your length, again, because we want to find the longest and we want to find the widest. And certainly patients live in they what's my numbers? What's my numbers? And so, you know, what we have to make sure they understand is that we're simply measuring the longest and the widest. And sometimes there's all this crazy change going on that's healing in other areas. So many times showing them the pictures is more valuable. We used to have tracings that we could do, but of course it became a bit of an infection control issue, keeping stuff like that in a chart, and we got rid of paper charts. So letting them know and maybe showing them their picture and show that they are actually making headway. And then we have dilemmas like the one on the bottom right, where you've got a cluster of multiple ulcers in one area. And especially when we're doing venous ulcer care, I don't know if you find that sometimes they'll have a little place pop up this week and then it's gone the next week. I tell patients it's like that whack-a-mole kind of game. It's here and it's there and it's there. It's hard to keep track of that many ulcers in one small area. And so it is very acceptable to measure the general area in which the ulcers are found. And then, of course, if you do photography, then you can actually visually show in your documentation that things are getting better. So this one down in the bottom right is very hard. If you wanted to do 1, 2, 3, 4, 5, 6, 7 measurements in that little cluster of space, good luck. It's just hard to keep up with, but it's not impossible. If your system says, nope, you have to measure all of those, then I would take a global picture that might be able to be printed so we could identify which was number 1, number 2, number 3, etc. So then we're going to measure depth, and that's, of course, we do it the same way. We measure from the edge of the wound into the deepest area straight in. That will be our depth, as you see here, grasping it at the skin level, laying it onto our measuring guide. Now, one little recommendation, when we're dealing with especially diabetic foot ulcers, many times when they come in, they have a lot of callus that has developed around the wound, and many times that's going to go. And so it's not a pathologic thing, it's just callus. And so what we would want to do is measure from the edge of the wound in and not the edge of the callus in, because that's going to add a couple of millimeters that really is not part of the wound. Then we're going to look for any other space, and that's our undermining and our tract. And as we teach our colleagues, as we have new physicians, physical therapists, nurses, whoever, come into our practice, we need to give them permission to, or give them the confidence to really probe around in wounds that have space. Because if we have undermining or we have tract, we need to find them. We need to be able to find them, first of all, obviously to measure, but also to pack adequately. So if you're using a sterile applicator, sometimes they're so small you may be using a little metal probe. You're not going to make a new track. But we've all done the rooting around a little bit, and then our cotton applicator gives, and then you get some drainage out. That can be a little scary, but it's what needed to happen. We need to find those areas because we may be filling in, undermining our spaces and not necessarily seeing improvement in the shape of their size of the wound. So undermining is a space. Tracts are tunnels or individual narrow tracts, but we want to find them, and we're going to look at those more carefully. So undermining is a space that you can appreciate. Oops, sorry. And maybe this one up here is not as good. I can tell you that once that clot was gone, there was a lot of space under there, but you can appreciate that there is space here. So it's undermining is parallel to the skin, and it's an area, like in this case, running from here to here. And the way we usually measure it is with a clock method. And I superimpose little measuring guides on top of here, but it's just to indicate that this was, let's say, 5 centimeters from 12 to 3 o'clock. And the purpose of that is so that the next person who goes back knows where to find that, so they don't have to do all their probing around. So it gives you, again, we want to measure it. To do 12, 1, 2, and 3, or if it's circumferential, do all the hands of a clock would be very difficult to keep up with. So most will probe around find the deepest area of that undermining, and that is the depth, and then use the clock method. But again, it's something that you agree upon amongst your group. So we want to find it, and I will tell you to do as I say, don't do as I do. We should not be shoving wooden ends of cotton applicators into wounds. Now, this wasn't into a wound, it was underneath that dry hunk of skin there. But there are little splinters that can come off. So if you're going to use that, we have wonderful little metal probes that we use for exploring around into a wound. If you have a real narrow area, you can use an angiocath if you have those available to get into little areas, although your length is a little bit limited there. But in the case of this, we found this space underneath this dry skin, and we could have dressed that until the cows came home, and we're not going to improve it. So it was a benign space. Our provider came in the same day, unroofed that whole thing, and then we can see the wound and see what we're dealing with. Now, let's say you work in a long-term care facility or you're in home care. You know, you can't necessarily, maybe you can, but it's all in your practice act if you're a nurse, unroof that. But if you're finding something like that, get them back to their provider so that can be unroofed, and it will make your job easier, and I can tell you that it will make the wound heal faster. Tunneling and sinus tracts are individual tracts that go into the depths of the tissue, and some want to differentiate this, and again, you can make an argument for both, that a tunnel has a beginning and an end, so like a tunnel that you drive through. Others just consider a tract that starts at the base of the wound and goes in deeper than the depth. So again, here's another option. So if you have a wide open wound and you know there's a tunnel right here that you can measure and you can grasp the applicator there, then you can measure from the base of the wound down. If you have a tunnel that goes way down here, you may want to measure it from the edge of the skin down. It doesn't matter as long as you can appreciate as the measurements change. We want to watch our wound edges to assure that they are open and conducive to migration. Pamela, when she talked about wound bed prep this afternoon, will use an acronym that has an E in it, time or dime, and the E is looking at the edge. We want it to be open and know that the cells can migrate off. Now, this is a blown up version of a diabetic foot ulcer, I believe. But anyway, what you're seeing here, I just haven't cleaned it yet. But I blew it up just to show that a close examination, you can see a nice pearly pink epithelial edge there. And that tells us a couple of things. One is that the wound is closing, but two, that our wound bed is conducive to those cells migrating out. We want to gently clean that, but we have to clean it. And then there is something we laughingly call the wrinkle test. You can, if you have good light in your room, you can actually squeeze the edges of the wound, and it may be a single or a couple cell layers thick, but they will still wrinkle on the top of the surface. So it's kind of an interesting way to look to see, is that skin or is it not skin? And many times you're looking at like, it'll have a wet look to the wound and then sort of a matte look to the cells once it dries a little bit. And it tells you that, yay, things are getting better. Then we want to know if those wound edges are not healthy and if they're not going to close. So we're going to talk about epivally, but when you see these edges like this that are rolled and socked in, that is a beautifully granular wound bed. But the chance of those edges migrating out are slim to none. And it's so hurtful and hard to tell a patient, you know, I'm really sorry. I know you've worked hard at this wound, but those edges are probably going to have to be completely excised away or lifted up in order for that wound to go on to healing. Wound edges will also tell us if there's trauma, if there is a callus there, if we have a separation, as you see in that right-hand picture, and we need to, you know, discuss with the patient and look further at offloading and protection of that peri-wound area. We have thickened edges. I mentioned this yesterday with hyperkeratotic edges that we see sometimes build up on venous leg ulcers. Here's another one. It's a little macerated, but you can see it's just thickened keratinocytes that are probably not going to migrate unless we trim them away or use something to flatten them out. The other thing, remember that if you begin to see this, then it may be that the cells just don't want to migrate because it's not a well-prepared wound bed. The one on the right-hand side is just a big old pressure injury. And while, I mean, some of these edges look nice and open, this looks like evidence of trauma. And then you have, this is just a mess. You have this curled up tibia here. So that ulcer needs a lot of attention. But sometimes we can just do it with good dense foams. I use this as an example. This is real easy when you're taking care of venous leg ulcers, but this was a polyvinyl alcohol foam, but any good dense foam many times will do it. And so that's just a week apart, but we were able to get a dressing on. It was a sacral shaped dressing, and we're able to get those edges flattened down and some pretty nice healing in a week's time. So the term, and we mentioned it yesterday with pressure injuries, is epibole, and Pamela will talk about it again today. And this is just the edge, and the one on the right-hand side is just an old 35mm slide that I don't even know where I got it. But it's just such a good example. What's happening is those keratinocytes are migrating down the moist edge. And so if we don't have the granulation tissue coming up to meet the skin's going to find its way down to the granulation tissue. So as I mentioned, this is a little bit exaggerated here. Epibole is just the migration. Many people will call that rolling, but nonetheless, it is not conducive, as you see here and here, to that wound resurfacing. It needs to be removed. So the implications with all of this is that we have to get rid of bad edges, expose it. This is how that wound should look. And again, just good education to the patient. Don't be alarmed. I'm going to make your wound bigger, but it's what we have to do in order for it to continue to move on. We're going to document the exudate, how much is there. This is, again, a little subjective. You have to know when was the dressing changed last. And if you're asking the patient, sometimes they will know, sometimes they won't know. But many times we know when the home health nurse was there, or perhaps we put the dressing on the week before. So again, we just give it our best shot as far as amount. Most of us have either none, scan or small, moderate, large, copious. Again, knowing when the dressing was changed is the most important thing. So that's how much is there. And then we went, oh, this is just a kind of a guesstimate help. It's an inexact science, but if you, let's just say you've got a 4x4 anything, and this was changed a week ago, then that would be a small amount. It's taking up most of the 4x4, whatever, foam, dressing, gauze, whatever, but it took a week, so that's a small amount. If it was changed a couple of days ago, that might be moderate. If it was just changed an hour ago, that would be large. So again, just using kind of a best guesstimate based on when that dressing was changed. Then we're going to describe the color of the exudate, and it's just what you see. Now, most of the time we're going to see red, yellow, tan, pink, green, brown, bloody, you know, whatever, red. And that can be impacted by our previous treatment. It can be impacted by bacteria that's growing there. So there's a difference, though, between color and character. So the character is those commonly used terms, serous. I'm going to show you pictures of these, serous sanguinis, sanguinis, and purulent. But before I move on to the pictures, be very careful about using the word purulent. Many of the treatments that we use, let's say we have necrotic tissue and we are using collagenase. It's going to liquefy that dead tissue, or we're using honey, or we're using surfactant, whatever, and it's liquefying that tissue. As that tissue liquefies, it's going to be creamy colored. It may not smell so great. And so we want to be careful that we don't document it as purulent, because purulent is pus, and pus is just a collection of white blood cells in exudate, and so you can have it where there's no bacteria at all. But the word purulent oftentimes will make a reader think it's infected. And so let's say the provider comes in after I've done my documentation and I've written purulent, when it was really just liquefied necrotic tissue, they may say, oh my goodness, let's culture it. You're culturing dead tissue, you grow something, and you can understand the ripple effect there. So we want to make sure that we have the ability to call it something else. It may be liquefied necrotic tissue in a narrative form, previous treatment residue. What if you're using cadexim or iodine and you've just got this brown and white granular stuff on the wound? How do you document that? So be very specific, but a good thing to have is previous treatment residue. But if you're not sure, don't make it purulent. Just go to the narrative and document what you see. So here's what we look at. This is predominantly serous, just sort of that yellowy serum, the liquid part of the blood. Serosanguinous, which is a mixture of the pink and the yellow, and then pure blood or sanguinous here. Then purulent. So here we might call that tan purulent. I'm going to come back to this because there's a story behind what was underneath there. But you can see, I think we all like to express stuff out. That's so fun. So I was pressing on it, and you can see that I was causing the exudate to come out. The one on the right is just green purulence. That was just nastiness that was coming out, and that's exactly how that would be documented. And the one at the bottom actually had the pressure injury there, had a lot of necrotic tissue previously, and we were using collagenase, and that was just liquefied necrotic tissue. So it looks kind of purulent, but we wouldn't want to document as such. Previous treatment residue. This is using cadexim or iodine, so you see that brown mixed with pink, and so really we can only chart what we see, but it's an expected outcome of what we are doing. This is a nanocrystalline silver, which looks sort of silver metallic, but I would look more at this exudate, which is more of a sanguinous or a serosanguinous, but it's thicker because it's mixed, it's been trapped under that dressing. So we just don't want to raise any red flags if we know that we're not looking at infection. So here's the rest of this story. So here I was expressing this out. Again, the provider comes in, they just unroof that, and it was just a little collection of exudate that wasn't able to drain adequately. So the body responds with white cells, and that's what gives it that color. So we got it unroofed. And of course, if you're seeing this in home care or long-term care, you're going to notify someone. And if you can find space underneath there, then perhaps you could send them out, or someone could come in and do that debridement for you. Now, the foot at the top looked like a blowfish, and we could have expressed all day. We weren't going to get to the root problem. So she needed to go into the hospital and have that filleted open because she had a rampant infection in that foot. We document odor, but I recommend that you clean the wound before you document odor. So many of, especially an outpatient, because they've had many times these wraps on for a week, they may have not so great feet, for example. So sometimes the odor can be pretty overwhelming. But once we get it clean and out from under our nose, if there's truly an odor, it will usually remain with the tissue. But you just have to kind of think, where's the patient been? How long has this been here? And is that odor really pathologic, or is it just because it's been on for several days? We're going to document the type of tissue that we see, and many of our documentation systems ask us for a percentage of each of the tissues. And so that's, again, a best guess. We can't scientifically do it. Some people will divide it into quadrants and add that up, but it's really just a guess. So in this case on the bottom, that's fascia, so we usually don't have that as an option for percentage. But if we could, then we could say that that was 75% fascia, and then 25% other tissue. I wouldn't call that granular. But then if you jump ahead, our percentages have changed. So we're now at 25% fascia and 75% granulation, 90% down to 50%. So again, it's just a best guess. So let's talk about the definitions of these tissue types. eschar, and I will tell you from the test exam, the exam standpoint, and you'll see some of this on the practice one that we give you to take away after the day, is that they will show you a wound and ask you what the predominant tissue type is. So when you see this and you see anything that's dark, whether it's dried eschar or soft black, call it an eschar. So if it's dark black or brown, then it's considered to be an eschar, or eschar, some people say. If it's yellow, then pretty much people call that slough. There's unfolding information about what slough really is in terms of being more of a byproduct of of inflammation versus really dead tissue, but don't let that muddy the water for you. At this point in time in the United States, most people document slough as the yellow dead material. And I'll be showing you a difference, but I think in the next section. But in any event, if it's firmly attached to the wound bed, then it's dead tissue, and it goes under a change as we moisten it. So this is moist loose slough. This is a mixture of slough and eschar. You can see that's liquefying. This may be described as dense adherent. And as you get experience in wound care, as many of you know, the one on the left is easy to get rid of. The one on the middle, you can tease that off with a scalpel. This stuff on the right, that densely adherent, is really hard to get rid of. Operative debridement is easiest there. But if that's not an option, then you may want to cross-hatch it and use an enzyme, and Pamela will talk about that later. And then there's yellow. I guess I'm getting into this now. You know, it's this stuff that we see on the surface of the wound. So the left one is just a collection of exudates. It's not dead tissue. If you can aggressively clean that, which we need to do, and I definitely will talk about that later, then we can get a lot of that off. But take a look at these over here, and I'm sure that you've seen it in your practice. That it's this coagulum. It's this densely adherent, tenaciously attached stuff that you can actually almost peel off, not necessarily dead tissue attached to live. And so this is a byproduct of inflammation, and that's where we're going to need to start understanding. And there was actually a study going on called the Slough Study by the International Wound Infection Institute, and that is going to have to be resumed because most labs right now are tied up with, of course, the COVID problems. So I'm going to show you these two videos. And if you look at the one, I think I'm going to show you that one. Oh, okay, that one's not working. So if you look at that, as Lee is dissecting that away, that is dead tissue. The one on the right, unfortunately, this doesn't play. I think my next slide may have it though. There you go. Let's see if this one will play. I hope, yeah. See, and then I'm sorry it's blurry, but you can see he's actually just peeling that away. So I wish I could see your eyes, but there's a difference in tenaciously, firmly attached down to the clean wound bed, dead tissue, and this coagulant that sits on the surface. And so here's that same wound, only it's not so blurry, before and after. And you can see he's not cutting it, he's kind of peeling it off. And so if we continue to see, people call that biofilm, it's not all biofilm. But anyway, we need to use something that's going to do a better job of absorbing that and wicking it away. So, you know, more to come on that because a lot of research is unfolding about this. So then our ultimate goal, of course, is to have a healthy granulating wound. The one on the left is a pink non-granular versus the one on the right, which is nice and healthy and red granular. And we want to make sure that we're talking about these correctly. So, for example, this patient had this big old pressure injury, and there was no way, he did not want surgery. He would not use negative pressure. And so the decision was made, and he was cognitively able to make this decision that we are going to palliate him and not expect it to be granulating. But back to what you're seeing. If you're looking at just plain pink tissue or red tissue that's not granulating, we don't want to call it granulation tissue, because over time, if something's always called granulation tissue and it's not filling in, there's a problem. You know, 6 months later, if it's been granulating, it should be way above the level of the skin. So non-granular makes us look to say, why isn't it granulating? Maybe they need a debridement. Maybe they need something that will be better to stimulate granulation tissue. And then, of course, this is just really good, healthy red granulation tissue. Then we can get too much of a good thing. We can have this, what is called hypergranulation or exuberant granulation, and it takes on different looks. Many times, if you see it, look like the one on the left, and it's like translucent and thickened and edematous. Oftentimes, that is bacteria, and the bacteria are in the tissues. It's not necessarily infected, but they're producing toxins, and our body responds with edema. And so oftentimes you want to think about bacteria and address the bacteria. The one on the right is pretty much too much of a good thing. And so those keratinocytes are not going to migrate up and over that hypergranulation tissue. So we need to do something about it. So here is a before and after with a ultrasonic contact thermal ultrasound, which is the best device in the world for getting any kind of wound cleaned up. They're just wickedly expensive. But you can see that in one sitting, we were able to knock down all that hypergranulation tissue, and truly it was with a minimal of bleeding. Using dense foams, as I mentioned earlier, you can, for the edges, you can also, especially under compression, compress down hypergranulation tissue like this. I'll show you this again in the next session. And then many of us will use silver nitrate. And silver nitrate, Pamela will describe in debridement, and it is something that will help to knock down that hypergranulation tissue. And chemical cauterization of this kind of tissue is actually a CPT code that you can use for billing. And then lastly, of course, we want to get epithelialization started. We want to see that the wound is starting to resurface, remembering that if it is a full thickness wound, it is only going to epithelialize from the edge. And if it is a partial thickness wound, you may end up seeing a lot of these little islands of epithelium that will come up. I showed you this picture yesterday, and then form those little islands and migrate out. So we want to be, again, very careful and not disturb the wound any more than necessary. This is where undisturbed healing is so important. Once we get it to a good trajectory and it's epithelializing, leave it alone. The less often we change that, the less we're going to disturb those cells. Secondarily, when we think about measuring, if you have a system that gives you the opportunity for a percentage of wound bed, hard to do when you've got epithelialization from the outside in. So unless you stick with the original measurements and then say it's 40% epithelialized, which we're not going to do, you will be able to show evidence of epithelialization just by your decrease in your length and your width. So another thing that happens with wounds that you've seen is that as they begin to close, they actually bridge together. And so how you document this, again, just make the decision within your own facility or group. So this was a patient who was in a long-term care facility, was not able to be sharply debrided because she was combative. And so we opted to use collagenase. The nurses in the facility did a great job. You can see this denser area here is beginning to show the full true depth, and the wound is cleaning up. And then a few weeks later, you can see there's a bridge of epithelium there. So your choices there are either to continue to measure edge to edge, length, and widest. There's still some undermining. You want to account for that. Some will then take, let's say this was wound number 1. Some will make this wound number 2 and then wound number 3. So they'll convert it to 2 wounds. Again, it doesn't matter. It's just having it consistently documented. We're going to look for structures because these are critically important in terms of coverage and making sure we keep them healthy, protect them from injury. Of course, bone is obvious to most, very hard, white. And I mean, if you have bone that's exposed like this, there's nothing that we're going to do to cover that up. So that really needs to be surgically addressed. This is our metal probe, and they're not expensive, but I would, if you can, I would get some, because let's say you have a narrow track. We have a lady right now who has a shoulder injury that we're waiting for her surgery to have it washed out. But when we probe down into this wound, we can not feel though, we can sense it with the metal probe. You can actually tell the difference between hitting soft tissue and hitting bone. And so they're wonderful. They have to be re-sterilized in between patients. So it depends on where you work and if you have access to those. But they're a nice safety in terms of not using the wooden end of a cotton applicator. And they're narrow, so they slide in easily. And so it's a nice to have thing if you have that option. The one on the right was actually, and we're always concerned, and Leo will talk about osteomyelitis when we do bioburden. We always are concerned when we have exposed bone that we're going to have a bone infection. And so, that's just a given. But this was a fellow who had a pre-tibial injury, he fell off of a jet ski and hit a dock. But anyway, so we had this bone exposed, we kept it moist, and he ended up completely granulating over that. and never did have any kind of osteo. So it's not 100% of the time that they're going to have an infection, but we want to address it, and we want to be as aggressive as possible about getting it closed. Fascia we described yesterday, but as we debride wounds, many times we're down to it. So we want to make sure that we are protecting it and making sure we keep bacteria at a minimum so that we don't have it cause any kind of migrating infection. Tendon, of course, should look like the one on the left, nice and glistening and shiny. Once they turn yellow or become fibrous like the one you see at the bottom, they have to be debrided. It's not going to close over that. If it happened to close over that, it would probably reopen. So again, these are situations where they need to have a surgical approach. We want to know what vessels are in the area so that we, of course, are not going to traumatize it. The one on your left, this lady had too much pain, and so we did not do any kind of sharp debridement on her. And you can see that little capillary running down the middle of her wound bed there. And, you know, if we would have gotten into that, we would have had some pretty good bleeding, but it wouldn't have been like drama. She would have exsanguinated. Let me see if this will play. It does. So I want you to watch right there in the middle. You see that pulsing? That's why I say know the neighborhood. Now let me tell you the story. This guy had a ray resection, so there's a much larger wound than you can appreciate there, and we were doing negative pressure wound therapy. And the nurse came out and said, you know, come look at this. And she was getting ready to put the negative pressure back on, and there was that pulsing vessel there. So we obviously don't want to put negative pressure over that. And so think about some of the wounds that we get that are vascular access, maybe groin wounds from a FinPop bypass. So we want to make sure that we are assessing that and knowing where they are so that we can protect them. And certainly before we put any negative pressure onto an area like this, we want to talk to the surgeon to know that there is soft tissue over any potential vessels. We're going to look at the surrounding skin and identify any potential injury or issues there. We certainly, and when we have overwetting, we call that maceration. You can certainly see the one on the right. That's what happens when you take a shower with a contact cast on. But this is macerated. It needs to be dried out. If these edges get thickened and full like that, then they are going to, they're not going to close. So we may need to trim those up, do a better job of absorbing the exudate. Perhaps maybe we can't absorb the exudate until we get some edema resolved or something. Then we would want to do something like a cyanacrylate, which I'll describe later, or skin preparation of some kind in order to protect that. We're going to look for erythema, indicating that there might be some sign of infection, and of course differentiating true erythema from maybe just normal inflammation, depending on the age of the wound. We'll look in the peri wound for any other sign of problems, like in the one on the left, a reaction. They're either reacting to the dressing itself, or they're reacting to their own exudate. So it could be one or the other, but we need to figure that out. The one in the middle is actually where negative pressure foam was put onto the skin without any drape underneath it. But that wet, irritated area is called denuded. I'm going to come back to that one. We want to look for any telltale signs of rash or inflammation. So if it's a fungal type rash, then we would want to treat it with an antifungal. If it's inflammation, then we would want to treat it with an anti-inflammatory, like a topical steroid, temporary for a short duration. But let's go back to this one, the one in the middle here. Many people call that excoriated, and if you call that excoriated for the rest of your career, it doesn't matter. Everybody's going to know what you're talking about. But true term excoriation are linear scratches caused by itching. So what you see here actually are true excoriations. And again, if you call that other one this excoriated, again, the visual will be appropriate for most people, but the true definition of excoriation are linear scratches or linear injuries caused by scratching. So in summary, and then I'll look for questions, our assessment is what has to drive our treatment decisions. And in our little group here with the wound course, we always say drainage drives dressing decisions. That's going to be our ultimate driver. But we have to do our assessment to know if what we're doing is working, and utilize some system for saying, where are we? Remember the prognostic indicators that we discussed, that if it's not 40% or 50% closed, regardless of the wound type, this is more validated in venous leg ulcers and diabetic foot ulcers. But about a month in, look to see where you are. If you're not seeing some short-term goals met, even within a week or 2 weeks for that, but if you're not seeing change that is meaningful, then we need to step back, either change what we're doing or look to see if we're missing something from a diagnostic standpoint to make sure that we're covering all of our bases as we take care of these patients. So with that, I'm going to look to see if we have any questions. Is there a medical difference between calling something a wound or an ulcer, or can you use it? That's a good question. Yes, probably so. There are probably billing issues, and I wish I was smarter about the billing piece. But I think most of the time, we certainly call pressure injuries, or we call them ulcers, or we will use venous leg ulcers or diabetic foot ulcer. But then when you have other things like a traumatic injury, such as a skin tear, or you have an avulsive injury because of a trauma to a leg or something, then that probably would be best called a wound. So it's really, as you look at the ICD-10 codes that you need to apply to these different lesions, then there's probably a difference. Now, and I do know that some people, if a wound has been present for a month, they will convert it to an ulcer, meaning that it has become chronic. So again, that's probably a billing thing that I'm not real savvy on, but usually, again, ulcers are usually our diabetic, venous leg ulcer, pressure injury or pressure ulcer, and then the others are probably wounds. Please tell us more to how to envision and use your tip. Oh, I love this, about the wrinkling. Okay, great, here it is. So you're looking at your wound. And if you are in a center or you're someplace with good light, once you get the wound clean and you get all the dressing material away, after it's had time just to have a little air exposure, many times if you get it the right plane with the ulcer, you can see there's a difference between in the wound bed. And you'll see a glistening wet look to that area that is still wound. And then you'll see where it changes to sort of a matte appearance. There's nothing scientific about this. This is just an observation that we've had. So when you see that it's got that matte appearance or non-shiny appearance, that's probably a couple of layers of cells that have migrated out. So if you just pinch the edges just a little bit, if it's in an area that sort of lacks, you'll actually see little wrinkles in that matte area. So it's just an observational thing on my part. Certainly no science there, but it is kind of telling, and it's something that we sort of celebrate when we see. So the next question is, granular tissue is in what stage? When you see granulation tissue, I'm assuming that you mean stage of healing. That is in the proliferative stage. Dimensions, height. Would you enter measurement 2 by 3 by 1? Oh, you mean if it heats up above? Generally not. I guess you could say it's hypergranulation tissue, so it would be a +1, but most of our systems are not able to document that. If you were paper charting, you could say 2 mil, or you could go to your documentation narrative and say 2 millimeters is hyped up or hypergranulated 2 millimeters above the level of the skin. That would be exquisitely accurate charting. But I think most people don't, because we're fitting it into a system that doesn't have the ability to put a plus. And so, but you're correct. It would be an appropriate way to do it. We just mostly don't have it. So most will still just document it as a 0.1 at the very least. Do you often debride peri-wound maceration or try to salvage the skin by dressing? It really depends. If you think about the ulcer that I showed, where it was like callus that was macerated, if it's really thick, that skin's going to be tough to dry out. So if you can shave down, if this is in your licensure, if you can shave down some of that maceration, you're usually not going to get any bleeding. Then it'll be easier to dry out. So it really depends on how thick it is. And sometimes, and I'm never trying to skirt the issue with this, sometimes there is a difference between maceration and over-wetting. And you've probably seen this where the patient comes in and the skin is usually flattened. It's not thickened with maceration, and where it's like a sponge that has soaked stuff up. But a lot of times you can take a dry gauze and gently almost roll off some of the white macerated skin. And then you see sort of normal skin underneath it. So, debride if it's really, really thick, if it's callous that you know needs to go anyway. And then if not, just gently try to roll off some of the macerated skin cells that are sitting on the top. And what is the billing used for silver nitrate, Heather? I'm going to have to look that up, but it says chemical, you can Google it. It's chemical cauterization of tissue. Now, a warning, not a warning, but silver nitrate cauterization that you're using to flatten out tissue is a CPT code. Cauterization with silver nitrate that you use to stop bleeding is not. That's part of your treatment. That's part of your procedure for the debridement. So you can use the silver nitrate. It's chemical cauterization, and I can look that up and find it for you. And then another question says, can physical therapy apply silver nitrate in their scope of practice? Now, I've heard Pamela say, and she'll have to answer this, that she can't, like if a nurse can't give Pamela some meds and say, can you give these meds to him? That's not in her scope of practice. Now, topical application of silver nitrate, I'm going to have to ask Pamela. I don't know if she's on right now or not, but we'll get Pamela to answer that in terms of the scope of practice. It might be state by state. I would think that you could, because you're chemically cauterizing. Although it's a prescription to get the sticks, it's not a drug, I don't think. So we'll get Pamela to answer that question. And yes, I think anybody can use that CPT code, and I will find that CPT code since we've had a couple of questions. So Kimberly, I'll get that for you also. Okay, oops. You discussed leaving a dry eschar yesterday and minor drainage at wound edge accessible. Question is how to dress and minimize infection as you wait for the eschar to lift. Cadexter, iodine, betadine. Okay, good question, Robert. So dry eschars, usually most people will either skin prep them or they'll paint them with povidone iodine. And there was a time in long-term care when that was a red flag for surveyors, but I think they finally got the idea. And what you're trying to do is just keep it as dry as possible, but at the same time reducing the bacterial burden in the peri-wound area. And so if, you know, how to dress it, if it's on the heel, if it's a vulnerable area, I think just wrapping it with a bulky bandage is probably protected. If it's not in a vulnerable area and maybe they're bed down, you know, just painting it with betadine and leaving it open to air would be appropriate. So I wouldn't use cadextrin or iodine or silver sword for sure, because we don't want to, and you don't want to protect the dry eschar with a foam, because if you do that, you're going to start an autolytic process around the edge of that. So either dry gauze or leaving it open to air is the way to go. What test would you order if you get down to bone? Lee will be talking about osteomyelitis, and he'll differentiate the type of imaging that you would want to do for that. And then the last question, for wounds in the foot that have more of a tunnel, say 0.8 by 0.8 by 4, okay, small diameter, deep wound, the depth is pretty severe. I heal primarily. Oh, I heal. That's your documentation. Primarily measures the area for debridement and doesn't take this into account for billing. Yeah, that is a problem. And I don't think there's a good answer for it. Unfortunately, our systems just go by our surface area for debridement. So I think you would still have to just put the centimeter square, the surface area. But those are tough wounds. And many times you don't know, you can't see. We just said this on a wound the other day. I wish I had some sort of little pediatric scope that we could get into these wounds and see what's down there. And so if we know where the base of it is, the bottom, we know we're not down in an organ or something or a vessel, sometimes we'll just silver nitrate down the track and then pack in something that's really wicking, like a hypertonic salty dressing, like me salt. I think that's the only one on the market, to try, or a wicking fiber dressing to try to pull it off. And so as that silver nitrate would slough off, then it would freshen up the surface. But you have to be really careful with that. You just don't want to be you obviously don't want to blindly be roto-rootering around in a track, but also you also blindly silver nitrating. So you want to make sure that you are kind of know what's down there. Oh, guess what? Heather found it. The CPT code for chemical cauterization is 17250. Thank you, Heather. 17250 is the chemical cauterization code. And remember, it's only for hypergranulation tissue, not for chemical cautery for bleeding. What formula do you use to calculate AWM lesser? I've heard some physical therapists use a percentage for variance in wound edges or exact length times width. I'm afraid, Heather, I'm not sure what you're asking. Some therapists say length times width only the slough debrided, not the whole wound. I think you must be talking about field debridement. And again, I'm not a expert at the coding requirements. Lee might be able to answer that. He's going to be coming in here right now but I think, oh my gosh, there's still more questions. I think when you are debriding, you really only calculate based on the area that you debrided. So someone's heal over with a thin scab with polymem pink, do you call this a scab or eschar? If it's a scab, you can pick it up. I mean, if you can peel away something, it's a scab. It's just coagulated blood. If it's firmly attached, so dead tissue is attached to live tissue by a covalent bond, and either it has to be a sharp instrument or an enzyme that cleaves that apart. So if you have a scab and you can actually peel it off, or if you have something on the surface and you can actually peel it off, then that is a scab. The name of the ultrasound wound debrider that you used, I wish you had, she'll cover it, but I'm going to give you the 3 that are on the market, and I am very proud to say we are getting one in our new clinic. There are 3 on the market. One is the Soaring Sonica, one is the Arabella, and then the one that we are getting is the Sonic One by Misonics. They're very expensive. You can bill for the procedure. They ultimately, I think, would pay for themselves, though, in improvement and healing. They're perfectly wonderful. And then what causes slough? Slough is, remember, and then I'm going to have to turn it over to Lee. Slough, remember, is dead tissue if it's attached. Byproduct of inflammation. Stay tuned for that because it's just inflammation is causing exudates that are coagulating on the surface of the wound. In fact, I kind of like the word coagulum. It sort of gives a visual, but it's tenaciously adherent, but it's not attached by that bond. So that's unfolding information. You wouldn't see it on this test, but just stay tuned because we've got the slough project going on, and it will resume after this virus pandemic has settled down because most of the labs that we were using to do our analysis are caught up in the COVID. And then lastly, how caustic is betadine to a wound? Povidone iodine is known to be caustic or deadly toxic to fibroblasts. So we do not want to use it in its full strength into open wounds, and I'll talk about that in the next section. So with that said, I will get Dr. Ritchie. If you need to take a little quick stretch, do so, and he will be right back to talk about nutrition. Thanks. There you go. Make sure you can hear that.
Let me fix, and Frank, let me know if everybody can hear me. I'm back for the nutrition section. If you just shoot me a quick text and be sure that everybody can hear me. Okay. Hello again. So we will take off now onto the nutrition section. Certainly a pertinent topic in wound healing, in a global sense, but certainly critically important in the pressure injury world. We realize that the majority of human evidence in nutrition in wound healing is in the area of pressure injuries. We know that the stage of the pressure injury that develops is impacted by the degree of malnutrition or undernutrition. And the prevention of malnutrition is certainly equivalent to a risk reduction for pressure injury formation. What we're going to see throughout the course of this is that determination of nutritional status is a multifactorial process, and in some ways not as simple as we had thought it to be in the past. We'll see that the determination of nutritional status is moving away from laboratory testing and numbers to a more historical and weight-based format. Okay, so what sort of things lead to malnutrition? Well, any sort of catabolic illness, any sort of illness that leads to breakdown of tissues, trauma, surgery, sepsis, etc. Any involuntary weight loss for any reason. If I'm 200 pounds today and I'm 180 pounds 3 weeks from now, and I've lost 20 pounds from my usual body weight, then almost by definition, I'm going to be malnourished. Chronic illnesses, diabetes, cancer, renal failure, all of these can be catabolic in a sense. Chronic wounds, we have to remember that our wounds secrete a protein-rich fluid. So in our highly exudating wounds, we need to be careful about replacing those protein losses. Enteral fistulas, any intestinal problems that impair absorption, any problems with dentition. Perhaps there's no problem with availability of the food, but there's a problem with actually mechanically processing and eating it. And then, of course, there are those segments of our population that have difficulty accessing adequate food. We know from multiple animal studies that decreasing caloric intake by a significant amount decreases collagen synthesis. It decreases matrix, extracellular matrix and glycosaminoglycan deposition, ultimately leading to decreased granulation tissue formation based on the mechanisms that we saw yesterday. So here's an interesting scenario, and when I look, back on 25, 30 years of medical practice, and especially, as an emergency room attending, I realize a big deficiency from the past. So somebody comes to the ER with, let's say, the 75-year-old lady comes in with a 2-day history of nausea and vomiting, and her abdominal x-rays reveal a small bowel obstruction. What is the first order we write when we admit her to the hospital? That order is NPO. And we put an NG tube down, and we are hopeful that we'll be able to decompress that small bowel obstruction conservatively so that this nice elderly lady doesn't have to go to the operating room for a laparotomy. But inadvertently, while we're providing that care, we're not feeding her. And so now she's been vomiting for 2 days at home, and now we've had her in the hospital for 2 or 3 days decompressing that belly, and if it doesn't work, she goes to the operating room, and then we wonder why we have trouble with postoperative wound healing. So the long and the short of it is that we need to be sure that we feed our folks, if they're not able to be fed enterally, that we feed them parenterally so that we don't put them in this acutely malnourished state. The next couple of slides, there's 2 points to be made, and those points have to do with the difference in the metabolic response to injury and stress as opposed to that of starvation. So in the starvation response, there's a generalized decrease in metabolic rate. Over the first 24 hours or so, the glycogen stores in the liver are exhausted, and the process of the manufacturing of glucose or gluconeogenesis utilizes amino acids as the primary substrate. So ketone bodies from the fatty acids end up providing energy needs. And in the starvation response, the net effect is that there is a preservation of lean body mass. So starvation response, preservation of lean body mass. In the stress response, such as following injury or sepsis, this is characterized by a decreased SVR, decreased systemic vascular resistance, basically lower mean arterial pressure, elevated cardiac output because of that, fever, hyperglycemia, and we use or burn up lean body mass. So bottom lines here, starvation response, there's a net preservation of lean body mass, and in the stress response, there is a use or burning up of lean body mass or muscle. So how do we define malnutrition? This is where it gets a little bit tricky. So the Academy of Nutrition and Dietetics, AND, and the American Society of Parenteral and Enteral Nutrition, ASPEN, published in May of 2012 the following characteristics for malnutrition. And the presence of two or more of these is a definitive of malnutrition. Insufficient energy intake, weight loss, loss of muscle mass, loss of subacute fat, localized or generalized fluid accumulation, and diminished functional status as measured by hand grip strength. So what do you see? What's the glaring absence in this list of things that we use to define malnutrition? The glaring absence are numbers and laboratory tests. So the only thing that you can really assign a number to here is the weight. So we'll talk a little bit more about weight in a few minutes. And we know that malnutrition has a dramatic impact on morbidity and mortality. When we look at this cycle, we see that undernutrition impacts immunity, leading to infection, leading to mortality. And so there's a global adverse reaction physiologically to malnutrition, to say nothing of higher treatment costs, higher readmission rates, so on and so forth. So we know that malnutrition is correlated with a significantly higher risk of developing a pressure injury. Loss of lean body mass is definitely correlated with impaired wound healing. And remember that during bed rest, when we are sedentary or bed confined, the loss of lean body mass accelerates. So as we lose about 10% of lean body mass, we have a reduction in our immune ability and an increased risk of infection. If we get above 15 to 20% loss of lean body mass, now we've impaired wound healing, and greater than or equal to 30% can lead to the development of, frankly, spontaneous wounds and pressure injuries and a complete lack of wound healing. So why shouldn't we just assume that every patient is malnourished? Well, first of all, the cost of that supplementation is expensive. Second, many of the forms, in fact, all forms of parenteral nutrition are invasive, such as TPN. If we overfeed, we lead to hyperglycemia, which causes other problems. And overfeeding also causes immune suppression. So we've got to figure out a happy medium. We have to figure out how to appropriately feed. So it's difficult to differentiate mild malnutrition from normal nutrition. There really aren't any identifying criteria developed at this time. Then we have moderate or non-severe and severe malnutrition. We know that if we're able to make a diagnosis of malnutrition at the time of admission of a patient to a hospital, that does lead to an increase in reimbursement for medical care. And also we have to remember that folks with high body mass index, high BMIs, the obese, the morbidly obese, and the super morbidly obese certainly can also be malnourished. So this is not a validated scale in any way, but this was developed by our nutrition and dietetics department within our 5 hospitals in the Catholic Health System in Buffalo. And I just thought that this was a remarkably good and complete way or context in which to assess the degree of malnutrition, especially in the hospitalized patient. So this was developed by Catholic Health in Buffalo in 2015, and I had their permission to use this. So if there's anything in here that's useful to you, feel free to use it. So just some references here on malnutrition. Morbid obesity and wound healing. So can we be morbidly obese and malnourished, and does morbid obesity lead to wound healing complications? Well, the answer to both is yes. We know that protein-sparing diets are common when people are trying to lose weight. High carbohydrate, high sugar, high glycemic index, and low protein diets are common among the obese. We know that the obese are more likely to experience wound healing complications such as post-op wound infection, dehiscences, seromas. And the reason for that is as follows. When we are born and develop embryologically, we are pre-programmed to have a certain amount of adipose tissue. That adipose tissue, or the fat cells or adipocytes, are grouped into lobules similar to the alveoli in the lungs. And each of those fat lobules has a vascular pedicle, including an artery and a vein. So when we gain weight and we add fat cells, what doesn't happen is an increase in arterial supply. So the vascular pedicles don't change. We just add a greater burden for each of them. So what we end up with is hypoxic and ischemic fat due to the decreased vascular supply. So what sort of nutritional assessment tools? Well, weight, as it turns out, is going to be one of the most important things that we look at. And we have ideal body weight, which we're going to see is really not of much practical use. And then we have usual body weight, which is. We can do food histories and dietary recalls, but gosh, I have a hard time remembering what I ate 3 days ago. So I don't know that that's a practical way of doing this unless people record their diets. We have nutrition-focused physical assessments, this NFPA, and we're going to see that this is gaining a lot of favor, but we'll discuss a little bit what some of the challenges might be with that. That includes observation of muscle wasting, subcutaneous fat loss, fluid accumulation, and or hand grip strength. And the practical challenge with that, from my perspective, is if I meet somebody for the first time today and shake their hand and look at their muscle mass and their sub-Q fat, well, you know, I can maybe make a vague judgment as to where they are, but I don't know where they were a month ago or 2 months ago. So there's no ability to compare these nutrition-focused physical assessments until you go on beyond your initial visit. And the other challenge is that the visceral proteins that we used to think were useful for the assessment of malnutrition, we find out now really are not. They're a better indicator of morbidity and mortality than they are of nutritional status, because protein molecules such as albumin and free albumin are dramatically affected by inflammatory processes, and they are negative acute phase reactants. So what does the Joint Commission say? The Joint Commission says we should assess nutrition when warranted by the patient's needs or condition, and each facility should define their criteria in writing for when they should be performed but they must be completed within 24 hours of admission. Nutritional assessments are not required at all encounters if not defined by an organization's policy or not warranted by the patient's needs or condition, so on and so forth. So it is comes down to a common sense decision, but also based on your institutional policies. The National Pressure Injury Advisory Panel says that we should screen each individual at risk of or with a pressure injury at every admission to a healthcare setting with each significant change of clinical condition and or when progress toward pressure injury closure is not observed. We need to use a valid and reliable nutrition screening tool to determine nutritional risk. We need to assess our patients' ability to eat independently, make sure they have an individualized dietary plan and assistance when necessary, and we need to keep track of the adequacy of their total nutrient intake. And the bottom bullet is so important. We have to remember to refer our patients with malnutrition or at risk for malnutrition or with a pressure injury to registered dietitians or nutrition teams for a more comprehensive assessment. So we have two validated tools as of 2020 for the assessment of nutrition, one for hospital use and the other is validated for older adults in the community and long-term care settings with or at risk for pressure injuries. So let's look at this MUST tool, first of all, the one that's been validated for hospital use, and this is it. So we see step 1, BMI, step 2, unplanned weight loss, step 3, and going on, we see that there isn't a lot of objective data here other than the present BMI and whether there has been unplanned weight loss. So again, this is the validated tool for hospital use, and you see a remarkable absence of laboratory studies here. The mini nutritional assessment, or the MNA, this is the one that's been validated for older adults in the community and in long-term care settings. And we see things like, has food intake declined? Has there been weight loss? What about mobility, psychological stress, neuropsychological problems, and then a body mass index? So again, no laboratory studies here to help us make that determination. So ideal body weight is that weight which is believed to be maximally healthful for a person based mostly on height, but also modified by gender, age, build, and importantly, the degree of muscular development. So for guys, we get 106 pounds for our first 5 feet plus 6 pounds for each additional inch. For women, you get 100 pounds for the first 5 feet plus 5 pounds for each additional inch. So as you can see, this is really not useful for determination of nutritional status at any given point in time. Now, usual body weight, we are going to see that the percentage deviation or loss from usual body weight is the most sensitive tool for nutrition assessment based on weight. So the usual body weight is what you usually weigh. And everybody has a pretty good idea of what they usually weigh. We can also measure total body weight, which is the addition of two separate components, the lean weight, which is, as you might imagine, muscles, bones, tendons, ligaments, and normal body water, and then fat weight. And typically, the adipose weight is a little bit more in women. This measurement does not allow for short-term shifts in body water or fluids and so on and so forth. But it can be useful for looking at overall trends over time. But again, keep that usual body weight in mind as the most important weight-based tool for nutritional status. We can measure lean body mass with some fancy instrumentation. but this is not either used on a routine clinical basis. Nutrition-focused physical findings, this NFPA that we discussed a little while ago. So body fat, loss of sub-Q fat in the orbits, triceps, and the overlying ribs. Well, if I meet you for the first time today and I look at the tissue around your eyes, I don't have any idea what that looked like 3 or 4 weeks ago. Muscle mass. Loss of muscle is noted by wasting in the temples, clavicles, shoulders, interosseous muscles, scapula, thigh, calf. Again, examining somebody, you can get an idea if it appears that they have muscle wasting, but again, you don't have a comparator until you've seen them a few times. Fluid accumulation, this is a tough eyeball determination. And reduced hand grip strength in comparison to normative standards. There are tables according to gender and age what our hand grip strength can be. But all of you realize you shake somebody's hand and hand grip strengths are all over the place. So again, I am challenged by these nutrition-focused physical findings, but these are validated, and this is what the American Academy of Nutrition and Dietetics and Aspen have to say about this. We can administer questionnaires. Again, the questionnaires sometimes are difficult because people have to remember what it is that they ate. But asking questions about diabetes, allergies, various medications, do you smoke, do you drink alcohol, those are important factors as well. Indirect calorimetry, just realize that we can measure your basal metabolic rate in an exercise physiology laboratory based on oxygen consumption and carbon dioxide production. Again, not useful on an everyday clinical basis. So again, if you do have the luxury of doing indirect calorimetry, you can measure trends over time, but when you're meeting Tilly for the first time today and she's 85 years old, these things aren't going to be of too much help. Nitrogen balance. We can measure in a laboratory urea, urine for urea nitrogen. We can measure this weekly. This can help to give us a look at trends in protein breakdown over time, and ultimately allows the nutrition and dietetics folks to adjust protein administration. Laboratory assessments. Not a whole lot that is helpful. Certainly glucose and electrolytes, we want to maintain these under optimal control. We want to optimize renal function in terms of BUN and creatinine. We can measure 24-hour urine for urinary urea nitrogen, as we just discussed. We can look at total lymphocyte count. All of these things are adjunctive, perhaps helpful measures for your nutritional puzzle. Total lymphocyte count is normally about 2,000 to 2,500 cells per microliter. They are increased in infection and leukemic processes and decreased with chemotherapy, steroid use, and malnutrition. So again, if you do a total lymphocyte count and you're suspicious of malnutrition and the total lymphocyte count is remarkably diminished, it is a supporting laboratory test for your diagnosis of malnutrition. Albumin. And I still see people using albumin for measurement of nutritional status, but it is completely invalid and erroneous. It is very significantly impacted by inflammation. It has a long half-life. It's really sensitive to hydration status. It's remarkably affected by liver and kidney disease. And as it turns out, the albumin molecule is a much better indicator of morbidity and mortality than it is nutrition. In other words, if normal albumin in your lab is 3.5 to 5, and your patient has an albumin of 1.5, that is really a marker that they are chronically and or acutely ill, and is a strong predictor for ongoing morbidity. Prealbumin used to be thought that this was the one lab test that we could do, and we were always taught that a prealbumin gives you an accurate look at the patient's nutritional status over, the past 4 to 7 days. It has a short half-life. It's not really affected too much by dehydration or overhydration. It's a relatively small body pool, but it is an acute phase reactant. It is affected by renal failure, and it is not at all accurate in the acutely ill population or those people with any sort of an inflammatory illness, because when that inflammatory state begins, the liver shuts down production of prealbumin in favor of producing other molecules that are frankly more important. So prealbumin is no longer useful. I've asked the question several times. Okay, I understand that in an acutely ill patient with an inflammatory illness, that the prealbumin is not accurate. I understand the mechanism for that. It's a negative acute phase reactant. But in the non-acutely ill community dwelling population that's coming in for wound care to the outpatient clinic, can the prealbumin molecule be accurate and useful in that setting? And they're telling me no. So maybe there's going to be more information than that, maybe not. There are multiple inflammatory response proteins, and many of these are diminished when things start going bad. If we were to, well, and I still mention prealbumin because we don't have any way to know whether the current tests have caught up with this most recent trend in nutrition assessment or malnutrition assessment. So I would suggest that, especially for the purposes of the exam, that you do keep prealbumin in mind. If there's a question as to what would be the most useful laboratory test, the answer is probably still going to be prealbumin. Anyway, that's it for prealbumin. Transferrin retinol binding protein, CRP, haptoglobin, alpha-1 antitrypsin. None of these are thought anymore to be particularly useful for determination of nutritional status. And remember that one of the best indicators of a good nutritional status is good wound healing. So if your patient's wound is marching on and granulating and epithelializing, chances are their nutritional status is adequate. Nutritional requirements in the presence of wounds. For patients with a normal BMI, 30 to 35 calories per kilo per day. If an individual is underweight or losing weight, obviously that needs to be boosted up. And for obese or geriatric patients, really you need an individual evaluation. The obese, you don't know simply based on their weight that their nutritional status is adequate. Recommendations for protein. For healthy adults without a wound, the DRI, or the dietary reference intake, is 0.8 grams per kilo per day. I would remember that number for purposes of an exam that you may be taking. The dietary reference intake for protein for healthy adults without a wound is 0.8. That's the baseline then. So for somebody with a chronic wound, obviously that needs to get boosted, and somebody with multiple pressure injuries or in a severely catabolic state needs to be boosted even more. That only makes common sense. So we need to provide adequate calories and adequate calories in the form of protein in order to prevent protein from being used as fuel. Water. The vast majority of us don't drink anywhere near enough water, and so we know that water is the vehicle in which transport takes place within our vascular tree, and is a normal or is a really important part of physiologic processes. So we need to make sure that our patients are drinking enough water. Suggested intake, 30 mils per kilo per day. Gosh, that's a lot. That's 3 liters per day if you are 100 kilos. Overfeeding. So this slightly perturbed looking fat cat here in the upper right. Complications of overfeeding. Hyperglycemia, as we discussed. Increased carbon dioxide production because of overfeeding and hyperglycemia can lead to problems, especially in the ICU in terms of ventilator weaning. We can develop hepatic steatosis, or basically fatty liver, hyperlipidemia, immune suppression, and elevation of BUN and creatinine, i.e. azotemia. Frailty. So here is another concept around which there really aren't objective parameters, but nonetheless, if you think about this, you'll know somebody in your life that has gone through this phase or maybe is in it now. It's a state of decline and vulnerability in later life characterized by weakness and a decrease in physiologic reserves. No gold standard for the diagnosis, but leads to an overall increased risk of adverse outcomes and complications such as falls, disability, morbidity, and mortality. And I think about my mom who died just short of her 94th birthday. Had a great run, and but in her 92nd and 93rd year, I look back now and I can so appreciate that developing frailty. More trouble getting out of the chair, was falling down a little bit more often, more difficulty in the bathroom, needed help taking showers, and she was not in any way acutely ill. She was healthy as a horse for a 93-year-old, but was becoming frail. So again, it's not just old age, it's physiologic aging versus chronologic aging, and it is thought to be the activation of multiple inflammatory pathways and ultimate dysregulation of many systems. Ultimately leads to skeletal muscle decline, which is called sarcopenia. And this is the age-related loss of lean body mass, skeletal muscle, and overall strength. Again, consequences simply of aging. And due to changes in inflammatory pathways and an increase in inflammatory cytokines. So you look at this cross-section of muscle in a 25-year-old as well as a 63-year-old. And I guess that this picture on the right, if somebody sawed my thigh in half, I guess that's what my muscle would look like, 63. All right. Lipids and wound healing. Lipids are a very important part of wound healing, especially in the maintenance and integrity of the basement membrane. So, deficiencies in lipids lead to decreased production of phospholipids, and the phospholipids are an important part of the basement membrane and to decrease production of prostaglandins, which are important in the inflammatory phase. Remember from this slide that omega-3 fatty acids are the good ones, omega-6 fatty acids are not as good. Omega-6 fatty acids are pro-inflammatory, whereas omega-3s are not. Many of us and many of our patients take fish oil capsules because we feel that fish oil is good for our cardiovascular and cerebral health. And I think that there's a fair amount of literature to support that, but make sure that you're taking plenty of omega-3s. Not to say that you can't ever eat any nuts, but your whole source of fat should not be from nuts. We know that not all calories are created equal. We have protein calories versus non-protein calories, carbohydrates and lipids. We know that in wounds and burns, the wound exudate tends to be a very protein-rich fluid. And so we need higher stress levels of protein, especially for large surface area and highly exudating wounds. It only makes sense. But it's easy not to think about this when we're taking care of these large venous leg ulcers every day. But, you know, it's interesting, and as nurses, any of you in the audience, I'm sure you appreciate, sometimes you take a dressing off somebody's leg and you say, oh my gosh, the dressing feels like it weighs 2 pounds. Providers, you may not be as in tune with that because you're typically not the ones taking off the dressings, but ask those questions. If the gut works, use it. The gut and the gastrointestinal tract is the best triage agent, if you will, in terms of how to send and process nutritional elements. So you eat, food hits your mouth and you have salivary amylase, food hits your stomach and you have hydrochloric acid and a different form of amylase. And as food goes into the small intestine, the gallbladder says, oh, well, there's a little bit of fat in there, so let me squirt some bile into the small intestine through the common bile duct. And the pancreas says, oh, there's a little bit of this and that, so some pancreatic enzymes come in. The best mechanism is the gut. If the gut doesn't work, then you've got to use something else. And the quote unquote steak and potatoes in a bag, hyperalimentation and intralipids, typically via a central venous catheter. Remember that there are multiple oral supplement formulas around there. Some of them taste pretty good, some of them taste frankly gross. I would suggest that if you're in the habit of recommending a particular oral nutritional supplement to your patients, taste it. If you haven't tasted it, taste it, because if it's gross, nobody's going to drink it when they get it home. Anabolic steroids in wound care, remember one name, and that is oxandrolone. Oxandrolone has been studied and has been associated with less weight loss in burn and wound patients and faster donor site healing in burn patients. There probably are not going to be any further studies on oxandrolone because it's inexpensive and it's available generically. But if anabolic steroids are going to be used in wound healing, oxandrolone is probably the name to remember. And please do not memorize that molecular formula. We probably should take that off of there. Glutamine. One of the essential amino acids. It's a primary fuel source for lymphocytes, enterocytes, and dividing epithelial cells. Enterocytes, if you're not familiar with that term, enterocyte is another term for the columnar epithelium that lines our gastrointestinal tract. So glutamine is a critical substrate with alanine for the production of glucose by the liver. It's the most abundant amino acid in the body, makes up to 20% of the amino acid pool. It stimulates the inflammatory response in wound healing. We know that glutamine levels fall in muscle and plasma after trauma. So supplementation with glutamine in some clinical situations has been appropriate, but the bottom line is that no clear benefit has ever been shown on wound healing with glutamine supplementation. Arginine is another story, one of 2 semi-essential amino acids, and there have been 2 significant large-scale studies done to look at the effect of arginine supplementation and collagen deposition and accumulation in healthy subjects. So one study was done in young, healthy volunteers, and the other was done in an elderly population. And both concluded that arginine is an appropriate amino acid supplement for wound healing. There is some theoretical suggestion in the critical care setting that this may be controversial because it can increase nitric oxide production, which could contribute to hemodynamic instability because nitric oxide is a vasodilator. So as a vasodilator, it helps with wound healing, but it could contribute to hemodynamic instability. Hydroxymethylbutyrate, this is sometimes offered as a supplement. No real science to support it in wound healing. You'll see this in muscle building formulas because it does tend to help decrease muscle breakdown. So, closing out with vitamins and minerals. Who should we supplement? Obviously, patients that are malnourished, we should be looking at their vitamin status and probably measuring some of those levels. Patients who are unable to eat by mouth for a week and who have not been given other forms of nutrition, we should think about supplemental vitamins. And of course, anybody with a documented vitamin or trace mineral deficiency. How much should we supplement? As a bottom line, we should avoid supraphysiologic doses or mega doses of vitamins, especially watching out for the fat-soluble vitamins such as vitamin A and vitamin E. Excess consumption of these can lead to toxicity because it gets stuck in the fat. So vitamin A, originally discovered in the early 1900s, impact on wound healing discovered as early as the 40s, benefits of supplementation described in the 60s, and we know that retinoids as a group, retinoids which are vitamin A derivatives, have been used in acne and other wound-related problems for quite some time. We also know that, this could appear on an exam, that administration of vitamin A can mitigate the corticosteroid-retarded wound repair problems. So we know that our patients that are on chronic systemic corticosteroids have impaired wound healing because of those corticosteroids. Administration of vitamin A can reduce that adverse impact. Vitamin A deficiencies will almost always affect wound healing at all stages, and here are some of the sources of vitamin A. Oral doses, anywhere from 10,000 to 50,000 international units a day. The last time I looked through a vitamin shelf at a pharmacy, the most common dose appeared to be 40,000 international units per day. It can be administered topically as well. Do remember that vitamin A levels are easily measured as a laboratory test. So if you're measuring vitamin D, not a bad idea to throw in a vitamin A, and we'll also see that it is useful to measure zinc levels as a trace element. So vitamin A supplementation has an important role in stimulating macrophages, which, as we know, are important in the inflammatory phase of wound healing. And vitamin A supplementation has a beneficial effect on epidermal growth factor and collagen synthesis. Vitamin C, ascorbic acid associated with fruits. This is an essential element or cofactor in the hydroxylation of lysine and proline in collagen synthesis and in the ability of mature collagen to cross-link. We also know that vitamin C can improve infection, and it also facilitates leukocyte migration to wounds. Vitamin C deficiencies and supplementation, classic deficiency, of course, is scurvy. We don't see that, at least in most of our civilized populations, we don't see that anymore because it acidifies their urine. Vitamin E, one of the fat-soluble ones that we need to watch out for. It is an antioxidant and also has anti-inflammatory properties in typical doses, but excess intake can decrease our normal inflammatory response. In just about every multivitamin preparation, there will be vitamin E. Trace element deficiencies, there's lots of trace elements. The one that has the most literature behind it and the one that you probably should be most aware of is zinc. Zinc is an important cofactor in multiple enzymatic reactions and has been shown to have a direct influence on epithelialization, fibroblast proliferation, and a lot of immunologic responses. Zinc levels are easily measured in the laboratory, and deficiencies are easily replaced by oral zinc supplements. I would remember some of these etiologies of zinc deficiencies because they are common exam questions. Chronic alcoholism, surgical trauma, large body surface burns, psoriasis, GI fistulas. Just stick those in the back of your mind in case you are asked that on an exam. Iron deficiencies, the most common effect of iron deficiency is anemia and iron deficiency anemia. However, clinically in wound healing, rarely does iron deficiency have any significant effect on wound healing given that there is adequate perfusion. So even with very low hemoglobin levels, tissue oxygenation is well maintained. Okay, that is the end of that session, and so we will now look at some questions. There are a lot of questions here, and again, we are going to address the ones that would appear to have some utility for the entire group. So nutrition is such a struggle in our elderly population with limited income. Anemia, pernicious anemia, hypoalbuminemia are problematic. How do we assess nutritional status if not with prealbumin now? How do we help them when nutrition consult only covered for diabetic or renal patients? How do I assess nutritional status in a patient with ileostomy, high output, and tube feeds? Oh my gosh. Okay. Heather, sorry to say that this is going to be a very, very long answer. We can try to answer this for you individually later, but I would suggest as a sort of a global view on this, and nutrition is a struggle in all of our elderly population with limited income. So I would recommend that you assess their nutritional intake as best you can and measure some things that are measurable. Measure vitamin A, vitamin D, measure zinc levels, and in a fairly inexpensive fashion, you can replace many of those things. Are you recommending vitamin C and zinc supplementation for wound healing? What about end-stage renal disease dialysis patients for nutritional counseling? I usually ask renal doc about protein daily intake limits. Yes, so in your end-stage renal failure patients, we cannot just unilaterally suggest increased protein diets. This has to be done in close coordination with the nephrologist to be sure that we don't recommend dangerously high protein levels. Vitamin C supplementation, you know, it's an individual decision. I can't say that I recommend it, but you're certainly not going to hurt anybody with it either, and you might help them. Zinc supplementation, I would suggest, should be based on measured zinc levels and not simply given without measuring those levels. We only weigh at first visit. Do you weigh at each visit to trend weight loss? Typically, we do not weigh at each visit. We certainly weigh on the first visit, but we don't. We do weigh based on a sense that somebody is losing weight, and that's not a perfect answer. And maybe we should be weighing them on each visit. Next question: Our plastic surgeons are still using pre-albumin for nutritional status. How can we discuss this is no longer used for assessment? What other things can we recommend? Well, this is a challenge, and we run into the same challenge here. In terms of the lost validity of pre-albumin, I think all you can do is show them the literature. And so I would suggest you go into the ASPEN and the AND literature and get some of that out. I would also recommend that you go to the 2019 National Pressure Injury Advisory Panel guidelines, and there will be some things in there from Mary Litchford and Nancy Munoz about that. Fred asks, who says no to pre-albumin in chronic outpatient setting? Well, Fred, that's been my question as well, and I admit to still having a tendency to use it in the non-acutely ill outpatient setting, but it is the American Academy of Nutrition and Dietetics and the Academy of Nutrition and Dietetics, ASPEN and AND. We limit fluid intake in our CHF lymphedema, phlebo lymphedema patients to 60 ounces of fluid per day or less if cardiologist recommends less. They argue with me about the point that they need fluid intake. Thoughts? Also, are chronic kidney disease patients on diuretics, same issue? Yes, of course. Your fluid intake recommendations always have to be made with the entire organism in mind. So somebody with brittle or unstable congestive heart failure, we certainly can't recommend unlimited fluid intake. And these are also in the category of areas that I will make a phone call to the cardiologist or the nephrologist to ask those questions. Have you heard of or recommended Juven supplement for your patients? What are your takeaways? Juven, you know, we're certainly in this course, we're not here to make recommendations about specific brands, but I can tell you that Juven is fairly popular, fairly commonly used, and I, in my anecdotal experience, has been a pretty good thing. For patients on chronic daily steroids, what dose of vitamin A supplementation do you use to assist in wound healing and for how long? Again, vitamin A dosing, you can start anywhere in that 10,000 to 50,000 international units per day, but get a baseline vitamin A level and then measure your response in another few weeks so that you don't lead to vitamin A toxicity. Kay asks, how do you determine malnutrition with dialysis patients? Well, I can tell you, and I don't mean to be a smarty pants with this answer, but I do not. These folks, I will coordinate with their primary care or nephrologist to get that answer for me. Have you ever been told by registered dietitians that multivitamins have no to little benefits in frail patients with poor oral intake? Their rationale is poor absorption without food. I have not been told that by a registered dietitian, but that does not come as a big surprise. So that's something interesting. I think I'll look that up. Can PTs recommend vitamin supplements to patients? Well, you know, I think that recommendations, you're not writing a prescription, and you're talking about things that the general population recommends. So, I guess you probably need to look at your state practice act, or who runs that business in your area, to make sure that over-the-counter product recommendations are within your scope of practice. I can't really answer that specifically. Anyway, that's the end of these questions, and I will turn it over to Dot. Are we going to take a short break now?
Yes. So yes, we're going to take a 10-minute break now. The bioburden section, which is a couple of slides in, the bioburden section is pretty long, so we're going to take a 10-minute break. Be sure to go into the virtual exhibit hall, see the 4 exhibitors, fill out the thing. We are giving away gift cards as well as a free attendance to SAWC for our virtual meeting. So that'll be worth it all. So anyway, take 10 minutes. We will see you back at 10 after 11 Eastern time. Thank you. All right, so welcome back. I will look to make sure everybody can hear me on my phone here. Welcome back from your break. I hope you all went into our virtual exhibit hall. And so we're going to start a rather long session that will take us right up to lunch on assessing and managing bioburden. It's a big deal, and there's a lot of new research, not necessarily in here, but just there's a lot that is going on in looking at bioburden. So first of all, let's define it. The bioburden has a loose definitions in many ways, but it's really the degree of contamination or microbial load on an object. And so in our area of wound healing, sometimes it's just a statement just stating that we think there's bacteria on the wound, and as well as a qualitative sort of, not quantitative, but qualitative descriptor of bacterial status of the wound. And so we use it many times to sort of justify the use of various treatment alternatives, and specifically dressings that we know will impact the amount of bacteria on the surface. So we're going to look at how we describe them. Bacteria are generally described as by their shape. When you get a lab result, you see it gram-negative rods or gram-positive cocci. So the cocci are round or ball-shaped. Rods are, as you would imagine, are sort of rod-shaped. The spirillum look kind of like noodles, some kind of noodles. But anyway, so the spirilla or spirochete is more of a spiral shape. And then there's some other variations on that, but those are the three basic shapes. And importantly, they're also described in terms of their ability to take a stain called a Gram stain. The Gram stain was named that because of Dr. Gram. But it's a series of staining. It's what we get when we order a Gram stain. It's good early information. I'll talk about that more. But it's whether that it uptakes a purple stain, which would make it Gram positive, or when they rinse it off, if it uptakes a red stain or a pink stain, then it's Gram negative. So we'll talk more, though. That has a huge implication in how we treat. So when we look at the Gram positive and Gram negative bacteria, we get sort of used to the ones that we see most commonly in clinical practice. And you can see some of the ones here. We commonly see Staph aureus, Staph epi, the streps as Gram positive. We commonly see E. coli, Klebsiella, many of the ones, particularly Pseudomonas, Acinetobacter, and proteases, some which may be contaminants, but we see those commonly as pathogens that we see in our open wounds. Then they're described as to whether they need to use oxygen or not. And this is really important when we're talking about deep spaces, when we're talking about choice of dressings, for example. And so they're either described as aerobic, meaning they need oxygen to survive, or anaerobic, in that they can survive in the absence of oxygen. And so the anaerobes is a fairly, in wound care especially, are a fairly short list. You can see them here. And then, if you know those, then the aerobes are pretty much everything else. But the gas-forming bacteria that we see some of the real devastating wounds are really more of the anaerobes. Then, just to throw a curveball in, there are those anaerobes or aerobes that can become anaerobes. So in the presence of oxygen, facultative anaerobes can use aerobic respiration, and without oxygen, some of them will ferment. The most common ones are like the fungi and the yeast because they are able to ferment. So they use anaerobic respiration in order to survive. And so really, and I'll say this from the outset, our relationship and our ability to have an infectious disease practitioner to bounce things off with and discuss cases, and specifically looking at bacterial coverage is so critical. So I do hope you have one that is readily available and easily accessible. So I'm going to now go into talking about how we assess for bacterial burden, because that's where we are in terms of understanding our assessment of the wound. But when we look at the microbial states in a wound, we know that all open wounds are contaminated. You're not going to have a wound open for very long before you have some bacteria that's just sitting on the surface, minding its own business, if you will, not causing any kind of issues with the healing of the wound. Once those bacteria begin to replicate, then we consider that to be colonized, and usually still there's no immune response. It's simply a state of multiplying bacteria, but nothing that's affecting the wound healing. So historically, since about 95, we talked a lot about critical colonization. I'm going to deviate from that in just a few moments. But this is when we had enough, a critical level of bacteria that now we were beginning to see a change in the healing status. And I'll define it more in what we see in just a moment. Because clearly in these first three levels, what we're trying to interrupt is the burial or the invasion of that bacteria down into deeper tissues, causing the disease of infection. So critical colonization, I think you're going to see that term used less and less, and more are using the term covert infection, meaning it's locally infected. It's not spreading infection. But it is the process where the bacteria is there now. A wound that might have been healing along at a nice trajectory suddenly stops, but they may not have standard signs of infection. What's happening is we have now enough bacteria sitting on the surface of the wound where they're competing with the tissue cells for nutrients, for oxygen. They're replicating, they're leaving toxins behind, which causes an inflammatory response. And so we do begin to see the wound stop healing or even go backwards. So critical colonization, kind of a vague term where you're probably not going to see as much. Covert infection or local infection is how it's more commonly being described. What do you look for? Regardless of what you call it, what do you look for? You may have been granulating along just fine and suddenly it stops. Maybe the color of the granulation, if you look at the one on the right-hand side of the screen, you'll see that it's a sort of a darker granulation superimposed on top of a lighter, or it just suddenly stops granulating, or you begin to see pockets, or you begin to see exudates that are trapped within the granulation tissue. You may have an odor. It might be subtle. It might be a dramatic change. Most of the time, you're going to see an increase in exudate because the toxins that are being produced, the body's trying to flush it out. So we see more peri-wound edema and more exudate from the wound. And so if you're new into wound care, this might not be a term that you're familiar with, but those of us that have been practicing for a while, and if you've been to some of the meetings, the term bacterial biofilm has really become to the forefront in terms of how we approach wounds and what we need to do to reduce that. So bacteria that is sitting happily on the surface of the wound, the bacteria that we culture off of a wound, say using a swab or even a biopsy, depending on your lab, are called planktonic. These are bacteria that are free floating. They're not attached. So they're fair game for antimicrobials, biocides that we might put on the surface, for systemic antibiotics, and the testing that's done in our laboratories on our cultures is done on this planktonic bacteria. So biofilms are complex communities of bacteria and other organisms, which I'll define, which now become sessile. They become attached to the surface of the wound. They embed themselves in this exuded extrapolymeric substance that they produce, and then they can still be replicating within that polymeric substance, so they have a protective film over them, hence the name biofilm. So what you can ultimately get to is a biofilm that has multiple species. You have lots of different kinds of bacteria, gram-positive, gram-negative, anaerobes, aerobes. You can have fungi. The EPS is very protective. It doesn't let large molecules through. So bacteria are in there, and they're basically protected. And so when we have a full-blown mature biofilm, now you've got one where like 75% of it is this protective slime, if you will, the extrapolymeric substance. The bacteria that are in there are now around 25%, but they're very well protected now. So it's estimated that between 60 and 90% of our chronic wounds have some level of biofilm versus only about 6% of acute wounds. And the challenge with them is we can do a debridement and we can get rid of a lot of it, but they can penetrate down a couple of millimeters into the tissue. So just a superficial debridement may not rid us of them. It may knock the tops off, if you will, and it will expose some of the bacteria, but they can start to reform within 24 hours, and in 72 hours, you can have a full-blown biofilm again. So it's something we need to, I won't say fear, but I think we need to respect that this is pretty well understood that this is in a lot of our chronic wounds. But they're difficult to kill. One, because of that slime, that extrapolymeric material, does not let large molecules through, so it impairs antibodies getting in, it impairs biocides and antimicrobials getting in, as I mentioned. And there are some bacteria in there, and they're called persister, which simply means that they persist. But their metabolic needs are less. So what's happening inside this biofilm, it's kind of a cool kind of a thought process. They're in there, and they're sort of going into hibernation. They slow their metabolic rate down. And so we know that antibiotics go after rapidly dividing bacterial cells. And so when they slow their metabolism down, they don't uptake that antibiotic into the cell. And so the oxygen diffusion is limited inside the biofilm, so the anaerobes are just going to get stronger. And so they have this great ability to communicate. It's called quorum sensing. So they're smarter than we are. And so it's usually going to be a physical removal coupled with a topical management to prevent the bacteria from replicating rapidly and forming more biofilm. So our challenge is, how do we know it's there? Because right now it's still a clinical observation. People will look at it as something maybe that's not healing or stopped healing. And this goes back to the yellow wounds and inflammation. When we start to see slough forming in well-vascularized wounds, there's no reason for new dead tissue, and that's where you might see some of that slime that I showed earlier in assessment forming. It's not 100% biofilm. There's probably biofilm embedded in it, but it's the byproduct of having the biofilm there and our body's reaction to it. So again, stay tuned. This is a study that's going to take us into next year, the slough study, but where they're doing pictures, they're doing biopsies, and then help us identify the yellow stuff that we're seeing in wounds. Some people will see sort of a glazed slime look to the wound. That could be there's a variety of ways that it might present to our eyes. And so our normal culturing doesn't take care of it. PCR, the polymerase chain reactor, which I'll talk about in a second. If you happen to have one in the clinic, it can help you. Scanning electron microscopes you can see them, but of course, who really has that at the bedside? So when we look at our culture report, the minimum inhibitory concentration of our antibiotics really aren't going to be helpful in this. So and mostly we just go on a presumption of non-healing, and then we step back to what we kind of figured out anyway, that wounds can definitely benefit from a maintenance debridement, and then I'll be talking about wound cleansing a little bit later. So when we look across that continuum that I mentioned at first with the contamination, colonization, and then that critical colonization, it's pretty much assumed that this is where we probably have biofilm forming. And so what our goal is good topical wound management to debride and to get down below that, and then hit it with some antimicrobial. Consider the use of antimicrobial cleansers, which I'll talk about in order to, as we clean wounds, especially until we get to a nice healing trajectory, and then we can perhaps use other things. So, of course, our ultimate goal is to prevent spreading infection. So biofilm-based wound care is simply good, aggressive topical care. Debridement is the primary approach. Biofilm respond well to cold, hard steel. And so our topical management, there are some newer agents that are biofilm busting agents, and you can just Google that or go to a website I'm going to give you later, the Wound Source, and you'll see some of the companies that do make products that they have the ability to market them for biofilm busting. Cadexmer iodine. Iodine in general will help against the biofilm, but since we don't tend to use straight povidone iodine, there are some products that deliver time-release iodine that are safer to the healthy cells. There are some pH&B solutions and some other things that have some data behind them for biofilm busting. So we just want to look and see what the manufacturer, what data they have to support any kind of claim with that. But any kind of mechanical disruption is usually going to help. So when we get to true infection, this is just a medical dictionary definition of infection: invasion and multiplication of these pathogenic organisms. But it's in a body part, it's in a tissue, it is an actual disease. So when you have the invasion of these bacteria down into deeper spaces, then you have the disease of infection. And the things that predispose the patient or the skin to it are first a damage to the stratum corneum. Well, of course, we all are taking care of open wounds, so the stratum corneum is damaged and open. A high enough concentration of particularly pathogenic organisms, a disruption to the blood supply, which we know that wounds are inherently hypoxic, and then a favorable environment, which is the environment we create because we want to keep things moist and undisturbed. But when we have dead tissue there, just think of dead tissue as a grocery store for bacteria. They love it. Again, why we need to try to get wounds clean as quickly as we possibly can. So this formula that you see here is not particularly one that you can add numbers to or plug numbers into, but it's just a concept of the presence of bacteria are really what the host does with that bacteria is really what influences the healing. So it is a disease, and it's the number that we see, but also the virulence factor of that particular bacteria. And again, that's where our infectious disease practitioners are so necessary in terms of treatment, especially recalcitrant or reoccurring infections with the same organism, because they will certainly know probably the virulence factor and write down sometimes even to the specific species of a particular bacteria that is particularly problematic in your hospital or in your region. And then the patient, how healthy are they? What is their immune function? Some of these things that if I had an open wound, I feel like I'm pretty healthy. If I had an open wound, may not cause me a lick of problem. A lick of trouble may be deadly for someone whose immune response is not good. So all those things come into play. So as we look at assessing infection, it's a clinical skill. It's not a number. And so the decision to prescribe antibiotics or topical antimicrobials need to be based on our clinical presentation. The wound culture is really a follow-up to our assessment to let us know that the antibiotic that we might have started them on empirically is the correct one. So we never can step away from the clinical picture of infection that we were all taught about in our basic training: swelling, induration, erythema, warmth, pain, and odor. So the patient that, and listening to the patient that you see right here, the one on the left, she calls in one day and says, could you call me in something for pain? My foot is killing me. Well, we knew this lady. She had her great toe removed. We could debride her with no anesthetic, and now she's hurting. We had her come in. And what you're seeing on the right is what her wound looked like just 5 days prior when she was in the clinic. You see no necrotic tissue where you see it in the proximal part of that wound, or excuse me, the more distal part of that wound in her foot. And then you can also see how red her foot is. So listening to the patient is so critically important. So when we want to look at the offending organisms, that's when we use a culture. So I'm going to talk about the various types of culture as well as how we get them. But the gram stain, if you don't know if the lab that a culture might be going to does a gram stain automatically, you need to find that out, because gram stains can give us a tremendous amount of early information. And it's not always 100%, but many times can give us some early information. So if you look at this gram stain, what it's showing us is that this can be within hours of the culture arriving at the lab, that it grew out a few gram-negative rods. There were some rare white blood cells, but that shows that the body's responding to it. And then it will also talk about some of the other debris that might be picked up with the culture. And so the types of cultures that we have, I hope you don't just see qualitative cultures, meaning you're just finding out that the bacteria are there and the antibiotics that it's tested against it. It doesn't give us any sense of numbers other than the minimal inhibitory concentration. So in this case, this is a qualitative culture. You can see it grew out E. coli, Pseudomonas, and then some skin flora. And then the inhibitory concentration, you can see the list that's on this example. They were lucky everything was sensitive. So it just gives sensitivity or resistance, but doesn't give us any idea of the concentration or the numbers of bacteria. So I believe that what most labs do now are semi-quantitative cultures, and semi-quantitative gives us a number. Basically what they do is they divide the Petri dish into quadrants, They streak in the culture, the broth that's made from the culture, and then they flame the loop. They drag it into the second, drag it into the third, drag it into the fourth. So what you're looking at is the number of quadrants into which the bacteria grows. You see a 1 plus 2 plus 3 plus 4 plus. And if it goes to 4 plus, you can be sure it's a pretty virulent type of bacteria. And so this is what one looks like in real life. I just found that on the internet. And so a good correlation has been found between semi-quantitative culturing and quantitative, which I'll talk about in a moment. But when you have 1 plus or 2 plus or, up into 4 plus, it tends to, one paper talked about, and the citation is down at the bottom, and it's an older paper, but it did talk about the fact that 4 plus correlated a tissue count of approximately 10 to the 7, which is a lot of bacteria. So our semi-quantitative culture, this is what one will look like. And as you can see, there is Staph aureus growing, a little Enterobacter that was just in the broth, but it gave 2 plus as the growth on the semi-quantitative culture. Then quantitative cultures are well, it's the gold standard, just so you know, on a test, it's the gold standard. One of the things that you have to know about this test is you need to know the gold standard, not necessarily what your clinical practice is. In live groups, I ask how many of you all do 100% quantitative cultures with tissue biopsy, and rare does anybody raise their hand. If they do, it's usually a surgeon, and it's somebody that can take out tissue in surgery. And then there's a few others that, may do punch biopsies on all their patients for quantitative culturing. But most of the time we do good swab cultures, and we'll talk about how to do that. But when you do a quantitative culture, and again, you're usually going to do a biopsy, you're going to get an exact amount of bacteria. And so we've only done them when we were doing clinical trials, not in our everyday practice. But this was a person who was in a clinical trial, and I mean, her wound clearly needed to be debrided of that debris on the surface. But what that grew out from a biopsy, and it was a 6 millimeter punch, it was huge, is 10,000 colony-forming units of Acinetobacter and 2 million. Now that's 10 times 2 times 10 to the 6. You count the zero. Staph epi, which was maybe a contaminant, but nonetheless, that's the kind of information that you get on a quantitative culture. Here's another one. This leg is much more red than it really looked in real life. That's the area where the biopsy was taken, and then what he grew out, I can't even say this bacteria, but that's immaterial, 500,000 colony-forming units per gram. That's 5 times 10 to the 5th. So that would be correlated with clinical infection. So, and so most of the time we're not going to do this. So we want to do, obtain the, garbage in, garbage out. So we want to do the very best culture that we can to send to our lab. And so there are a couple of methods that I'll talk about, and 2 you will know about, 1 you probably don't do. One is aspiration. It's actually written up in the literature. You can read about how to do it. It's more than what I've got listed here, but you basically prep the skin with some alcohol, not with betadine or anything, because you don't want to take the needle through an antimicrobial. You put the needle in, because what we want is the cleanest fluid possible. So you're sliding a needle in underneath the level of all that fluff that's there, and then you aspirate it out. And again, there's a little bit more to the technique, so just Google aspiration for culture. But then you apply that to a swab and send it off, and you're going to have a very clean culture then. Quantitative tissue biopsy is the answer, okay? If you are asked about, if you are given choices for how to obtain cultures for microbes, then quantitative tissue biopsy is the best practice, but it's not practical in most places. It's painful. They would almost need an anesthetic, but sometimes the anesthetics can inhibit bacterial growth, so you don't want a lot of anesthetic in the area. It's obviously skill intensive. You're not going to have a nurse at home or a treatment nurse in a long-term care facility, or even myself in my wound clinic. I can't do a quantitative tissue biopsy because I'm not a provider. So it has to be done by a provider. So I would say it's used in research more than it's used in real life wound care. But the number that you're going to look for is greater than 10 to the fifth. That's still what's in the literature, but again, our ID people may treat for something much lower than that because they know the virulence factor. But from a holistic standpoint, these are the answers that you would want. This is the general acceptance in wound care. Greater than 10 to the fifth counts as zero, or greater than 100,000 colony-forming units per gram of tissue, and that mostly comes from the burn literature. So what we want to do is we're going to do swabs, and we want to do them well. One thing we don't do is we don't swab through the other side of this. We don't swab right through the wound that this came off of. We're leaving dressings in place for a long time. We're liquefying necrotic tissue. We want to make sure we take the dressing away, cleanse the wound well with a cleanser. If you use, and you know, I'm a big proponent of aggressive cleaning. And so if you're going to use, and I often do, an antimicrobial cleaner, a preserved saline or preserved cleanser, a spray cleanser, something like hypochlorous acid. If you're going to do a swab, you want to rinse that away with saline. Don't make sure you don't pick some of that fluid up with your swab because you're going to reduce your bacteria count. Pick an area that's clean and get it to the lab as quickly as possible. So the Z-stroke, so how we obtain these cultures, with the way I was raised as a baby nurse, is we took our swabs and went back and forth and back and forth. It's called a Z-stroke. And I mean, this was back in the 70s. Just think about all the bacteria we were picking up. We were picking up contaminants from the skin, contamination from necrotic tissue, all kinds of stuff. And so, of course, if that was all treated back then, it probably contributed a lot to our resistance to bacteria that we have now. But nonetheless, that is taught, I hope not taught in any kind of schools, any basic programs anymore, but that's not a good way. But that's what it's called, is Z-stroke. I think most of us do the Levine technique or have heard of the Levine technique, but it's a very appropriate and validated way to obtain a culture. So there's been a couple of papers that were written looking at how we do cultures. This one was from, it's an evidence-based report card from the Wound Ostomy Incontinence Nurses Journal, and it was just to look at best evidence about when and how to perform cultures in order to really determine good treatment. And so there were 7 studies that they found, and the results were that, again, quantitative culturing is the gold standard, and this was from 2018. So still quantitative culturing with tissue biopsy, still the gold standard, but the swab is an acceptable alternative, and the Levine technique was found to be more reliable than the Z technique in the papers that they looked at. Then there was another one that was published in Wound Repair and Regeneration out of the Wound Healing Society. This was a big study. They looked at 180 different wounds that were both swabbed as well as biopsied from the very same site. So this is a very nicely done study. And so they found that more skin flora was picked up with the swab, but they found that the swab could actually identify the same bacteria that was cultured in 131 of the wounds, or 72% of the time. And so while not perfect, certainly better than doing a poorly done culture. And so the most common organisms found, as you see here, were Staph aureus, Pseudomonas, and beta hemolytic strep, of which they will usually just treat if they have one organism. So the way the Levine technique is done is that the swab, I know this is a Q-tip, but I kind of made this picture up, but you're going to take your swab, you're going to find about a centimeter squared area of clean, healthiest tissue you can find, press that swab in, and then roll it around. And so here's just one you can see rolling around the culturette tube, and then put it into the container. So then, looking at a wound like this, if you did a Z-stroke over that, you're going to pick up all kinds of garbage. So you want to pick the cleanest area that you can find and limit your rotations to that so that you don't pick up the stuff that's growing in this necrotic debris, because it's going to be a lot more. So I mentioned PCR, or polymerase chain reaction. It's a machine. It's about the size of a coffee machine. But anyway, it's a molecular technique, and I couldn't, on a good day, tell you exactly how it works. But it is an interesting way of targeting and identifying bacterial DNA to allow them to be detected. And so it's some kind of heating and cooling. You only have to send a swab specimen. You don't need tissue. It's sensitive and specific, and it can be done in a few hours, but most of us don't have access to it. There are some labs, reference labs, that you can mail off swabs overnight, and you'll actually have the results by midday, the next day. But it really depends on your state lab laws, if you will. And for example, in the state of New York, we can't send something out to a lab that doesn't have an address, basically, in the state of New York. So what you get too, and this is just an example of when I got off the internet, is you get a sort of a laundry list of pretty much every bacteria that's been in the neighborhood, but the labs will focus you on what they think are the biggest offenders. So it's probably something that we'll all be doing eventually, but at this point in time, for most of us, it's send off, unless you work in an academic setting. So that's how we look for the bacteria. Now let's talk about how we manage them. And I'm going to spend time talking about the topical stuff, and then Lee will take over and talk up until lunch about the different wounds and things that are caused by bacteria. So again, if we look across here and look at the spectrum of wound bioburden, the one thing that stands true is that we have to practice antimicrobial stewardship. We have access to so many antimicrobial dressings, lots of silvers, lots of different things that we can use easily on top of our wounds. But we want to treat them with respect and only use them when we need them and stop using them when we think we don't need them anymore. You can read so many different papers about resistance and things to various dressings that are shown in the laboratory, and you could probably grow just about any bacteria and show that it's resistant to a variety of dressings. So we have what we have, and right now we don't have the ability necessarily to look at the specific resistance to a specific dressing, but just know that this is the sweet spot. This is the time when we think we're getting critically colonized, when we start to see exudates that are coagulating on the surface of the wound. Then we need to think maybe there's bacteria there and go ahead and treat it with an antimicrobial dressing. And then when we think it's getting better, maybe you can to more towards the picture on the left, then we stop them. So when we look at topical management, first we can talk about antibiotics. Of course, the last thing we want to use. We know that we have morbidity associated with systemic antibiotics, especially with C. diff and colitis and overgrowth of yeast and things that people get. Always making sure if we're talking to people about their antibiotic that they may want to take a probiotic with it if they're taking them orally. But this is one of the reasons that we don't do routine cultures. We don't do what people call pan culturing. We don't culture every wound that comes into our clinic because they're not all infected. And many times in a chronic wound, we're going to culture something. And if you culture it, then you're almost obligated to treat it. And so we only want to culture to confirm the antibiotic that we might have put someone on empirically because we used our clinical assessment to see if they were infected. Now, the caveat to that is, let's say you think you're doing all the right stuff. You've used some topicals. Sometimes wounds will surprise us. So it's not a hard and fast rule. Don't culture every time or a lot of wounds, but you just have to use your clinical judgment. But we do want to avoid culturing every single wound at the first visit, for example. So topical antibiotics is also the routine use is discouraged because there is a potential for resistance. Just think about how much mupirocin is used in the United States just because that's what people know kills staph. And so there has been some resistance to mupirocin shown according to an infectious disease doctor that attended one of our courses. Additionally, people can have sensitivity reactions on their skin. The two pictures on the right are examples of that. The one with a triple antibiotic, some people will react to the gentamicin or the neomycin that's in there. The one at the bottom, I'm outlining what his actual wound was. And he was admitted to the hospital. Of course, they saw that from our wound center, he had a MRSA that had cultured out. And so they ordered mupirocin, which in the hospital was probably appropriate, but they were sort of icing it onto a 2x2 and laying it down, and he had this massive reaction to it. So obviously we stopped in, and as soon as we did and used another antimicrobial, he cleared up. So we want to be careful about the topical usage as well. Now, antiseptics, we think of this with our cleansers. These are agents that can destroy or make the bacteria not grow as easily in living tissue. And actually, antiseptics are more safer and preferred to antibiotics because of the potential for resistance. So we've kind of come full circle, and a pendulum has swung a different way in terms of how we used to look at antiseptics. And I'm going to talk about wound cleansing this afternoon, but we may have all heard that saying, don't put into your wound what you wouldn't put into your own eye. And I can tell you there's a lot of things in wound care I wouldn't put in my eye. So we had this abandon. We can't use iodine, we can't use Dakins or acetic acid or any of these things. They're toxic at the cellular level. And indeed they might be. We always have to look and think about the risk versus the benefit. We know that bacteria are always going to win the battle. And so if we have bacteria in the wound, if we've got a wound that's filled with necrotic tissue and draining all kinds of stuff, who cares if it's toxic? Because it needs to be cleaned up. Once we get to a healthy granulating wound bed, or where the healthy tissue is the predominant tissue, then we would go to something that was safer or more tissue friendly. So we want to know what our goal is. Is our goal to clean, or is our goal to disinfect? If it's to disinfect, then we can use whatever we need to accomplish that goal. When we have a clean wound, then we want to use something that is safe. And if we feel compelled to use an antimicrobial cleanser, say in an outpatient wound clinic, then we want to use something safe that might be like hypochlorous acid or something. So, and anyway, so it's a decision that we have to make based on our patient assessment. But then we can just stop using it when the wound is clean. So let's finish by taking a look at the antimicrobial dressings that are out there. And I don't want to disappoint, because there are, oh my gosh, so many dressings out there. So I'm going to hit the sort of the high spot on the 5 or 6 antimicrobial dressings that are in our wound space. And our purchasing people would love to say, isn't there one that's better than the other? Why do you need all these things? Well, we'll get to that. But one of the things about the dressings that we use is that they need to do what they say they will do. So we need to know what the manufacturer's claims on the dressing are. So we want to know what level. Does it actually kill bacteria? Does it just keep them from replicating? Is it bacteriostatic or bactericidal? And how long is that kill maintained? So how often do I need to change that dressing? And we want to know that they've tested the whatever against the known pathogens that we see in wound care. So we want to know, is it a barrier, or does it deposit the antimicrobial agent onto the wound bed? I can tell you that the answer to that in all dressings is that they are a barrier. FDA doesn't want to know that we're depositing any agents onto the wound bed, because then it would become a drug. So most of them are going to make the claim of being a barrier. How does it need to be used? Does it need to be activated with fluid? Does it need to be hydrated? Does it need to make intimate contact with the wound surface? Again, how long does it last? And can you get it, and can the patient get it? It's one thing to say, I'm going to prescribe this for you, but a lot of these some of them are impregnated into dressings, and so you might be able to get them from their biller or through their insurance, but we want to make sure that they can get it. And then how long should we use it? Well, it's really until we see the wound begin to progress, and then we can go to something else. So I'm going to go through these 6 types of dressings and that delivery systems that are in our market. There's a lot of different manufacturers, and I try not to be too product specific, so I hope I'll be able to live up to that. But unquestionably, the largest category are our silver dressings. And so I can't even go into all the ramifications of the types of silvers and things like that. But again, learn about the particular dressings that you have from the manufacturer. We all have formularies. We may not be able to get everybody's silver dressing, unless you make a really good case to your value analysis people. But anyway, so silver I'm just going to talk about as a broad category. But silver is very broad spectrum. You know, it's been around forever. They actually put silver coins into big barrels of water, and they were bringing them across the ocean because they knew it would keep bacteria from growing. And so there's broad spectrum. They are good against gram-positives, gram-negatives, anaerobes, aerobes, fungi, yeast. And so they can even be effective against some of the antibiotic-resistant bacteria. So you'll just want to know the specifics about the one dressing that you're looking at. So what you see here, and it might look a little weird, is a potpourri of various types of delivery systems for silver. They come in foams, they come in gels, they come in fiber dressings, jelly fibers, calcium alginate, island dressing. So there are a lot of options for silver out there. And I think we need to have these, and this is where it's sometimes hard to convince our purchasing people, but we need to have something that we can use in all kinds of wounds, whether they're draining, whether they're dry, in order to maintain microbial control. So it begs the question, there is a lot of discussion about silver resistance, and there have been many studies that have shown actually bacteria growing on silver. They have, you know, but the overarching feeling is that it's not likely to be real common. That because the way silver works is there's 4 mechanisms of action, and you can read them here, but it inhibits the bacterial respiratory chain, and ruptures the cell membrane. Some of the others do too, you know, and you can read this. This isn't going to drill down as much on a test, but because antibiotics work with one pathway. Their method of action is one pathway. And so while it takes millions and millions of mutations, bacteria can learn to become resistant. With our silver, because there's 4 mechanisms of action, the thinking is that it would take a lot of mutations for the bacteria to learn this. So while again it has been shown in the laboratory, I'm not able to tell you that it's not true or that it is true. It's just that it's less than likely. So, you know, again, if we use stewardship and use it when we need it and stop using it when we don't, then we're going to be in better shape. The pigmented foam dressings are one that many of us use. They have 2 pigments containing usually methylene blue and gentian violet. There's one on the market that contains silver, and they're effective against the most common wound pathogens. And so they're changed generally 1 to 3 days or weekly, depending on the manufacturer. One of the things that I really like about them is that some of them come in a polyvinyl alcohol foam, and I'm a real fan of this because PVA or polyvinyl alcohol has a really strong absorption capability, so it helps to pull debris off of the wound surface. So in clinical use, we find that's one of the dense foams, and there's some dense silver foams that work well that can actually compress the hypergranulation tissue back, and it works exquisitely well, especially under compression. This is the back of what one of them looks like. You can see it actually helps to flatten out edges, but this is that PVA effect. It helps to pull exudates up and off of the wound. So there's actually a PVA foam that also has iodine in it, and both of these, the pigments will blanch when they come in contact with wound exudates, and so that's an indication that it's time to change. So another type of antimicrobial dressing is the PHB or polyhexamethylene biguanide. Chlorhexidine is the most commonly known biguanide. It's like Hibiclin, but straight Hibiclins on an open wound is absolutely cytotoxic. So the polyhexamethylene biguanide is much more biocompatible. It's bound into a variety of different kinds of dressings, works very well as a barrier, and then is commonly effective against most pathogens. So it comes impregnated in foams and solutions for cleansing and gels and cellulose dressings. The very first one on the market was actually a gauze. And they use that as a nice study I'll show you next, looking at the barrier effect of it. So if we worry about someone's cleanliness, their hygiene, their living conditions, using it as a secondary dressing is probably a good idea. But when they looked at just the gauze, they found that it's a good barrier because they put some gauze onto wounds and challenged it from the top down with 10 to the 6 bacteria. And then underneath the PHMB, they found none. And underneath the plain gauze, they found about 10 to the 3rd. So it does work well as a good barrier. And then there's been some studies looking at PHMB cleansers as compared to saline on MRSA biofilm. So look to your individual manufacturers for the studies that they have done. Iodine actually is a very good antimicrobial agent. Unfortunately, it's just not real good for healthy tissues. So we have it in other delivery systems. One is just in the iodophore gauze or the packing ribbon that you can put into wounds. It's not going to be toxic. And then 2 different delivery systems, one a cadexamer iodine, another a polyvinyl alcohol foam, which delivers it in a time release manner, so it doesn't hurt cells. So the cadexamer iodine is available in a paste and a sheet. What it is these little spheres that contain the iodine. And they're starch-based. And so when the exudate goes up into the dressing, the sphere opens up and it releases the iodine in a slow release method. And so it doesn't kill, it's not harmful for our cells of our wound. And then it does a good job of killing the bacteria in the product as the exudate comes up. Then it is one that many years ago in 2010, I think it was, Dr. Greg Schultz, at that point in time, and remember, there's a whole lot more that are out now, but in 2010, it was compared to most of the other dressings on the market at that time, of course, 10 years ago, they found that it was one that completely took down Staph aureus biofilm. And then there's the foam, polymer foam, which is a polyvinyl alcohol foam, and it works the same way as the pigment. When the exudate comes up into the dressing, it delivers the iodine into the exudate and then reduces it that way, as well as has the ability to lift nicely off of the wound surface. And so lower toxicity, long duration of delivery. And so they do have some in vitro evidence that it does affect biofilm. Honey, many people use honey. Again, it's one of those historic entities that have been used and mentioned in many biblical and historic documents. And so it's like 20 years ago had a resurrection in terms of use in chronic wound care. Its mechanism of action is that it's antibacterial and that it will not allow bacteria to grow. That's why you don't have to keep your honey at home in the refrigerator. But it's anti-inflammatory because it causes a shift of fluid from the wound bed up into the dressing because of an osmotic shift, because of the high sugar content. And so you'll see a reduction in edema and pain. And then it creates a very nice wound environment if you have a drier wound or you need something that will create a moist wound healing environment. And because of that osmotic shift, it does a nice job with autolytic debridement. And then lastly, we have, this is not antimicrobial per se, but it's in this space. It's a pathogen binding mesh. It's not technically antimicrobial. As I said, it comes in a lot of different varieties. But because bacteria are inherently hydrophobic, they push water out from their core, then that is what helps them communicate to each other. It's what helps bacteria stick on stuff. And so this hydrophobic dressing, which is a fatty acid derivative, it doesn't kill the bacteria, but the bacteria attach to it, and then they are bound in the dressing, and then you take the bacteria out in their living form. And so it's usually applied daily at first, and then you can reduce the frequency of dressings. But this is just an electron microscope picture of the bacteria adherent to the fibers of the dressing. And here's the legend over here. So Pseudomonas is purple, Klebsiella is green, you can see the rest. But in any event, it takes bacteria out in toto. So they're stuck to the fibers, they're stuck to each other, and then you take the bacteria out as a living being. So there is no one perfect dressing. To finish out my part, again, we want to practice antimicrobial stewardship. We need to know if it's available. It needs to be compatible with our support needs. If we're using a contact cast, if we're using compression wraps, then we need to be able to leave it in place for the length of time. We don't want something that should be changed daily. It needs to meet the wound needs, like the assessed wound needs, if it needs absorption, if it needs to have moisture delivered, and then we need to continuously reassess and make this part of our wound bed preparation. So I'm going to stop now. Lee's going to take over and talk about the disease processes and things that happen. Now, we were going to have a hard stop at 12:30 for the Lunch and Learn. It's me. I don't even know it's a recorded session with me. But in any event, I know what it's about, of course. But we will do a hard stop. If he doesn't get done, we'll finish right after lunch, and then we will take your questions. All right? Thanks.
All right. Okay. Hello again. So moving on in this bioburden section now to infections of the skin and soft tissues. So we'll start with bacterial infections and look at furuncles or boils to start with. So a furuncle and boil are synonymous. It's a skin infection that starts in a hair follicle or an oil gland. Carbuncles are multiple connecting furuncles or boils. Skin poppers, of course, are the term applied to the subcutaneous abscesses that we see in the intravenous drug population. Etiology of furuncles and boils, primarily staphylococcal, both methicillin sensitive and methicillin resistant Staph aureus. Primary treatment is hot pack, incision, and drainage. Again, I would caution you when you see these things on tests, don't sucker for excision of a furuncle because you don't want to excise it, you want to incise it. And then alternate or adjunctive treatment. I think most of us with an incision and drainage of a boil, we will typically accompany that with a short course of systemic oral antibiotics, whether a first-generation cephalosporin for methicillin sensitive or something else for methicillin resistant staph. So here's that picture I mentioned yesterday, the sort of different appearance between a spider bite and MRSA. This is what a spider bite looks like. More commonly, this is what we see in the outpatient population, and this is community-acquired MRSA. So certainly, if we make the diagnosis of MRSA, we want to treat that. We want to obtain a culture and sensitivity. It's reasonable to treat empirically pending results. Oral antibiotic options for MRSA typically are clindamycin, trimethoprim sulfa, doxycycline, or linezolid. Now, I just insert a little editorial here. I think, in life and in work, we like to reach for things that make our lives a little bit simpler rather than more complicated. And for me, whenever possible, I will use doxycycline for MRSA. It has less in the way of systemic allergies or other problems associated with it than clindamycin or trimethoprim sulfa. Bactrim has a pretty significant incidence of allergies with people with sulfa compounds, and it certainly can have a significant impact on renal function, especially in the elderly. Intranasal mupirocin and showering with antiseptics or mupirocin to your fingertips are not considered a universal recommendation, but basically should be decided on an individual basis. Is this a patient's first go around with MRSA? Are there other people in the household that are affected? Those are all the sorts of things that impact your decision about adding some of these other adjunctive things. Hidradenitis suppurativa, or HS, really a lifestyle altering and quality of life altering problem. This hidradenitis suppurativa typically involves hair-bearing areas of the body. the axillae, the groins, the buttocks, the nape of the neck. And the most popular theory is that hyperkeratinization of these follicles leads to occlusion of the follicle, subsequent rupture and inflammation, then probably with bacterial overgrowth and a secondary bacterial infection. The typical treatment over the years has been an oral tetracycline such as minocycline, accompanied by topical clindamycin gel. And, you know, in my practice, that is effective in a certain percentage of times. However, I need to tell you, if you're not aware of this, that the TNF inhibitors such as adalimumab, which is Humira, and infliximab have been approved by the FDA for the treatment of hidradenitis suppurativa. And so I do have a sort of partner rheumatologist that is willing to see these non-rheumatologic conditions which require some of these medications that are much more in his wheelhouse than they are in mine. Impetigo, we think of this as a common contagious superficial skin infection in children, but it does present in adults as well, most commonly as staphylococcal, but could be a combination of strep and staph. Lesions are usually localized, rarely widespread. Systemic symptoms are infrequent, and generally, other than itching, these lesions are generally asymptomatic. So this is that typical honey-crusted appearance of non-bullous impetigo, and this is what bullous impetigo looks like. Non-bullous impetigo, again, most of the time staph, but can be a combination of staph and strep. Primary treatment is mupirocin ointment TID for 3 to 5 days. Most of us, I think, also will add something additionally systemically for a short course, depending on the severity of the eruption. Bullous impetigo, these are a small bullae that collapse to look like a varnish crust, almost always staph. Primary treatment for bullous impetigo is oral dicloxoxacillin or a first-generation cephalosporin such as cephalexin, and then alternative treatment with mupirocin plus one of these antibiotics. What I will share with you, just a little tip about impetigo. I think we're accustomed to thinking about impetigo as a primary entity, but be aware that non-infected wounds can become secondarily impetiginized. So if you're taking care of a wound that suddenly on one of your visits you see this yellow honey-colored crusting, be suspicious for Staph aureus, maybe take a culture of that and add mupirocin or one of the oral antibiotics to your treatment. Ecthyma is a deeper form of impetigo. These begin as a vesicle and then they progress to a punched out ulcer. Staph, strep, and Pseudomonas are causative bacteria of ecthyma, and we'll see something else with Pseudomonas that looks similar to this in just a little bit. Ecthyma theoretically can be associated with bacteremia. Due to the depth of the lesions, they can seed the vascular space. Cellulitis, I think everybody out there has a pretty good grip on cellulitis, a fairly common bacterial infection of the skin. It can happen anywhere and usually is associated with some pre-existing lesion, wound, or portal of entry for bacteria. Characteristically, cellulitis is associated with erythema, edema, and pain, and oftentimes with positive laboratory findings such as a leukocytosis with a left shift. Treatment includes empiric antibiotics aimed at skin flora, and if there is any abscess formation, then of course debridement becomes necessary. Erysipelas is an acute inflammatory, well-demarcated form of cellulitis, and typically you will see that proximal lymphangitic streaking with erysipelas. This tends to be more superficial and again, very, very well demarcated. Often there's a break in the skin as a portal of entry for the infection. I had a patient about a year ago that had erysipelas like this, and it appeared around his ankle in such a well-demarcated fashion that it initially almost looked as though he had a bright red ankle brace in place because it was so well demarcated around the ankle and then around the midfoot. But so that's erysipelas. Prodromal symptoms can include chills, fever, anorexia, vomiting, similar to any other form of cellulitis. Erysipelas tends to be most common on the lower legs, the eyes, and the face. With erysipelas, as well as other forms of cellulitis, strep is responsible for the majority of cases, group A being the most common, and treatment, of course, oral antibiotics aimed at the streptococcal population. Gas gangrene, also known as clostridial myonecrosis. Classically, this has been associated with contaminated traumatic wounds, especially outdoor wounds, but it can be spontaneous, and we'll see the most common form of spontaneous gas gangrene in just a little bit. The etiology, and you need to remember this because I am positive on any exam you will be asked, what is the causative organism for gas gangrene? And the answer is Clostridium perfringens. That's probably the way the question would be asked, and then other clostridial species as well. Initial diagnosis can be as simple as a plain X-ray looking for gas in the soft tissues. The antibiotics are critically important, and this should be in concert with your infectious disease colleagues. Emergent surgical consultation and debridement, followed by adjunctive hyperbaric oxygen therapy, is the ideal course of treatment. Emergent surgical consultation with appropriate antibiotics, and then hyperbaric oxygen therapy to follow. Hyperbaric oxygen limits the production of the alpha toxin that is liberated by Clostridium perfringens. Necrotizing fasciitis, this got the name flesh-eating bacteria some years ago, usually in post-surgical wounds, trauma, or really any streptococcal skin infection. There are a few different subtypes of necrotizing fasciitis. One is purely strep, the other is clostridial, and then a polymicrobial variety. And this is what it looks like. Initially, it's a clinical diagnosis based on being able to probe and pass your hand and instruments along the fascia. This disease progresses along fascial planes. Primary treatment, again, prompt surgical consultation and debridement. Empiric antibiotic treatment with gram stain and culture to make sure you're treating the right thing. This picture on the right here is not about what's under the yellow bandage. It's about that extensive scarring a little bit higher up, and that is from an episode of necrotizing fasciitis some years earlier. Polymicrobial necrotizing fasciitis. So Melanese synergistic gangrene is a less common term, but Fournier's gangrene is, I think, what's important to remember here. Fournier's gangrene is a perineal and genital necrotizing fasciitis. It is most common in diabetic males. And you can see here that this, the entire inferior aspect of the scrotum is gangrenous with some purulence coming out of it. And that needs urgent surgical intervention and appropriate antibiotics. And once again, hyperbaric oxygen therapy is indicated here as an adjunctive treatment. Toxic shock syndrome. This, interestingly, became popularized, back in the 70s or 80s with tampon use, but this is a toxin-mediated, life-threatening illness, deep-seated bacterial infection caused by toxins from either Staph aureus or Group A strep. Exploration, debridement often required, and because there is a hypotensive shock associated with this, necessitating the use of intravenous vasopressors, typically there will be distal ischemia and tissue loss, as we see in this cases, and most dramatically in this lower left picture. Staph scalded skin syndrome, again from a toxin-producing Staph aureus. It is an epidermal problem, slightly different than that seen in toxic epidermal necrolysis. Treatment, again, anti-staphylococcal agents. A biopsy sent for culture, of course, would be helpful in identifying whether this is bacterial or a TEN. So this is the follow-up of what I said we'd be seeing something similar having to do with Pseudomonas. So a couple of summers ago, my hyperbaric tech came up to me and sort of sheepishly pulled up her shirt and showed me her belly, which was covered in a rash like this on the lower right. And she said, "Do you have any idea what this could be?" And I said, "Well, when were you last in a hot tub?" So anyway, she had hot tub folliculitis, and for at least the next couple of weeks, she thought I was pretty smart. But you will be asked, what is the causative organism for hot tub folliculitis? And the answer is Pseudomonas aeruginosa. So this is what happens when you get into a big hot tub with 50 of your closest friends. This certainly does not demonstrate social distancing. Puncture wounds. So here we have on the sole of the foot, typical nail puncture. And on the right side, we have pictures of people who have had inadvertent nail gun injuries and have driven 16 penny or so nails through their foot and hand. The most common presentation is nails, not surprisingly. Less common, wood, glass, plastic, or other things. Most superficial puncture wounds heal without problems. And of course, as common sense would dictate, the deeper or penetrating wounds have a greater risk of serious infection, such as abscess or osteomyelitis. These injuries are most common around load-bearing areas, as in where we step, and also diabetics, not surprisingly, develop infection and osteomyelitis more commonly. A wide variety of organisms in puncture wounds, but the skin flora, staph and strep, tend to be the most common in these as well. Do remember that there's an exception to this rule, or an exception to this commonality, and that is that Pseudomonas aeruginosa is the most common organism associated with a puncture through an athletic insole. So nail puncture through a sneaker, more commonly Pseudomonas. Anything else, more commonly staph and strep. Environmental concerns, where the injury happened can be important. Stepping on a nail during your house remodeling project is much different than stepping on a nail that is submerged in the bottom of a lake or out in a garden with manure. Management of infected puncture wounds, again, this is an important case in which to remember tetanus immunization. Always evaluate for and remove foreign bodies. Start with a plain film, but don't rely entirely on the plain film, because if it is wood or plastic or non-leaded glass, it is likely not to show up on plain film. I saw a young lady last year in Buffalo who had been to an urgent care center and subsequently a hospital emergency department because of the fact that she had a wound on the dorsum of her foot from stubbing her foot on a wooden stump out in her friend's yard. And in both the urgent care center and the emergency department, they did plain films and said, there's nothing there, you're going to be fine, go home. And on neither of those occasions did anybody actually palpate or explore the wound. So she came in to see me as a brand new wound care patient, and I just took a pair of forceps and probed around just a little bit and pulled out about a 3/4 inch long piece of wood. Problem solved. So you can't rely on just that X-ray. You've actually got to look at the wound and touch it and feel it and look around in it. Antibiotic coverage, again, staph and strep will be the most common, possibly additional coverage for MRSA and Pseudomonas, depending on your judgment and where the injury happened. Soft tissue infections and water exposure. So how often do people say, can I go swimming with this wound on my leg or with my diabetic foot ulcer? Can I get in the hot tub? Or I'm going down south and salt water's okay, right? The answer to all of the above is no. You know, it's up to your individual judgment whether to allow people to shower or bathe with their wounds. But lakes, pools, hot tubs, and oceans are absolute no-nos with an open wound. So there also can be infections associated with in-water objects or aquatic organisms, and there is an acronym that applies to the common water organisms. It's this AEEVM, and it stands for Aeromonas, Edwardsiella, Erysipelathrix, Vibrio, and Mycobacterium. Those are odd enough sounding names that you'll probably remember them as being associated with water. Other infectious causes of ulcerated lesions. So you've got a wound that you're taking care of, you've cultured it, you've found nothing, you've treated it entirely appropriately, and it's not getting any better. So you got to think out of the box. First of all, you have to think about atypical causes of wounds such as malignancies. Secondarily, ask the question, where has the patient been? Do they have any recollection how the wound started? Because there are areas in the country that are endemic to oddball microbes, and it's helpful to know that. And this would also be the type of wound that you may actually want to ask for a quantitative tissue culture. Osteomyelitis. Dot mentioned to you earlier that I'd be talking about this, and osteo remains a relatively challenging diagnosis and treatment situation. The diagnosis as well as the treatment can be difficult. Clinical evidence often is not glaring. Radiographic studies can be inaccurate and misleading. So most patients, if not all, with a deep or long-standing foot ulcer should have a foot X-ray at least at baseline to look for cortical disruption suggestive of osteomyelitis, especially in the diabetic population. If the plain film X-ray is positive or equivocal, then you really need to move on to the next step. In 2020, the most sensitive and specific diagnostic imaging study for osteomyelitis is MRI with gadolinium contrast. Many of our patients cannot have MRI due to associated metallic hardware or pacemakers or spinal stimulators or any one of a number of things that are not MRI compatible. And in those cases, a 3-phase bone scan or tagged white blood cell scan would be appropriate studies. So here's a plain film. Look at the proximal phalanx of the hallux, the big toe here, and you certainly don't need an MRI to tell you that that is osteomyelitic and probably is going to have to come off. This is a lateral view of the calcaneus on MRI, and the red arrow is pointing towards that area of radiolucency, which is osteomyelitis. Much has been made of the probe to bone test. In other words, you look at the wound, are you able to see or touch bone? And a lot of studies have been done to look at the positive predictive value, if you will, of being able to probe to bone. And I don't think we need to talk about the numbers. What we need to know is that if we can see or touch bone, there is a high likelihood there is osteomyelitis, and we better go looking for it. Swabbing the exposed bone is not going to get you reliable information. The only way to accurately gauge appropriate antibiotic use for osteomyelitis is to actually have a piece of the bone. So if the bone is accessible in some way, shape, or form, you want to get a little piece of that osteomyelitic bone to send for culture. Because there are some new oral antibiotic regimens that have actually been shown to be as effective, if not more effective, than the old tried and true 6 weeks of intravenous vancomycin. So here is just an example of being able to touch bone, and again, a completely destroyed proximal phalanx of the big toe. All right, and closing up with viral infections. We certainly are, and I've got 4 minutes before that hard stop. All right. Shingles, we all know what that is. Shingles is a reactivation of the varicella pox virus, or the chickenpox virus from childhood. It usually involves the skin of a single dermatome. Our sensory nerves are arranged anatomically. They start in the midline and then move outward from the spine and down, sort of in a Christmas tree fashion. And usually shingles or herpes zoster will affect one of those dermatomes. It can be extraordinarily painful with significant prodromal symptoms, as well as very significant post-herpetic neuralgia pain. And understand that there are 2 vaccines available. The newer Shingrix recombinant zoster vaccine is presently recommended by the CDC and is more efficacious than the old Zostavax. Fungal infections, candidiasis caused by Candida albicans and other Candida species. Usually these are localized infections. If you see widespread Candida, you probably should be on the lookout for some immune limiting illness. You can make the diagnosis of a Candida in your office with a simple microscope and some potassium hydroxide, but more commonly, you would look at this shiny, moist, red eruption in a warm, dark, moist environment, and you would clinically make the diagnosis of a yeast infection, such as this candidal diaper dermatitis, or on the right-hand picture, candidal intertrigo. The intertriginous regions are those regions beneath our skin folds, typically between underneath belly folds or beneath pendulous breasts. And again, warm, dark, moist environments, fertile for the development of yeast. Some risk factors for candidal or fungal overgrowth: antibiotic therapy, of course, diabetes, topical steroids, wet skin, oral contraceptives, pregnancy, and then any problems leading to cell-mediated immunity. Candidal diaper dermatitis and balanitis, although the balanitis portion is appropriately covered here. And then an interesting case of candidiasis in the folds of the thigh. Candidal treatment, usually topical antifungals. Remember that some fungi have become smarter these days, just like bacteria, and so there are newer generation topical antifungals that are effective against some of the more resistant organisms. You want to keep the areas dry, clean, washed, clean, and dry. And then barrier creams such as zinc oxide in areas like diaper dermatitis. And that's it. I have finished with 1 minute to go. And so I'm going to let my adult supervisor here give you directions for the next half hour.
All right, everyone, we're going to take our lunch break and have the Lunch and Learn, which is also available for 5 CE, half an hour of CE. And we will resume at 1 o'clock, and then Lee and I will take questions from this section. So enjoy lunch, and I hope you enjoy the presentation.
Muted.
So these are our objectives. We're just going to look at mechanically powered negative pressure wound therapy if you've never seen it, and look at a holistic approach and what kind of things this can do for our patients, recognizing the importance of using some sort of a wound therapy that's going to limit somebody's ability to move and to mobilize, can definitely impact their quality of life. So we'll be looking at all of that. And then we both have some of our favorite case studies with us. Oh, this is the evaluation code, but again, it will be up at the very end also. So let's get into talking about wound healing. When we look at what we call a chronic wound, and Chris is going to talk later about the prognostic indicators and things that we tend to look for. But, we tend to put this 30-day time limit on it. Is it really 30 days before a person really develops, their wound becomes truly chronic? Well, I would submit to you that it's really more patient-driven. Certainly time comes into play. If it's been there a long time, there's likely an increased bacterial load. As a result of the presence of the bacteria, you're going to have more proteases that are going to be there. And anytime as you have a high level of proteases, they are indiscriminate. They're going to start breaking down anything protein. So that's going to include our growth factors, all of our other matrix proteins, cell surface receptors to receive signaling, as well as our receptors such as integrins that allow the cell to interact with its environment. It results in prolonged inflammation, so that's what we seem to hear so much, that these wounds are being stuck in a chronically inflamed state. Cells sitting on the surface are now bathed in this environment that don't kill them necessarily, but they certainly are not going to be as responsive, hence the reason we do a lot of the maintenance debridement that we do. And a lot of times it's just been they haven't had the right kind of treatment, or as I joke sometimes, they listen to their mom. Clean it out with peroxide, let it breathe, don't pick your scabs, all these things that we know are not good for the wounds that we take care of. So it also, of course, can be patient-driven. These folks arrive to us with disease processes and comorbid conditions, an average of about 10 or 15 or 20, I think I just heard, that will put them in a position of having something that's competing with the resources that they need to heal, such as metabolic resources, such as oxygen. The person who has some sort of a pulmonary issue, if they're not breathing good oxygen, they're not perfusing good oxygen. Certainly different medications that they can be on can interfere with wound repair, and some of the newer or older medications that are being used for newer indications, such as the TNF inhibitor agents that are typically used for rheumatoid arthritis and now are used for Crohn's disease and other things. Certainly patients getting in their own way, not adhering to our treatment program, not following their diet, the whole smoking issue, which of course we could spend a lot of time on, and then those people who we need to compress, we need to wrap, and or offload with a diabetic shoe or device. How many do you have come in and their compression wrap is off, and you say, why don't you have your compression off? Oh, I just took it off to come in here today. Or you look at their shoe, they live in Western New York, it's muddy there right now as the snow is all melted and we've had a lot of rain, and it's perfectly clean. Nobody's shoes are clean in Western New York right now. So these things where the patient certainly gets in their way, and we have so much counseling to do. So when we look at the requirements for wound healing, this is something that we've all been schooled on. We know we need to get the wound clean through good debridement, manage to the bioburden, protection from contamination, as well as treatment to what we think might be there, along with the threat of the biofilm that we're hearing so much about. And Greg Schultz and Randy Wolcott will be talking about, I think it's in session 44 tomorrow. Managing to edema, getting a good tissue balance, realizing that sometimes even if they don't have venous insufficiency per se, they may still need some edema management, either right around the wound or certainly on their lower extremity. And then, of course, managing to inflammation. So that's, I think, what negative pressure wound therapy will do for us a lot. It provides a lot of those things by promoting good granulation tissue, getting rid of the wound exudate that's harmful to the environment, taking away the waste off the surface of the wound, creating that nice balance of moisture, as well as promoting perfusion. And we'll talk about how that happens. But I would also say to you that I think negative pressure has become a part of our routine care. I remember when it first came out, I was actually not working clinically at the time when it was launched, and one of the things I couldn't wait, in 2001 when I went back into clinical practice, I couldn't wait to put my first negative pressure device on because I'd heard so much about it. But now we wouldn't try to really fill in a huge soft tissue defect without negative pressure unless there's some reason that we can't use it for a particular patient. For skin graft recipient sites, this was a patient who had probably the worst vasculitis that we had ever seen and had a very, very large skin graft put on. And there should have been some things on the side, but he had debridement, he had a split thickness skin graft. That was the skin graft in about 3 or 4 days afterwards, and this is the graft at 11 days. We wouldn't see that kind of take without negative pressure wound therapy. So again, it's something that we use routinely. But there was still a gap as we looked at the patients that needed negative pressure wound therapy. People needed to work. People needed to get on with their lives. Mobility was a concern. You get a frail, older person who's going through rehab, and even though we have the newer, smaller devices that could rest on their shoulder, it was still something that could cause them to lose their balance. So the person going through rehab, younger folks, people who are still going to school, such as a pilonidal cyst, things like that, where we wanted to use it for a large defect, but their lifestyle was going to be so negatively impacted. Even the person who wants to go to church, some of the larger devices, the portable ones, have a little bit of a sound that in a quiet area could be embarrassing to the patient. But it's really going on with their life and being able to continue to go to work is a big driving factor. So this is not all one company. This is all various different companies. I just pulled them off the internet that we know there's a lot of choices for negative pressure wound therapy. And for our inpatients, folks that don't need a lot of mobilization, then the larger devices are fine. Even the ones that they wear on their shoulder, or they can wear as a fanny pack, if you will. So when we look at negative pressure wound therapy, it's been studied and used across all the care settings and in all wound types. It's in its 3rd decade of use, so it's commonplace, as I've said. So the many kinds that are available, what we're mostly used to are those that we plug in and have an electrical source or some sort of a battery powered. And then what we're going to be talking more about today is one that works on a mechanical force with using a spring that enables them to not have to have a battery and not have to have any source of electricity, which is important if you have someone who maybe is homeless and would still benefit from the negative pressure but doesn't have a source of power at all times. The interesting thing about all of these is that they have similar mechanisms of action. The most significant differences are in how they're used and the instructions for use, which we'll talk about some. But the mechanism of action is so fun now to talk about the bells and the whistles that we have with negative pressure wound therapy, but the actual mechanism of action is the same. And that's the use of an interface that is drawn in under suction. And a lot of times people think it's a drainage device, but it truly is a suction device. The secret sauce, the sweet spot, is in that suction that's being applied to the surface of the wound, the subatmospheric suction. So we have the mechanical pulling in of the edges together, the macro deformation, and then we have the micro deformation, which is what is happening down at the interface of the interface dressing, most oftentimes a foam, and the wound bed itself. So let's look a little bit more closely at this. When we have the negative pressure bandage that's in place, is that showing? Oh, it's not showing up. The foam bandage that's in place. If you just think about the cut edge of that foam, it has these little struts that are pushing down ultimately at the very last thing at the interface of the tissues. Those little pieces of foam are pushing down in there. So the end result is that the cells are being stretched. And it's through that stretch that the cells have messengers that are sent into the intercellular space, and it causes that cell to change its activity. And again, this is the integrin that's on the surface of that cell that senses that stretch in the first place. And so what you're looking at the bottom are some biopsies that were taken where it was the same wound, but the one on the left is where it was just like a film drape that was sitting on top of the surface versus the actual interface dressing of the foam. It's been highlighted with that blue line. That didn't come along with the wound. But in this histology slide, what you see is where you had that interaction and the stretching and the micro deformation of those cells, you see a little bit more viable tissue, but we actually see an improvement in the vascularity. So what we saw happen is for negative pressure wound therapy to go from portable, which we've had now for a long time since the early 2000s, to wearable, where it can be underneath the clothing in someone's pocket and not where it can show to the outside world. So the mechanically powered negative pressure wound therapy system has a cartridge that is a collection port, if you will, but it doesn't have to have any kind of electrical or battery power. Its actual power source is a constant force spring that's made of a specific kind of metal, and as it unfolds, or as it works like a plunger on a syringe, and as it pulls back against the surface of the wound, it is actually created so that there's either 125, 100, or 75 millimeters of mercury, and so it's this slow pulling back or unfolding of this coiled metal that is generating the negative pressure against the tissues. So the majority of the little cartridges are a 60 cc capacity. There are some that are higher, like 150, and so there's no sound, there's no power, but there's also no alarm. So we have to have the patient educated on what to look for. So it's a visual indicator by a red line that tells the patient if they have lost their seal or their cartridge has become full. The interface dressing is also a little different. If you haven't seen this, it is a hydrocolloid dressing, but a very thin proprietary hydrocolloid. And it's interesting in that, we're used to being able to see the skin well underneath the film dressings that we use with most of our negative pressure wound therapy. But this hydrocolloid is very, very translucent, very thin, and you can really appreciate pretty well what the skin looks like underneath. It has an attached port on the surface of the dressing, and then it has a tubing that, this is a big plus, is that we can cut it to the length that we need it. It's not something that we have to coil up and tuck away somewhere, again, with the ambulatory systems, which could, again, be a sort of a fall risk. So the anti-reflux valve is at the end. It can come off. We can trim the tubing to the length that we need and then reattach that port. So the weight is another thing. It's very, very lightweight, 0.1 kilogram, and when it's full, it's just a couple of ounces. This one that's shown is 125 millimeters of mercury, but it does come in lower levels of negative pressure. And in our practice, we had used some of the others, but we pretty much settled on the 125 being, something that pretty much works for all of our patients. The dressing is an open cell, reticulated open cell foam, just like the negative pressure foams that we're used to using. The biggest difference is it's blue instead of black. So it is nice about that is you can appreciate color of the exudate in the lighter color. The cartridge is disposable. When we change the dressing, if there's any exudate in it, we generally just throw that cartridge away, and it's sealed up, but there's a bio-lock in it, so it's not a sloppy mess. It is gelatinous. It's gelled up in the cartridge, so you can just throw it away into the regular trash. And it is a continuous therapy only. Now, if you are taking care of a wound where you feel like you need intermittent therapy, you will need to use one of the bigger devices. And again, no audible alarm, just a red line at the base of the cartridge that lets somebody know that it's either full or that they have lost a seal. Being a hydrocolloid, it's not like you can cut and piecemeal little pieces of drape like we're sort of used to being able to do. And so there's an extra part to this that is a secure ring that looks like a hydrocolloid ring like we use for ostomy patients. And it's made of the same hydrocolloid as the dressing, and it really simplifies dressing applications because you do have to be careful as you put it on, and I'll get to this, because if you get any wrinkles, again, it's not like you can cut a bunch of pieces of drape and seal those up. So this ring has really made it easy to place it on, and I'll show you in the next slide that if you have a larger wound or you need to change the shape of it, you can roll it into like a jelly roll, or you can make it larger. But when you put it around, and I don't have a pointer, as you can see on the bottom, we've got the negative pressure in place, and as long as you have no wrinkles on the inside of that, oh, thank you. How do I use it? Oh, there we go. Oh, okay. As long as you have no wrinkles right in here, all the wrinkles out here won't matter. So it really makes a difference. The hand is a pretty easy place to do, but where I find the utility is especially on the foot and any place that's curved. Then you can fill in the ring with nice flat dressing. And again, this points out how nice and translucent this hydrocolloid is. And then you don't have to worry about the wrinkles that are farther out around it. So the FDA indications for use are the same as the negative pressure that we use now. It's really going to now boil down to how big the wound is, how large the surface area is, as well as how much exudate is coming out. So the indications, though, are the exact same as the negative pressure that we use now. So when we look at mechanically powered versus electrically powered, what are the differences? Well, electrically powered, you have very large canisters, depending on if it's the inpatient unit or one of the more mobile units. So we can hold a lot of exudate. Exudate is really, to me, what drives the decision of being able to move over or not. With the pressure options, you do have some lower options, but for the most part, 125 is the most commonly used cartridge. And as we know, with the electrically powered, we can alter that. There's no programming. It's very easy to use. It's a quick application in the clinic or in the home setting, and less bells and whistles to even have, although that's a big plus sometimes with some of the bigger units. It's something that we don't have to worry about with a smaller unit. You can see 2.2 ounces empty versus the heavier ones. Again, my point about it possibly throwing off the stability of the person who's walking, and again, requires no electricity. So as we decide, we're looking at size of wound, generally something that's 13 by 13 or smaller, although, we're all very creative. And so you can piecemeal a little extra hydrocolloid. There's all these little tricks that you learn, but as a general rule, if it's a massively large wound, we're going to choose the larger devices until contraction takes place and we get that smaller. Wound drainage is about 180, greater than 180 milliliters per week, we're going to use something that's a lot larger. And then the additional considerations you can see, and I've really already alluded to these, but it's really drainage and size of the wound. So the coverage criteria, it is a purchase for the supplier. In other words, the clinic that's using it, and I'm going to talk about some codes, it's off the shelf. So if you decide today that you want to use negative pressure, you can pull it off the shelf and use it. We don't have to wait 30 days because it's not DME and is not rental. So if someone has a very high copay with their DME that may be used up, or they have limited amount of DME coverage for a year's time, then it saves on using that part of their insurance. So there were some randomized controlled trials that were done. The company that had this mechanically powered device when it was first launched was different than KCI, who has it now. And they really stepped out and decided to take on the negative pressure. That was the number one selling in the United States. And so they didn't go out, though, and I'll just summarize this, they didn't go out to show that they were better. They went out to show that it was delivering the same type of therapy as the negative pressure that we had gotten used to using. So the study, we were in it in our clinic, was diabetic foot ulcers or lower extremity venous leg ulcers, and they were evaluated for 16 weeks or until they were completely closed. And the end result was that they delivered the same therapy. The healing trajectory in the mechanically powered was the same as the powered. And then Bill Marston looked at this data and thought, wow, we've got We've got people with venous leg ulcers in this group, and that's not a patient we often think about for negative pressure wound therapy. And so we did a subset to look at those patients that had healed venous leg ulcers and found that there actually was a difference, that many of the patients with the venous leg ulcer group did heal faster. And in fact, 53% of those patients in the venous leg ulcer group achieved 50% wound closure, which Chris will talk about in just a few minutes, at 30 days, as compared with about half of that with the power system. I tend to think it was the hydrocolloid dressing played a role in that, but I don't think that's really been described. So the other thing we did with the study is we talked to people about, how do you like this thing, and many of them had never had negative pressure before, so they didn't have a comparison. Those patients that we have that have had both obviously liked the smaller, quieter device better. But anyway, what they did is they found that it was not noticeable in social situations, less noise. I don't know if you have your picture of the patient with the pillow over his head. Do you have that in there? Anyway, okay. And I just gave it away, didn't I? But I mean, that's what people complain of, not so much during their working day, but when they're trying to sleep or trying to go to church. So that's the person who's going to be disconnecting their power source, their power device, while they go and do that until they can get back to where that doesn't matter to them. Now, I'm not a coding specialist, but there are codes that can be used for use with the mechanically powered, because it's not DME rental. And so the company has people that can work with you on this, but just suffice it to say, the two places that it can be used are in the outpatient clinic, and whoever's doing it has to take control over it. So the outpatient clinic has good codes that they don't lose money on this, but they have to see the patient twice a week. That's the frequency of recommended change for the mechanically powered. So they will have to come back into the wound center. We can't do it this on Monday and then have, say, home health. Even home health can use these codes. We can't have home health do it on the other day. One or the other has to be doing that billing. So they can still be done by home care, and then certainly we need to see them in the outpatient wound center, but one or the other has to be doing that billing. And again, there's lots of information that is available for that. So just a few of my cases, and then I'm going to turn it over to Chris. This was a lady who had a cat bite. I did most of this in Kissimmee, Florida, and we had a lot of people who came down as winter visitors. But this was a lady, I think this is one of them, 87-year-old gal, who you can see her past medical history. She had a cat bite, which became infected, so she was admitted to the hospital, had IV antibiotics, and then she was changed to doxycycline at the time of discharge. So her initial picture is a deep tunneling wound to her lateral calf. It was debrided. We started collagenase, and then we were packing hypertonic gauze ribbon in to help pull the exudate out as it liquefied. So you can see when we go from the initial to day 0, when we started the mechanically powered negative pressure, it was clean, but now that we got the negative pressure out, now that we got the necrotic tissue out, we had about 1.1 centimeter tunneling up, so we decided to use it on that. And the concern is still there. You have to be careful about really thin, skinny pieces. It is the reticulated open cell foam, so you have to use a durable enough piece if you're going to track it up into a closed area. So her tunneling became a little bit larger, but I think that has to do with reduction of edema in the area. But you can see it's nice and clean. This is at day 7. It is much smaller. The tunneling is now down to just 0.5. And then we got to day 14 where she had no undermining at all. And then you can see we could barely even get the dressing on it. So we stopped it at this time, switched her over to an ORC collagen silver dressing, and then she went on to completely heal. This wasn't one of our winter visitors. So this next case is another one that we become concerned about, and that's anybody who has hardware anytime. So we have an open wound over hardware. Of course, we're going to be concerned about it. So 75-year-old lady who, I just want to make sure I'm not taking up his time, doesn't have really much of a contributory health history, did have a knee replacement, and she had an area of dehiscence over it. And it looks like looking at this, it looks like the rest of this case is not here. So Chris was rearranging some things just for time, and so maybe we'll come back to her. But the bottom line is it was a very, very tiny wound, and you would have said, Why would you use negative pressure on that? Well, the reason is because it was right over a knee joint. And so we want to make sure we're getting those wounds closed, obviously, as quickly as possible so that we don't have bacteria, which we know will penetrate down into a few millimeters of tissue down to her joint. But this was a fellow who was in our clinical trial. He has a diabetic foot ulcer, no real past medical history other than some depression, but he wasn't a real good one. He had, you can see his A1C was 9.5, but he had had his fifth toe amputated, and his fifth ray amputation, and then he was referred to us because of this open wound. So he was uninsured, so we started him, and that wasn't the reason, but he was a perfect wound to put into the clinical trial, so we enrolled him. He had a washout period, so this is the first day of his application before and after the debridement. The days are gone. No, this is at 2 weeks. This is at 4 weeks, and he went on to complete healing. I'm not sure that was that. But anyway, this is a neck wound, cervical spine surgery. Patient that had cervical myopathy. You can read the rest of his comorbidities. But he had a cervical laminectomy, and again, he's in a very vulnerable area up there in his neck, and he had a small wound dehiscence. Not a difficult area, nice, easy place actually to apply the negative pressure wound therapy, mechanically powered. So he had a little bit of a 1 centimeter tunnel going up, and again, you don't have to pack it deeply. Just like we just put a little. I usually cut it like a little arrow, and then tuck up partly up into the wound. So this is the day that we started it. He had a 0.6 tunnel. And then at day 15, we were able to completely discontinue it, and he began collagen again, and he went on to complete closure. And again, this is not Chris's fault. He just wasn't familiar with my cases. This is my diabetic foot guy who ultimately went on to heal. So I think this might be my last one. This is a guy who's young, healthy, a 43-year-old guy. He really had no other past medical history, but he had a surgical reconstruction of his first MTP joint, and it had dehisced. So this is his initial evaluation. Well, we were getting him cleaned up, so we began pre and post debridement. I got him a little cleaned up, began to the negative pressure wound therapy. This is at day 14, at day 31. And then at day 38, it was able to be stopped, went on to a collagen dressing, and he went on to completely close. And okay, this is the lady with the knee replacement. And again, I should say that this is not your typical patient, because you can see where we started. We began the negative pressure here. And at this point in time, 3 weeks later, she was able to be closed, and then we started an extracellular matrix product, and then she was closed in a week. But again, our biggest fear, and why we put all this through all this at her, is of course the fact that she has a joint underneath there that we're concerned with any kind of contamination. So I think.
Great. I'm going to unmute myself. All right, well, welcome back from lunch. Hope you enjoyed the presentation. We're going to finish now by answering the questions that came from the bioburden section, and then Lee will start with hyperbarics. So well, there's some really good questions in here. So one is, has the antimicrobial stewardship affected our clinical practice, especially with SNF patients? And you know what, I don't know that. I mean, I've already read the rest of his questions, but this person is talking about the fact that they've witnessed overuse of antibiotics out of hospitals, emergency departments, private offices, and some wound care center providers. And I think that's where we have a responsibility as a wound care provider to practice antimicrobial stewardship and not do pan culturing and not overprescribe, prescribe when you need it. Do you want to add to that?
Well, yeah, and I think that in the wound care world particularly, and by the way, I am sitting on one of our broken office chairs that is stuck in the low position, so I'm not really this short. So I think when non-wound care providers see a wound, there's an automatic assumption that it is somehow infected. And I think that our well-meaning colleagues want to do something, so they will typically start somebody on Keplex or something like that. So, yeah, I mean, technically I do see some overuse, but not what I would consider to be harmful.
And she goes on to ask about returning patients into long-term care, rehab centers. If we've done culturing that we're not going to do anything with and they just are colonized with MRSA, then that can interfere with their transfer, so that could be a problem. Question about, is 2+ similar to, on a semi-quantitative culture similar to around 10 to the 5th? Probably so. That one paper cited that 10 to the 4th. I mean, 4+ was equal to about 10 to the 7th. So I don't know if there's a direct correlation, but your decision to treat could be based on how positive it was, what quadrant, as well as it's always going to be correlated with clinical symptoms. This is, I'm glad you asked this question. This was what was the teaching point, the query about, I was talking about, this was back in, talking about the adhesive stuff in dressing. And mechanical, I'm just drawing a blank on it, but I know what you're talking about. I talked about edge blisters, and I was talking about when thick dressings sink into wounds, into skin, especially under compression, you see these little water blisters, these little edge blisters. So that, if you're seeing those, and or if you're going to use a dense foam, like thick silvers, thicker, different foam dressings, then I'm trying to use brand names that we use, but like pigmented foam dressings, we will bevel the edges so it flattens it out a little bit so it doesn't create those edge blisters. And you really usually only see them when you have significant edema, but that's a reasonable thing to ask because I sort of glossed over that. Two chronic, I thought this was interesting, 2 chronic venous leg wounds recently cultured showing Clostridia, one perfringens, but also had Enterobacter and Enterococcus under multi-layer compression wraps. And where would this have come from? Contamination by home health. You know, I think one of the things that is one of my soapboxes about wound cleansing, and I heard Robert Kirshner once at a big international meeting, he changed my life with a statement, is that don't forget about the contamination that you can get from the wound edge. And so as we've looked more at wound cleansing and wound hygiene, we want to get rid of scales around the wound. If you don't think when you peel up that scale, and I'm going to talk about this afternoon, that there's not bacteria hiding under there, I think we have to think again. So it could be a contaminant, and it could be, if the wound doesn't look infected, but they're showing up with this on the culture, I would think it certainly could be from the wound edge or scales, and considering that we've got it trapped under that wrap for the whole week. Anything else?
Yeah, and I think it is extraordinarily unusual that you would grow Clostridium perfringens out of a venous leg ulcer and without the ulcer looking horrible. That frankly seems bizarre to me. I can't imagine the scenario, and I've never seen that in 15 years. But I don't believe that I would treat that empirically. I would call my ID buddy and say, buddy, I just found something really strange. I just grew Clostridium perfringens out of a venous leg ulcer. I think whenever there's an infection-related question, you can never hurt yourself by reaching out for a little bit of extra advice, but I have never, ever heard of Clostridium perfringens coming out of a venous leg ulcer. Next question is, when following a chronic wound, would you do serial x-rays monthly to look for osteomyelitis, such as in a foot wound? Well, that's an interesting question because a plain film x-ray is not the definitive study for osteo. However, I think that it gives you some reassurance if you, and who knows down the road, somebody else might be looking at your chart. And I think if you've done x-rays appropriately and documented that you're looking for cortical disruption, if those x-rays are read as normal, it doesn't prove that there's no osteo, but I believe in many ways you've done your due diligence. If on the other hand, there is exposed bone or the wound is worsening, then I think you need to build a case for your insurance with your insurance company to do an MRI or some other definitive study, because you really can't hang your hat on plain films for osteo. And then the next question, which oral medication do you use for osteomyelitis? Well, there's a wonderful podiatrist, well published from the Scholl College of Podiatric Medicine in Chicago. Her name is Stephanie Wu, last name W-U, and she has recently published on this. There are several different regimens. So what I'm about to tell you is not to be taken as gospel, but the regimen that I've been using lately has been doxycycline 100 BID and Levaquin 500 daily, each for 6 weeks.
Okay, and the last one, I think it might be a mistype, so oops, sorry, you can tell me, but it says a test question read similar to this: which drug is worse for the wound? And I think it's probably which bug is worse for the wound. And the answers were E. coli, protease, strep A, and strep B. So protease is not a bug, so that's an enzyme. So it would be down to E. coli, which is many times a contaminant, but it's definitely beta hemolytic group A is the one, right?
Right, and yeah, I would say out of that bunch, beta strep group A is the worst. But I'm wondering if the second response there, protease, I'm wondering if that was mistyped and it was intended to be proteus. Proteus is a gram-negative bug that also tends to be a surface contaminant and is not thought to be usually a significant wound pathogen. So E. coli, proteus, strep A, strep B, I would pick strep A.
All right, I think that's it, but we'll keep looking at them. So I'm going to bow out, and Lee's now going to talk about hyperbaric oxygen. And he gets the big chair.
That's right. I get to sit in the big person's chair now. Okay, so, and this is the last session today that you're going to have to put up with me. So, anyway, hyperbaric oxygen therapy in wound healing. First of all, sort of as a proviso here, hyperbaric oxygen therapy over the years has really gotten a black eye in the industry, if you will, because of some terribly unscrupulous use by people who A, didn't know what they were doing, and B, didn't care and were putting people in the hyperbaric chamber because they could get paid for it. So the regulations are more stringent. The indications are about 14 approved indications. And I would submit to you that all except about 2 entities, hyperbaric oxygen therapy is always an adjunctive therapy and rarely a primary treatment. I think the science of hyperbaric oxygen therapy is fascinating. I went back out in 2008 and got boarded in hyperbarics, and that was really a fascinating process in terms of the science behind hyperoxia and pressure. So a working definition of hyperbaric oxygen therapy is that it's a treatment in which a patient breathes 100% oxygen intermittently while inside a treatment chamber at a pressure that is higher than sea level pressure. Must be 1.4 atmospheres absolute or higher to qualify as hyperbaric. At this time, there is not insurance. Well, I take that back. There is some insurance approval for topical high pressure oxygen therapy. I will share with you that myself and my hyperbaric boarded colleagues do not agree and support the evidence behind topical high pressure oxygen therapy. So for the purpose of today's conversation, we're talking about treatment within a hyperbaric chamber. So in the regular world here, we talk about pressures typically in millimeters of mercury or pounds per square inch. So where we sit here at the Earth's surface is roughly 760 millimeters of mercury or 14.7 pounds per square inch. That also is the equivalent of 0 feet of seawater. Back in the old days, shipboard recompression chambers were calibrated in feet of seawater so that the injured or bent diver could be resubmerged to the same depth at which he was injured and then recompressed slowly. So 2 atmospheres absolute is 1,520 millimeters of mercury, and 3 atmospheres absolute is 2,280 millimeters of mercury. So we know that the partial pressure of oxygen at sea level is about 160 millimeters of mercury. So air is 21% oxygen and 79% nitrogen. So 0.21 times atmospheric pressure of 760 is 160 millimeters of mercury. Now, if we put you in a hyperbaric chamber at double atmospheric pressure, then we double that 160 and it's 320. If we put you in at 3 atmospheres absolute, it's triple that baseline number, 480 millimeters of mercury. But it's important to understand that air is always air, no matter where it is. Hyperbaric air is still 21% oxygen. So in the hyperbaric treatment environment, we are not using air, we are using 100% nitrogen, so that 0.21 becomes 1.0. And so the concentration of inspired oxygen at 2 atmospheres absolute rather than 320 millimeters of mercury is 1,520 millimeters of mercury. These are monoplace chambers. These are the ones in my program up in Buffalo. These are 8 feet long, 3 feet in diameter, and of course, 1 patient at a time in each chamber, and the chamber is compressed with 100% oxygen. The flat screens on the ceiling above are for folks to be able to watch movies, DVDs, and so forth while they're in the chamber. This is a multi-place chamber belonging to a program from a friend of mine from Miami, Florida. And in this scenario, the patients sit in these chairs on the sides of the chamber, and their hyperbaric and their oxygen is delivered through a hood that rests over their head with a neoprene air dam around their shoulders. And the studies have shown us that hyperbaric oxygen therapy, whether in a monoplace chamber or whether in a multiplace chamber, the concentration of oxygen is exactly the same. So the gas laws were developed back towards the end of the 18th century to explain the relationships of pressure, volume, and temperature of gases within a system. And the 4 guys who did these laws were Boyle, Charles, Henry, and Dalton. And we certainly are not going to look at all of those, but there's a couple of pertinent points that I think you should be aware of. So Boyle's law that says for a body of gas at a constant temperature, the volume is inversely proportional to the pressure. And where this This has two practical roles in the hyperbaric world. And in clinical hyperbaric medicine, this becomes most relevant in terms of people being able to clear their ears at the start of each hyperbaric treatment. When you're in an airplane and you're descending down through that last 10,000 feet and your ears start to get full and you clear them, that is Boyle's law at work, because the pressure is increasing as you're nearing the earth, given that an airplane cabin is pressurized at about 8,000 feet. And as you get below 8,000 feet, the pressure is greater, and so that gas is changing volume. The other area where Boyle's law is important is in the treatment of decompression sickness, or the bends. And so in that disease process, nitrogen bubbles come out of solution and find their way into joints and central nervous system structures to create this problem. So those bubbles, when we put somebody in a recompression chamber, we shrink those bubbles and drive them back into solution so that the patient or the diver can be recompressed at a more appropriate rate. Dalton's law is the law of partial pressures, and this says that the sum of partial pressures of the gases in a system equals the total pressure in the system. So when we have a commercial diver that's diving with a mix of oxygen and helium and nitrogen and other things, this formula becomes a little bit complex. However, the perfect real-world example of Dalton's law is air. Air, 21% oxygen, 160 millimeters of mercury. Nitrogen, 79% is 600 millimeters of mercury. That equals atmospheric pressure, 760. So the physiology of hyperbarics is about two categories. One is the mechanical effect, which is the reduction of bubble size, and we just talked about that with Boyle's law. And the other is the effect of increased partial pressures of oxygen. Oxygen at pressures higher than atmospheric pressures behaves like a drug. So like other drugs, there are specific indications, side effects, and adverse effects. So effectively, we need to write a prescription for hyperbaric oxygen therapy, which includes the dose, the duration, and the frequency. Okay, so 2 atmospheres absolute for 2 hours daily, Monday through Friday for X number of weeks. This chart is just to illustrate the reduction in bubble size as one goes down through the water column here, this happy diver, and that the relative size, surface area of the bubble is down by 70% by the time you get to 6 atmospheres absolute. These two graphs just illustrate the rise in transcutaneous oxygen tension in a hyperbaric chamber, 2 atmospheres absolute, 100% oxygen. Transcutaneous oxygen levels measured usually between 400 and 500 millimeters of mercury, remembering that normal is 45 to 50 at room air, as we discussed yesterday. And this is just the rise in inspired concentration of oxygen on the y-axis as a function of pressure in atmospheres absolute. So by the time we get to 3 atmospheres absolute, our inspired concentration of oxygen is 2,000. So there's a pretty good sized body of evidence that supports that the intermittent hyperoxygenation of under or hypoperfused tissue beds happens in the hyperbaric chamber. That process is only achievable by exposure to hyperbarics. Physiologically, this produces a directly proportional increase in plasma oxygen that is available for cellular metabolism. So herein lies one of my criticisms, and I think one of the hyperbaric community's criticisms of topical high pressure oxygen, is that when the oxygen is not inhaled and distributed through an intact cardiopulmonary system, we are not hyperoxygenating the plasma. So this whole process establishes adequate oxygen availability within the vascularized tissue compartment surrounding the wound. So you might ask me, or you might say, hey, wait a minute, oxygen is carried by hemoglobin. And if I put a pulse ox clip on my finger, I'm going to be 97 or 98% saturated. So how can we do any, can we make good better? Well, yes, but not by supersaturating hemoglobin. What happens is that, and I made this diagram here just to illustrate just a blood vessel with red blood cells containing hemoglobin coming down the pipe here, and all of a sudden we have a thrombus that blocks the flow of blood. So ordinarily the vessel and the tissue distal to that would be completely devoid of oxygen. However, in the hyperbaric environment, that plasma, the liquid portion of blood without red blood cells, becomes hyperoxygenated and is able to deliver oxygen to the surrounding tissues. We know that neutrophils, fibroblasts, macrophages, osteoclasts, many of these cell lines all depend on an adequately oxygenated environment to carry out their functions. We know that fibroblasts cannot synthesize collagen without oxygen, and we know that proper oxygenation of the vascularized tissue compartment is crucial to initiation and persistence of the wound repair process, and hypoxia becomes a rate-limiting factor for cellular functions associated with wound healing. Side effects. There are a number of potential side effects. We will go over in a little bit more detail some of the more common and the ones that I think you might be asked about on a test. So middle ear barotrauma, this is the most common challenge that we have. If people are unable to equalize pressure in their ears, we're not able to proceed with a hyperbaric treatment. So we, on the first couple of treatments, we start the pressurization process very slowly, and we teach the patient how to clear their ears, how to equalize pressure through the eustachian tubes. If they are unable to clear and they develop pain, we stop. We come back. We depressurize a little bit, have them try again. If they are not able to clear on that first treatment, I'll usually have them pick up a bottle of Afrin nasal spray, use it for a few days, and then have them come back and try the treatment again. Ultimately, if we're not able to get them to clear, then we'll have them see otolaryngology or ear, nose, and throat for placement of tubes in their tympanic membranes or eardrums. Effects on the eyes. Roughly 20 to 40% of patients that go through an entire course of hyperbarics, 5, 6, 7, 8 weeks, will develop some degree of myopia or nearsightedness. That typically returns to baseline within about 6 weeks after treatment, but in rare cases, it can be permanent. So you need to be sure that that is part of your informed consent. Also, if your patient has cataracts, there's a very good chance that hyperbarics is going to speed up the growth or the maturation of the cataracts, and they'll need to be fixed sooner than they otherwise would have. If you do not have cataracts, hyperbarics is not going to give you cataracts. Central nervous system oxygen toxicity. So this is the biggest concern and a fairly unusual occurrence, but we're talking about the oxygen toxicity seizure. So hyperbarics physiologically lowers the central nervous system seizure threshold. In other words, it makes it easier for someone to have a seizure. We know that prolonged exposure to oxygen under pressure can trigger that seizure. It appears like a tonic-clonic grand mal epileptic seizure, but it is not epileptic in etiology, and there are no EEG abnormalities associated with this. So there is spontaneous resolution of the seizure with reduction in the oxygen concentration and return of the patient to sea-level pressure. Now, these seizures are almost entirely preventable with a mid-treatment air break. If you're treating somebody for 2 hours at a high enough pressure, you may want to give them a 10 or 15 minute air break with a mask in the middle of that treatment, and that effectively resets the central nervous system clock, if you will, for seizure risk. Risk factors for oxygen toxicity seizures, the most common is hypoglycemia during the treatment. So we always check blood glucose levels before and after each treatment, and we don't like to let people in the chamber if their BG is less than 125, and we always encourage people to have a good meal before they come to the center for their treatment. Systemic corticosteroids and narcotic pain medications are also risk factors. Now, one very important thing that I think you may be asked about on a test. So you're supervising the hyperbaric treatment, and you see the patient go into that tonic phase of a seizure. They appear to be unresponsive, their jaw is clenched, and they're holding their breath. What do you do? The intuitive response, I think, for most people would be to grab the knobs on the chamber and urgently return the chamber to sea-level pressure. That is the wrong answer. So think about Boyle's law, and typically before a seizure, before people clench their jaws and hold their breath, they take a deep breath. So now you are at treatment pressure, you have full lungs, and your thoracic compartment, your lungs are closed because your glottis is closed because you're holding your breath. If you urgently return that patient to sea-level pressure, you will likely create pneumothoraces and end up with a very, very bad outcome. So as difficult as it is, you watch through the chamber glass and you wait until they start breathing. They'll ultimately, that tonic phase will resolve, and they'll take a deep breath, and you'll see the chest rise. That's the time that you start to bring the chamber back to the surface. Okay? We know that normal wound healing progresses through an orderly sequence of steps: controlled contamination and infection, resolution of inflammation, regeneration of the connective tissue matrix, angiogenesis, and resurfacing. We know that several of those steps are critically dependent upon an adequate oxygen environment. Fibroblast replication, angiogenesis, resistance to infection, as well as intracellular leukocyte bacterial killing. So failure to progress through an orderly healing sequence usually is as a result of one or more of those following factors, and we know that hyperbaric certainly is not magic. However, we can correct malperfusion and hypoxia with hyperbarics. Wound-related effects: improved leukocyte bacterial killing, suppression of synthesis of bacterial toxins. We talked about the suppression of the alpha toxin from Clostridium perfringens, and blunting of the systemic inflammatory response, and prevention of the ischemia reperfusion scenario. Now, that's another conversation for another day, but this is a common scenario following revascularization of an extremity, where the sudden inflow of blood liberates a number of toxins to be released from the vessel walls. We know that hyperbarics blunts that response, but the challenge, of course, is in getting a patient into the hyperbaric chamber immediately after their vascular surgery. So it's a practical enigma. Tom Hunt, Steve Tom, several others have shown us that vascular endothelial growth factor as well as platelet-derived growth factor are upregulated in the presence of hyperbarics, and there is an increase in wound fluid nitric oxide content, which we know is nitric oxide is a vasodilator. So the net effect of hyperbarics in the appropriate wound, serial hyperbaric exposures lead to improved local host immune response, clearance of infection, enhanced tissue growth, and angiogenesis, leading to progressive improvement in local tissue oxygenation and healing of hypoxic wounds. That is from the Hyperbaric Oxygen Therapy Committee Report, 12th edition from 2008. Lori Gazelle was the editor of that. We can measure wound hypoxia. We talked yesterday about transcutaneous oximetry, and so we will not go over that again. Just a reminder that normal is going to be somewhere above 40, abnormal somewhere 20 or below. Approved indications for hyperbarics, you've got all these in front of you. Certainly no reason for me to read those. So I will leave you to those indications, and certainly there is no reason for you to memorize all of them. I put this together only to illustrate where hyperbarics is useful in the wound world. Traumatic ischemias, thermal burns, necrotizing infections, compromised skin grafts and flaps, refractory osteomyelitis, and in the select problem wounds, the most common would be the Wagner-3 diabetic foot ulcer. Where hyperbarics is the primary treatment would be for air or gas embolism, decompression sickness, and carbon monoxide poisoning. Carbon monoxide protocol was written by Lindell Weaver at the University of Utah, so you can look up his protocol if you are interested. In the oncology world, we frequently use hyperbaric oxygen therapy for delayed radiation soft tissue injury, as well as osteoradionecrosis of the mandible, and sometimes prophylactically in irradiated tissues. Experimental areas, acute sensory neural hearing loss, intracranial abscess, blood loss, anemia, traumatic brain injury, and stroke. Contraindications. The only absolute contraindication at present is a current untreated pneumothorax. Relative contraindications, the most commonly cited is ongoing or recent treatment with these two chemotherapeutic agents, bleomycin or adriamycin, due to pulmonary toxicity. Also, some of the chemotherapeutic agents are anti-angiogenic agents, such as bevacizumab, and so the anti-angiogenic effect of the chemotherapeutic agent counteracts the positive effects of hyperbaric oxygen therapy. Congestive heart failure with a low ejection fraction, we have to be careful because hyperbarics physiologically is a vasoconstrictor and does slightly increase afterload, which is the systemic vascular resistance against which the left ventricle has to pump. So if someone's congestive heart failure is unstable, we can induce flash pulmonary edema with hyperbarics. So again, this is one of those areas where I will give the cardiologist a call and say, hey, how stable has this patient been? What's their ejection fraction? Do you think they can withstand a slightly elevated systemic blood pressure for 2 hours at a time? Off-label and unapproved uses. So many athletic teams have chambers within their facilities. We know that that hyperbarics as a vasoconstrictor can reduce joint swelling and can get some of these folks back on the court or ice or field sooner than otherwise. And this, of course, is Michael Jackson, a picture from the National Enquirer, and just a picture of a standard treatment protocol. Usually it takes 8 or 9 minutes to get the patient to treatment depth and another 8 or 9 minutes to bring them back up to surface level. And that's that. So let's see. I am assuming that we should do some. Oh, what about questions?
Oh, yeah, do the question.
Okay, all right. We're going to try to fly through a few questions.
There may not be any.
And there are not any questions. Question, can you define traumatic ischemias better for HBO therapy? So the most common indication, the most common traumatic indication for hyperbaric oxygen therapy will be a crush injury and in the treatment or prevention of a muscular compartment syndrome. So if you've had a crush injury of your arm or your leg and you get that intracompartmental edema and increased pressure, you can create neurologic compromise within that extremity, and hyperbarics as a vasoconstrictor will mitigate that response to some extent. And that's the end of questions. So I thank you very much for being with us this weekend and for going through and understanding our internet challenges yesterday. This is my last session of the day. So I thank you all. It's been a privilege to be with you this weekend, and everybody stay well and healthy. Bye-bye.
I'm sorry. Everything sound good now, Frank? I was just talking away to everyone, telling you welcome back. Thank you for experiencing this new experience with the virtual wound certification prep course. Lee just finished HBO. I've been watching them all morning and they have done a fabulous job. As I look at this, I usually sit in the back of the room and don't pay as much attention. And I have to tell you, sitting here and listening to my colleagues, I am also having a wonderful learning experience, and I hope the same is happening for you. So what we're going to do now is we're going to talk about psychosocial issues related to wound management, chronic wound management. We're going to roll in pain here, and then some considerations for palliative care. When we looked at the blueprint and we were deciding who was going to speak on what, a few of us, Dot, Greg Patterson, and myself, we were passionate about doing certain things. Greg wanted to do nutrition. Dot felt she should do pressure ulcer injuries. And I wanted to do the diabetes related talk. So there were some things left on the table, and this was one of them, psychosocial. And it came down to, I said, well, I think I'm the most qualified because I have 12 hours in my undergrad for psychology. However, a psychologist or a psychological expert, that does not make me. But every one of us who has ever done healthcare in general and wound care specifically, we have to, and our patients and residents have to deal with psychosocial issues. So we're going to talk about a few of those things. So when we look at some of the psychosocial aspects for wound management, it has been recommended in several sources that we formulate a plan of care, and that this plan of care is consistent with that individual's preferences, the family's abilities, their goals to support this person through this process. And as everyone on this webinar knows, this is a process. Wound healing is a process with multiple parts to get it all to pull together. So all individuals, the recommendation is that all individuals undergo a psychosocial assessment to help determine their ability to be motivated, to comprehend, and to adhere to some pretty strict parameters for getting this wound to heal that we're giving them to do. So we want to include in our psychosocial assessment their mental status, their learning ability. Everyone learns differently. I'm a kinesthetic and a visual learner, not so much auditory. And I was worried about this platform being a visual and kinesthetic learner. Would it translate well for the volume of information that we're trying to share with people? And being on here for the last two or three weekends ago, and then this weekend, I think it does work for someone with a learning ability that may not just be auditory. What about this person's social support? Do you, on intake, discuss their social support, particularly if you're having to change their work parameters or their ability to function the way they normally do, particularly with walking issues? What about their pharmaceutical issues or pharmacology issues related to over medications? We have some patients that shop docs or shop practitioners. I'm going to go to this doctor because I need this medication, and this doctor gives me this medication. And sometimes they're seeing different specialists, and different specialists have them on different medication regimes, and the practitioners aren't speaking, and the patient thinks, well, my cardiologist gave me this and my wound care doc gave me this, and I'm supposed to take all of it. So there needs to be oversight for the drug-drug interactions, which I'm sure all of you are doing. Do they use alcohol? Most people say if they use alcohol. These days, they'll even let you know if they use marijuana. They're not going to let you know if they use other illegal drugs or even some legal drugs that may be abused. So we have to take that into consideration. So what is this person's goals? What are their values? What is their lifestyle? Sexuality can be impeded related to having wounds, particularly if the wounds smell. Your partner may not want to expose their partner to this smelly wound. Their culture, ethnicity might make a difference. And then there are different stressors, and people respond differently to stress. Everyone has stress in their life. If you're a functional human being, you have stress in your life. You respond to it differently from your child or your husband or your friend, and so do our patients. There is something called the patient-reported outcome measures. And what this is, it's a methodology for assessing and reporting on an individual's perspective. This is their perspective. It's not your perspective, my perspective. It's the individual's perspective on their own health and their illness. And what you're looking at is you're measuring any aspect of that person's health status that comes from the patient. And it's not our interpretation of that information. We don't say, oh, you shouldn't feel that way. You should feel this way. They feel the way they feel, and they may be communicating that to you. And your job is to embrace how they're feeling and to try to discuss it from their perspective. So what we're doing is we're having a focus on person-centered concerns. There are different types of short questionnaires that you can use, or maybe you have a checklist of yourself for yourself as a practitioner or a clinical professional, looking at how these people cope with some of the issues around their wound. There's something, for instance, in long-term care, it's called the minimum data set, MDS 3.0, which we use for reporting an enormous amount of information to the Centers for Medicaid and Medicare Services related to that person's health, including questions related to their own perception about their quality of life. So the health-related quality of life is the impact of health and or illness on physical and social functioning, and it's also a psychological perspective. How does that person feeling emotionally? It takes into the consideration of objective functioning. How well do they move? How able are they to do their activities of daily living, as well as their subjective well-being, which is the emotional side. So it's complex, it's multidimensional, and it's more than just the absence of pain. Price said that the health-related quality of life is the impact of disease and treatment on disability and daily living, are as a patient-based focus of the impact of their perceived health state and their ability to lead a fulfilling life, which is what we all want, is the ability to lead what we perceive to be a fulfilling life. Franks and Moffitt said that the state of ill health may be defined as feelings of pain and discomfort are a change in that person's usual functioning and feeling. So the reason this is highlighted on my exam 10 years apart, there was a question, and I thought it was interesting the first time, and then I smiled the second time. It was related to, the question was related to that, is it the clinician's concept of that person's health-related quality of life that's important, the family member, but the answer was, it's the patient's own sense of well-being, which is important, and not the practitioner or the clinician's opinion about that person's clinical status. So if that comes up again, I wanted to remind you of that. So some of the other things that we want to look at for when we're thinking about someone's emotions and their activities of daily living and their usual functioning. There are other things that affects a patient's response to their wounds, such as what's the etiology of this wound? How prepared are these people to take care of these wounds? Is it visible, or is it under their clothes where no one can see it and they won't get a negative response from others? Is there pain that is associated with this wound? Does the wound have odor? Does it have leakage or stripe through the dressing that might get on their clothes, and that's going to impair their perception of their quality of life? Some of the first things that when we do this course previously, and I can't do it right now, and so I'm going to ask you, and in your mind, answer this for me in your mind. What is one of the first questions when you're assessing someone's wound? What is one of the first questions that they want to know? The usual answer is, how long is this going to take? How long is it going to take for my wound to close? And we want to be careful when we answer them and let them know that we need to get through the assessment process. We need to do our evaluations, and then perhaps we can set up, based on your findings, what type of time trajectory you may have for giving them an answer to how long is this going to take. What is the significance of this wound in their life? What has changed from their activities of daily living, for them to be able to go to work, for them to interact with their children? Maybe they have children that do a lot of sports. How do they support those children? Can they get there? Spirituality is very personal for every person. And for many people, the spiritual component is a quality of life perspective for them. So they may have people that they want to pray for them or sit with them. So spirituality can be a quality of life issue for some patients, and they want the spiritual support. What about social support? This is a big deal. Who is helping these people socially to get to their to their appointments with you, to help them get their dressings. If we're not providing the dressings, how are they getting the dressings? How are they putting them on? Can they reach that part of their body to put their dressings on? And a lot of times it takes social support. Maybe there's someone in the neighborhood. I've been known to go change dressings for my friends and neighbors in the neighborhood because there was no one else to help them with their dressing changes. So we want to know what type of social support they have to ensure that they can follow through with the request that we give them for care. Gender and age could also be perspectives that need to be considered. Some of the psychological consequences related to wounds, and if any of you have had any psychological consequences related to COVID-19, and I have had, I'm a very social person and I've been isolated and I haven't been on the road. And so I've had some anxiety, some depression, some social isolations, and that's not even in the presence of a wound. And all of this will have a negative impact on a person's quality of life. So if some of you have felt yourselves being a little bit emotional, don't be concerned. It's normal when we have been isolated from what we are used to doing and what's normal for us. And this happens to what you may be feeling. You might be able to interpolate that for something, a similar feeling for what your patients feel when their life is disrupted by a chronic wound. They may have embarrassment because of the wound odor or where it's located and people can see it. And they may also, some of these wounds, particularly when we have things like lymphedema, where they have a negative body image. We're going to shift to pain now, and we're going to talk about pain in people with chronic wounds. So my son, I have a son who is minimally brain damaged, and he's taught me some of my greatest lessons in life. And one of the first important lessons he taught me is pain is what he says it is. I think he has a low pain threshold, but it's his pain threshold. And that's one of the lessons I had to learn. Same thing for our patients and residents. Pain is what they say it is. In one particular study that was done, 88% of the people with pressure injuries responded that they had pain during dressing changes, whether that was a partial thickness or a full thickness wound. They reported pain. And then also in the study, this is with dressing changes. And in the study, they also reported 84% reported pain at rest. So they know they have this hole in their body and it is concerning them. And some of that concern could be interpolated into pain. So what is wound-associated pain? Now, I've highlighted two things for you, the nociceptive pain and the neuropathic pain. You may see a question on this on an exam in the future. So nociceptive pain is ongoing activation of some primary afferent neuron by some noxious stimuli. Neuropathic pain, on the other hand, is caused by a lesion or dysfunction of the nervous system, and usually by a primary lesion of an afferent nerve in the periphery, usually. So we have our nociceptive pain and our neuropathic pain. The neuropathic pain, my grandmother described her neuropathy related to her type 2 diabetes as I feel like I have ants crawling on my feet. And then she would talk about stabbing that she would feel. And then she told me, she said, Pamela, my pain related to my neuropathy and diabetes is much better. I don't have pain anymore. Did she not have pain anymore? No, she had complete loss of sensation at that point, but to her, it was better. So we can have these different descriptions from our patients and residents related to how the pain feels from neuropathy. Shingles is very painful. Anticipatory pain, as a result of a negative experience, and I'll give you an example. I had some important dental work that I had to do. And as I was sitting in the dental chair with my periodontist, I said, well, I'm having a little discomfort here. And he says, oh, okay, let me give you some more medication. Takes that needle, sticks it up in the top of my roof of my mouth, did not put lidocaine on, and shoves that needle into my mouth. And of course, I came out of that chair. I do not trust this practitioner anymore. And we will always make sure that we put on the lidocaine before we do the injections. He thought I was partially numb, but didn't check it before he did the injection. So these are some of the things that you want to be careful with your patients and residents when you're doing something that could cause pain, such as a debridement. That could be one of the ones we might see. So there's something called the chronic wound pain experience. Dr. Diane Krasner did her dissertation for her nursing PhD in chronic wound pain. So this information came out of Dr. Krasner's dissertation, and we brought it into the wound world, and we still use it today. So there are several different kinds of wound-related pain that a patient or resident may experience. It can be chronic wound pain, cyclical wound pain, or non-cyclical wound pain. So this chronic wound pain is background pain. There's nothing going on. The patient's not being moved. You're not manipulating the dressing or the wound in any way. And the person is having background pain. It can be continuous or it can be intermittent. So we want to document, are they having consistent chronic pain? Then there's cyclical wound pain that's caused by something that you do more periodically, such as the dressing change or maybe turning and repositioning. And this is called cyclical wound pain. And this is the most common type of wound pain. And then we have non-cyclical wound pain that's provoked by some more sporadic procedures. Maybe debridement would be an example. You might do debridement on Monday, but you don't need to do sharp or surgical debridement until the following Wednesday. So it's PRN. We do debridement PRN in general as it's needed. These two authors talked about managing the pain by eliminating or controlling the source of pain, such as covering the wounds, particularly covering the wounds that are partial thickness wounds, maybe adjusting the support surface and repositioning the patient. And so one of my questions for you is, how many of you use analgesia before you do some type of debridement or even the dressing change? And usually, and as I travel the country, I teach thousands. I have the honor and the privilege of teaching thousands of nurses in long-term care, some physical therapists, some physicians in long-term care, but it's mostly nurses. And almost all of my nurses talk about how they pre-medicate their patients and residents before they do a dressing change. And most of the practitioners I've spoken with over the years also pre-medicate before they do any type of sharp or surgical debridement. There was a multinational survey finding that talked about when the most pain was experienced by patients with chronic wounds. And this survey found that the time of most of the pain was during the dressing change. That's when most people complained of pain. And the study went on to talk about how dried out dressings and adherent products are going to most likely cause more pain during the dressing change. And then it talked about how soft silicones, and we have really come into an era of using silicone dressings. Even some of our tapes that we're using, some of the adhesives have silicone, and they're much gentler, particularly to fragile skin, that very young neonatal skin and the very older fragile skin that's so at risk for skin tears. So the National Pressure Injury Advisory Panel had a statement that said that we should select a wound dressing that requires less frequent dressing changes and is less likely to cause pain. So some of the consequences of pain related to wound healing and quality of life, but some of the consequences of pain. Here's a statement from Carolyn Moffat out of England, and it says, it's well known that pain during the dressing change has a direct effect on the quality of life, which can lead to depression, loss of appetite, and sleeplessness. In addition, stress and anxiety increases the cortisol level. If you've ever had a cortisol response in your life, anyone on this call or on this webinar, have you ever had stress in your life and you weren't eating all that much, but you're putting on weight? That is a cortisol response. So this cortisol response, in addition to putting on weight, can lead to an immune system dysfunction and delayed healing. So deterioration, according to this article, and the quality of life has also been shown to increase vasoconstriction. And we know what systemic vasoconstriction does. It decreases tissue perfusion, which will retard our healing rates. Now we're going to move a little bit. We're going to go towards the Joint Commission now. And I will tell you, for long-term care, pain management is a huge component of the survey process. Those surveyors are going in and they are asking the residents in those buildings, do you have pain? When do you have pain? What causes the pain? And what is the staff doing for your pain? These patients are asked these specific questions. In addition, the Joint Commission, which is for acute care primarily, and many of you probably work in Joint Commission facilities that are reviewed by Joint Commission, they, in 2018, they established some criteria related to pain management. And this came out of our opioid epidemic. That's what pushed the Joint Commission to recommend these particular criteria. So it talks about leadership. So they want clinical leadership related to writing the policies and procedures and looking at how the pain management for our opioid crisis is done in the facility. They want the medical staff and the hospital leadership to improve the pain assessment and management processes in the hospitals. They want us to provide at least one non-pharmacological pain treatment modality. So it's not just giving pain medications, it's also looking at what we can do to modify the pain response without pharmacology. One of the ones I recommend is music, soothing music. Music changes brain function. So one of the things you might do in your facility, and I live in Texas, and we have a lot of great Texas country western music, which is good oftentimes, but I would recommend that you do some of the lower key music, spa type music, rather than rock and roll or music that's really up. Whenever you go to restaurants, for instance, the restaurants move you through their busiest times of the day by playing music that is faster so that you will eat faster and get out and clear the table so they can get the next people in there. So think about music. You want to, the Joint Commission says that we should have a prescription drug monitoring program. So I suspect everybody on this call, if you are a prescriber, that you are having your medications viewed by someone at your facility with some oversight. They also want us to have our patients to be engaged in the decisions about their pain management and to assess their education and engagement. You want to look at their storage and disposal, particularly of opioids, and you want to make sure that these things are not stolen or misused by other people. We should facilitate a referral process. There should be a referral process for patients who are addicted to opioids. Hospitals have to have a process to address the pain assessment. They have to have a process for clinical determination to either treat or refer the patient for pain treatment, which may include non-pharmacologic or pharmacologic approaches. And there needs to be a process for the clinician to reassess and respond to a patient's pain based on your reassessment criteria. So what this is, when we think about pain, it's more than a number. It's more than 0 to 10. There are so many other aspects to it. So several years ago, I had found the PQRST related to the characteristics of pain and brought that into the course, in case you haven't seen it, to look at a more robust approach to assessment of the pain that a person's experienced. So let's look at this together. So P stands for palliative or provocative factors. What makes the pain worse? What makes it better? Is it a movement situation? Do you lay down and it makes it better? Is it an offloading situation? So what makes it better? What makes it worse? Try to get an answer for that. Quality, describe the pain. What is it burning? My friend in my little village where I live in Texas in the hill country called me the other day and he says, I told you about this yesterday. I'm having burning of my feet. And the doctor told me to watch my sugar. The doctor didn't tell him he had prediabetes, but that was what he was saying. I'm having burning of my feet. And that was his symptom. I told you about my grandmother talking about the ants crawling on her feet and the stabbing. So what is the quality of pain? Have them describe that as best they can. Where does it radiate to, or does it radiate? Does it stay in the same location, or does it move? And if it moves, where does it move? The S component is the severity. There's our 0 to 10. One component of this, at least 1, 2, 3, 4, 5 parameters. One is our 0 to 10. What's the severity on a pain scale? And then temporal factors. What makes it better? What makes it worse? Is it a time of day thing? My pain is worse when I have my chronic hip pain. It particularly gets worse with a lot of flying. It's worse every time at the end of the day when I'm getting ready to go to bed. Is it intermittent? Is it constant? Does it occur only with movement or activities? And what kind of activities or movements exacerbate the pain? So we want to have a more thorough description of pain so we can address the pain management interventions. Here are some of the different pain assessment tools that you might use: a visual analog scale, the 0 to 10 pain scale. Now the Wong-Baker are FACES, and FACES is actually an acronym also. This scale was originally created for children who could not count and couldn't say, my pain is an 8. So they created this 5 scale, 1, 2, 3, oh, I'm sorry, 6 scale, faces scale for children to point at where they feel their pain on this continuum. This information was taken from pediatrics and brought over into adults with mild to moderate cognitive impairments of these people who cannot remember how to count for whatever reason, and has been validated. So the Wong-Baker Faces Scale is validated for children and for older adult with mild to moderate cognitive changes. And the star is there and it's in green to let you know that this potentially could show up on board examination. So you want to also look at someone's body language. You want to look at nonverbal cues. This can give you a lot of information. If they're frowning, grimacing, or fearful, we had a patient in the long-term care facility who was not able to speak, and she was grinding her teeth. She ground her teeth to the point where she lost one of her gold caps, and actually she was bedbound, and it came out in her excrement. They found the gold cap. And the nurse went back to the family and finally asked, does your mother usually grind her teeth? Is this something she's done in the past? And I was really proud of that nurse for thinking to go ask that. And the answer was no, she's never ground her teeth. She didn't grind her teeth sleeping that we know of, and she doesn't grind her teeth. So what do you think that grinding was about for this person who cannot speak? It was her interpretation or her expressing that she was in pain, and it was completely missed on the assessment process. What about bracing or guarding or rubbing? Sometimes I'll rub my hip. I'm not sure if it's going to do a lot of good, but it feels good when I'm rubbing it. Fidgeting or increasing recurrence of restlessness or striking out. We have patients and residents sometimes in long-term care that can't tell you to leave me alone, and they will strike out at you because they are in pain. And when you reposition them, even though it's necessary to prevent pressure injuries, when you reposition them, they are made uncomfortable with the repositioning process. So it's not that they are mad at us, it is that they don't want to move, and they don't have another way to tell us this. People will see decreasing activity levels when I'm working with and teaching the CNAs, the nursing assistants in long-term care, related to wounds and relating to prevention of pressure injuries. And sometimes I have the privilege of teaching our CNAs also. We talk about some of the things that they may see that the nurses don't see. The CNAs see it first. They begin to see the decreasing activity levels first. They see resisting certain movements first during care. They see changes in behavior first. So in our care setting, in long-term care, our CNAs are precious to us. As a matter of fact, I am going to say something that I think that anywhere from 40 to 60% of the prevention program for somebody that is immobile is dependent on savvy CNAs, and would really like to see us beef up our CNA education for the long-term care setting, and maybe even for home health. So, and all of this can lead to loss of function. So we need to plan for the pain. When you're going to do something like sharp debridement or a dressing change, and you know that's uncomfortable for that particular person, we want to ensure that we pre-medicate. I am a physical therapist. I cannot give oral medications or injectable medications. I can put on topical medications per my state practice act in Texas. So I can do something for the pain topically. However, if we need to do it systemically, I rely 100% on my practitioners and my nurses. My practitioners to recognize which pain medication is going to be used and to order it, and my nurses to give it at the appropriate time. We have to partner. I can't have them give that medication 2 hours before I'm going to go in and do debridement, and neither can you. We have a lot of physicians and practitioners, nurse practitioners, PAs, that are coming into our buildings, and they're called practitioner groups, wound care groups that come into our building. They can't just show up and say, roll over and let's do debridement. The medication that that person needed before the debridement process, or before even the dressing change, when the practitioner looks at the wound, needs to have been put in place before the practitioner gets there. They go from building to building to building. If you are a practitioner coming into our long-term care buildings, are you coordinating with the nurses for that particular patient or resident to ensure that they're medicated before you come in to do your interventions? Outpatient wound care centers, you probably don't want to tell your patient to take their pain medication before they get in the car and drive to you. You might want to ask them to bring their pain medication, get there 30 minutes early for their appointment, take their pain medication while they're sitting in there, and hopefully 45 minutes to an hour when it's peaking, and you get them in the room, then they will have good coverage for whatever interventions you're going to do in the outpatient clinic. So we really need to plan for the pain, and we need to make it a team effort also. The World Health Organization's pain relief ladder, all of you know this. This model was originally developed to treat cancer pain, and it was successfully applied also for other patient populations, including those with HIV and AIDS, and has been suggested for people with wound-related pain. You know this. I'm not going to teach you this, but I just wanted you to look very briefly at where we go for using our non-opioids, the mild opioids, and the stronger opioids, if necessary, to try to provide freedom from pain. And I'm hoping that our opioid epidemic does not set up a crisis for people who really need this pain medication and they are having problems getting it. There are people who need their pain medication to have a functional quality life. Some of the other non-pharmacologic interventions is one of the top things you want to do. As a matter of fact, if you're going to take your test, and when you look, part of your self-study is going to be on test-taking strategies, which is at the end of the program. There's a module on test-taking strategies. And one of the things that you want to remember when you go in to take that test, and one of the things you want to work with your patients and residents on, is deep breathing. Everyone's sitting there, or if you want to stand up, either way you want to do it, sit there and we're going to take 3 breaths together, 3 nice long breaths together. So please do this with me if you would like. So here we go. 1 deep breath here. And exhale. Inhale. There is a point to this. And exhale. One more time. Inhale. And exhale. Can you tell? You just lowered your heart rate. You just lowered your blood pressure. You just increased your systemic oxygenation a little bit. And do you feel a touch more relaxed after 3 deep breaths? This can be very important to your patients and residents when you're trying to work with them. You might want to give timeout breaks. Give the patient control. I learned this with Dottie. This was the wonderful thing that she taught me. Give the patient control over the process, particularly something like debridement. Let them know that you're going to stop when they ask to stop. It may not be pain related. It may be anxiety related. Also, you might distract them. I love to tell stories, and I love to listen to people's stories. And so sometimes we're telling stories to each other. Music, I mentioned music to you. And also, one of the greatest gifts that you can give anyone, particularly your patients and residents, is rapport. You want to connect with them and show them empathy. Show them your compassion. We have to do this. We understand that this is very difficult. It's difficult for all of us. And have that rapport and empathy, and that will help to calm them so that they can get through the procedures that you need to get them through. Your clinician-patient relationship, their first visit is important. When you get ready to walk in that room, no matter if you're 2 hours behind, you don't want to throw open the door and rush in the room with the chart and say, blah, 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 blah. The first visit, no matter what's going on in your office, in your building, in your hospital, that first visit is critical for establishing the rapport that you're going to have with that person from then on. It's very hard to recover from a bad first impression. You want to involve that patient and maybe their family in that plan of care from the beginning, including dressing choices. And Dot's talked a little bit about dressings and how are the people going to get these dressings. And she's going to talk to you some more about that after we do debridement. You want to evaluate how the patient copes with that stress and anxiety that we talked about earlier related to the wound. You want to assess, again, their social support and their and identity opportunities for support groups. Maybe this is someone that has had radiation for some reason. Perhaps they have had cancer. Are they in a cancer support group? Are they in a wound support group for people that have had radiation injuries? So you may have a list of support groups that could be helpful. But the most important thing to establish that client-patient or clinician-patient relationship for it to be successful, the first thing, it starts with your first visit in establishing your communication and your rapport. Now we're going to shift to palliative care. When we think about palliative care, it has 3 components to it: physical, emotional, and spiritual. And when I say spiritual, not every person in the world has a religion, but they can be spiritual. So you may not belong to a religion, but you're still a spiritual person. So the goal for people with palliative care may not be wound healing, but you have other goals that you can write in your goals for care. So when we have chronic non-healing wounds, such as malignancy, particularly malignancies that are growing, that they can't be treated, or you have someone that is immune compromised, or for whatever reason, there's a certain group of people, usually older, not always, but usually older, that have the inability to muster the energy to heal their wound. Everything is in place. Nutrition, hydration, the absence of infection, everything's in place, but for some reason, the body will not respond. And we don't know the answer for that sometimes. So in these cases, the key objectives that you might have would be pain management. That's at the top of everybody's list. Prevention of infection, perhaps trying to prevent the wound from deteriorating. We are trying to do that. Odor control is another big one. And I'm going to give you a quick story. I was teaching debridement quite a few years ago, and there was a nurse who came in and she brought a photograph, and she brought the photograph of this gentleman who had a dressing on his neck. And she tells the story that his wife, he would not allow his wife to come in the room because his wound smelled so badly. It was a fungating wound from cancer, from throat cancer. It smells so badly. It's one of those wounds that you smell outside the room with the door closed, that he was so embarrassed and concerned for his wife that he wouldn't let her come see him. And it was devastating to his wife. She wanted to be there with him and to support him. So this nurse, this compassionate nurse, I always cry when I tell this story. I'll try to be good. This compassionate nurse cleaned the wound up as much as she could. Then she took a charcoal filtered foam, because it was heavily exudating, put the foam on, got an ABD pad, put his wife's favorite cologne on the outside of the ABD pad and put that over the charcoal impregnated foam. And he could now smell his cologne and not his wound. And he allowed his wife to come in and be with him as they went through this difficult time. One of my favorite stories of all time. And then also we want to, one of the key objectives, particularly in wounds that could be fungating or they could be infected, managing the exudate. So palliative care, during palliative care, our patients and our residents will often require higher levels of analgesia to help control the pain, specifically for these fungating tumors as they grow in size and in depth. And in that case, just as with the nurse that I mentioned to you just a moment ago and her creative dressing, it may be a creative dressing that helps to alleviate the pain and suffering. And in this particular case, with this particular couple, the husband with the wound and the wife who wanted to be with him, it was a form of pain. It was psychological pain. And she was grieving because she could not be with her husband and support him through his dying process. There's something called skin changes at life's end. And I do believe that Dot has already mentioned this. This is was a panel that came together in 2008. Dot was on this panel also, and they talked about the nature of skin changes at life's end. That's where the acronym SCALE comes from, which includes the kidney terminal ulcer, the unavoidable pressure ulcer, skin failure, all of these, the Trombley-Brennan terminal tissue injury. So all of these are grouped in skin changes at life's end. We don't fully understand them because there seems to be different mechanisms of injury when this is happening. But the unavoidable pressure ulcer versus the kidney terminal ulcer versus the Trombley-Brennan terminal tissue injury. With that said, skin failure is a multifactorial process that is directly related to the function or dysfunction of other organs. One of the things I tell my nurses in long-term care when they're doing their head-to-toe skin assessment, one of the most important things they want to do if that person has a chronic wound is they have cardiopulmonary issues, one of the things you want to do is look at systemic oxygenation. Are these people desaturating? What is their pulse ox level? When the pulse ox diminishes and the systemic oxygenation diminishes, and we're in a room in a long-term care facility and there's no HBO therapy, that wound is going to be negatively impacted from systemic oxygenation, not just local oxygenation. So here we have a multi-organ situation that is affecting the wound healing outcomes. So similar to other organ failures, sequelae such as heart failure, kidney failure, the skin failure barrier can be classified, the skin failure can be classified as acute, end stage, or chronic. There's no linear, that's why this is set up as a triangle and going from one to the other. There's not a linear progression for many types of organ failure. Chronic organ failure, in this case, we're talking about the skin. In this case, we're talking about the skin. Can happen with chronic illnesses. It happens with older populations, with multiple comorbidities, with decline in mentation. Some people don't realize that dementia is a risk factor for a pressure ulcer that needs to be on. It's the Braden and beyond. You have to look at the 100 comorbidities or 100 causes for pressure injuries. It's not just the 6 things that you see on the Braden. If you only rely on the Braden, you will always, always underestimate the risk for a pressure injury. The person has decreased functional ability and malnutrition. So these are some of the risk factors for chronic skin failure. Some of the physical manifestations may be loss of fat and muscle mass, decreased mobility. Watch that mobility. Have someone really watching mobility to see if it's beginning to decrease. This is why my CNAs are so important in the long-term care setting. Some of the other physical manifestations are the skin and underlying tissue changes that you might see. So skin failure is defined as comorbid conditions combined with degeneration in the individual's overall function, layered on top of age-related decline, all contributing to the acceleration of loss in function in the end stages of life, which in turn contributes to chronic skin failure. Some of the things that you might see as the person's body, the entire body, when they're going into multi-organ failure, some of the things you may see on the skin is, for instance, this modeling that we're seeing on the right. So some of these early signs of vascular compromise, which ultimately can lead to collapse, such as this mottled discoloration that we're seeing. And what's happening is, when we're related to skin failure, what's happening is the body is trying to keep the person alive. So the normal protective function is to shunt blood from the extremities when there's cardiovascular particularly issues, and certainly the other organs also, to shunt the blood from the extremities to the central system to keep that person alive. And so that's where you start seeing the blue toenails and this modeling effect that you're seeing during critical illness or disease states. And this helps to avert immediate death. So this chronic shunting of the blood to the vital organs can also result as a result of limited fluid intake over a long period of time, which is another issue in our care setting. As we get older, our thirst mechanism begins to diminish, and we don't even realize we're thirsty until we become significantly dehydrated. And again, this is another thing that I teach my CNAs. We really need to look at intake output, of course, but what's going on, we need to document almost every time that they have their fluids. And is that changing? Do they not want their juice anymore in the morning? Do they not want their coffee anymore? Do they not want their tea? Have they stopped drinking as much water? And it's my CNA who helps to determine this. So in summary, the patient-reported outcome measure questionnaires and the health-related quality of life is from the patient's perspective to help the healthcare providers to frame a plan of care that puts the patient in the center of that care plan, ensuring that the care plan is consistent with the individual and family preferences, their goals for care, and the patient's physical, emotional, cognitive, social, and financial abilities. Thank you, ladies and gentlemen. And what do you want me to do now, Frank? Are we going to go right into debridement? Are we going to let him have a break? Continue, he says. My husband wishes I minded you as well as I mind him as well as I mind you. All right. So what we're going to do now is, and we may have some questions. Let me see if we have any questions. Questions first. All right. All right. Let me see. Dottie, are you going to read the questions to me? Well, here, I think I can get them. Hold on. All right, here we go. Let me get down here. So here we go. All right, here we go. Frederick, let's see. Have you noticed any long-term care facilities actually administering an MDS survey to any of your patients? I haven't, but in our buildings, the nurses that work there have seen them do this. They have gone into the room, talked to the patient or the resident, and also talked to family members, which is part of the instructions that the surveyor, the federal surveyor, is given to do. It's actually a state surveyor, but the survey process is overseen at the federal level. So yes, I haven't seen it personally, but I do know of nurses who have told me that they had the surveyor go into that patient's room that had the chronic wound to ask about the quality of care that they were receiving. And usually it's around pain. A lot of it's around pain. Additional option for PTs to treat pain from CDC guidelines 2016. Additional options for PTs to treat pain. I need a little more clarification on that. If you'll give me some clarification. I mean, we can do things like, there's something here further below that says topical covered ice works well. It does for a procedure. And this person's found that it worked great. And how would you measure the wound to bill for debridement? We're going to talk about debridement in just a second. So that's going to come next. And do you measure length? And another question is about debridement. Let's see. Oh, and then there was a question earlier, and we'll talk about this, and let's come back to this, Kimberly, about whether the physical therapist can do silver nitrate with a prescription. I'm just going to go ahead and say I've done it in Texas. Absolutely. And is it billable by PT, or is it a physician-based code only? I don't know the answer to that. All right, here's a question. As a PT, how do you decide when to keep an outpatient that is not healing versus continue to provide palliative care that includes selective debridement as tolerated to avoid recurrent infections to keep the patient out of the hospital? Heather, this is a long-term patient. I've referred to multiple doctors that cannot heal her of her bilateral venous ulcers. Okay, so it sounds like you've got to find a Dr. Rutsey or somebody on this call that really understands chronic wound healing. Maybe these are wound care physicians. I don't know, but venous leg ulcers with appropriate care and the bioburden being addressed and compression being addressed and the patient being consistent with their compression should heal. So you've got to find out why these wounds aren't healing. Heather, that's number one thing to find out. And how do you decide when to keep? So this person is coming to outpatient. You're helping to do debridement, selective debridement to help avoid recurrent infection. That's great. That's what needs to be done. But you have to figure out, why is this wound not healing? That's where you would start. And then the decision would need to be collaborative between you and the practitioner and the patient. That's the best answer I have for you. Dr. Lee, if you want to weigh in here, please do. All right, let's see. How are we doing? Questions first. All right. All right, here we go. Now we're going to go into debridement. This is another one of my favorite. This is another one of my favorite talks, actually. Is my camera too high? Okay, I know my ball sinks down. I sit on a ball, in case y'all can't tell. I sit on a ball, and after a while, it seems to sink. Not that I get heavier. I'm sure that's not it. Thank you, Frank. All right. I'll bring this over here so I can see. I'm trying not to look at myself, so I move that out of the way. All right, debridement and wound care. Debridement is a standard of practice. A lot of the debridement guidelines that we have are based on best practice. Some of it's based on research, and we're going to talk about that, as much of the research as we can. So when we think about, please don't be on. I've taken this out of this talk several times and it's back in. I don't know what to do. I can't take the noise out now at this point. So I profusely apologize to you. There's going to be some noise. I used to have this in there to wake people up. You don't need to be awakened, I hope. So I apologize. All right, necrotic tissue, what does it do? Let me just go ahead and get through this. There we go. It provides a medium for bacteria to grow. The necrotic tissue, it causes endotoxins to be released, which inhibits the migration of the cells that we need for wound closure, the keratinocytes and the fibroblasts for our granulation tissue formation. The necrotic tissue causes this prolonged inflammatory response that keeps going on and on and on. We're talked about the cytokines, even the cytokines related to this cytokine burst related to COVID-19. The other thing that necrotic tissue does is it blocks the cell receptor. So you have a growth factor. Here comes the growth factor. Here's my cell back here. Here's the receptor. But I have necrotic tissue over that receptor. So the growth factor is not going to be able to interface with that cell to tell it what to do. So we have to, and there's microscopic and macroscopic necrotic tissue, and we have to get rid of both. So when we look at wound closure and healing, it starts with wound bed preparation with you can use TIME, T-I-M-E, or DIME, D-I-M-E, and recently 2 other letters were added, the R and the S related to repair and regeneration and the social factors. So this is an article that came out in the Journal for Wound Care in 2019, and I'm giving you that information in case you want to get this study and read it and change a little bit how you set up your wound closure and healing related to wound bed preparation. So the wound bed preparation model is dependent on both effective patient assessment and effective wound assessment. So we have to look at the whole patient, not just the hole in the patient. Carrie Sussman, 1999. So we want to integrate our wound bed preparation components into the overall care that looks at the other aspects of this person's treatment. It looks at the medication. It looks at the nutrition. It looks at their mobility. For example, here you go underneath, venous leg ulcers are not going to heal without compression. You can, and you have to watch your patients because sometimes they'll say, yes, I'm wearing my compression, but they're only wearing it when they come in to see you. So, and they're going to say what they're going to say. There's nothing you can do about that. Diabetic foot ulcers. If we have diabetic neuropathic foot ulcers, they're not going to heal without offloading and without successful management of their disease state. We have to have good blood glucose control. So what we're trying to do when we do debridement is to reduce the bacterial load, to reduce the risk for an infection, to decrease the production of those matrix metalloproteases. Dot talked to you earlier about matrix metalloproteases. We have several different types in the body, and they are doing what they think they're supposed to do. They're cleaning things up, but they're being overstimulated by that chronic wound milieu. And we have this overproduction of these matrix metalloproteases that literally damage some of the cells that we need for wound closure. The debridement stimulates the production and the release of growth factors from the cells. We actually have evidence for that. It exposes the receptors on the cells I just talked to you about, providing for that growth factor interface. Debridement helps to remove the unresponsive, also known as senescent cells. Senescent cells are still technically alive, but we think they're in the process of dying because they're not functional any longer. They're not growing. They're not dividing. They're not moving. I call them cells on hospice because they are probably in the dying process. They're senescent. They are not functional, and they do not lead to healing. You want to do good debridement before you put on any type of cellular or tissue-based product or some of the advanced dressings such as collagen. You want to have a really good clean base before you put on these expensive products. First of all, because of cost, or maybe second of all, because of cost. But first of all, it's not going to work if you don't have a good clean wound bed. And also, before you can determine the depth of that wound, how deep is that wound? Well, you want to be careful, and Dottie calls it the true depth. And I've been using that. I've been hearing it and using it more and more. When we record the depth, many people are recording the depth on top of necrotic tissue. Now, in long-term care, when my practitioners are coming in now, they're measuring their wounds twice. They measure their wounds before they do the debridement, and they measure their wounds after they do the debridement. Doesn't mean they've gotten down to the true depth, the base of the wound, but it does mean that they were able to see that the debridement process is what made it worse, and it was not made worse by the practitioner doing the intervention. The depth was not made worse, which can be a problem if the surveyor is only looking at the wound notes and they're seeing in the notes that the wound is getting worse. It is important that they see that it's not getting worse, that we are having less and less necrotic tissue. So you want to be sure if you're coming into our care setting that you do your documentation to reflect that for the survey process. In addition, when we do good surgical or conservative sharp debridement, it often renews the acute inflammatory phase, takes the wound back to the beginning of the inflammatory phase. Wounds are traditionally, our belief is that they're stuck in the latter part of the inflammatory phase before the proliferation phase. So what we're trying to do is take them back to the beginning of the inflammatory phase. In the literature, it talks about managing the underlying pathology, which we just mentioned a moment ago, is the most important first step when we're looking at wound management. If we don't manage the diabetes, then we're not going to get the outcomes that we need for that wound for closure. And Lee, I believe, and maybe Doc, they've already talked to you about pathergy. Know this word. It is highlighted. I need to bold it also. It's probably going to be on an exam that you see in the not too distant future. So pathergy is an exaggerated skin response to trauma. Any trauma, mechanical trauma, surgical debridement, surgical debridement is a mechanical trauma. So any type of trauma that is mechanical, particularly when you have something like pyoderma gangrenosum, you're going to get a pathergy effect where the wound gets larger. So when do we debride? You want to debride when there's necrotic tissue in the wound that's impeding the wound healing. It's, as I said, a barrier to, it's also a barrier to contraction. When you have necrotic tissue in that wound bed, the fibroblasts, so I'm going to ask you some questions right now, see if you can answer them for those of you who are going to take a test in the near future. What phase did the fibroblasts come in? Which phase of wound healing? What is it responsible for doing? And what does it change into to cause contraction to take place? Because it is the fibroblast that turns into the myofibroblast, myo like muscle tissue, myofibroblast, and that is the cell that causes contraction to take place. And you need good functional fibroblasts. When there's epibole at the wound edge, for all of you ladies and some of you men, I'm trying to get my 69-year-old husband to pierce his ear and he won't do it. I don't know what's the matter with him. So got my ear pierced at 16 years old. I'm headed towards 70. Still have a hole in my ear. It's called epibole. We get wounds like that where the edges of the wound roll over and they think they're finished. The keratinocyte has rolled down and around. It found the other keratinocyte and says, oh, I'm finished. And we have this big old hole in this person's body. So epibole needs to come off, freshen those wound edges so that the keratinocytes can now march across the wound. When there's sign of an unstable wound, when there's fluctuants, where it's squishy, soggy, boggy, fluctuant underneath this eschar, for instance, or advancing cellulitis or sepsis related to some type of ulcer. You want to debride when there's callus formation causing discoloration under the callus, or any time there's callus formation on the foot of a person with diabetes. And this is one of the reasons I think podiatrists are so well positioned to take care of the feet, healthy feet of people with diabetes. People with diabetes, the day they get diabetes, their feet are not unhealthy that day. Even with pre-diabetes, it takes quite a while for some of these changes to take place. And the podiatrist is one of the practitioners who can see these people and help keep their feet healthy. So I hope, and also remember, when you're taking care of one foot, you're taking care of that diabetic foot ulcer on that right foot. Remember to look at their left foot. I know you're not getting paid for that. I understand that. But look at the left foot. It is your duty to ensure that it is okay. Check the sensation on that foot. Look carefully for calluses to see if that foot also needs to be taken care of. And maybe you're not doing that as the wound care clinician. That foot's still moderately healthy, fairly healthy. Send that person to a podiatrist to help keep that foot healthy. So we may be seeing a person at the wound for the wound, and the person may be seeing the podiatrist to keep the other foot healthy. Hypergranulation tissue. Cells cannot go uphill. Doc May already told you that. The keratinocyte cannot go uphill. It goes straight across or it goes down. We don't quite understand how they move. Doc's going to talk to you about that a little bit, I think. So hypergran tissue, it's going to have to come down so those keratinocytes can march across the granulation tissue. Debris needs to come out, and you need to oftentimes expose dead space. So what is it that we want to debride? You want to debride non-viable tissue. You want to debride the bacteria out of the wound if it's appropriate. depends on your licensure, and the cells that impede the healing process, such as the senescent cells. So we're going to debride eschar, slough, callus, hypergram, biofilm. Again, we cannot see biofilm. Sometimes you can see the results of biofilm, but as Dot mentioned to you earlier, it's about 2 millimeters below the surface of the wound, at the base of the wound. You want to take out the infected tissue. You want to take out senescent cells, which you can't tell which cells are senescent or not. But you want to take them out. You want to take out the debris, scabs, or crust. And to know the difference, I had someone recently that said, oh, I have a black eschar. Well, it wasn't black eschar. It was a scab. It was not a full thickness eschar. It was a scab sitting on top of the wound that was the same color, but it was not a full thickness eschar. And then compromised or dead structures. Now, I do want to do a disclaimer about compromised dead structures. I'm a physical therapist. And I felt when I was doing my hands-on clinical practice that I needed my practitioners, even if that tendon is dead. I personally, professionally, wanted the practitioner to take out the tendon. By my licensure, I can take out things that are dead in the body. But anytime you start messing with tendons, you're going to change function. So therapists and nurses, if you are doing sharp debridement, conservative sharp debridement, you want to keep in mind what things you're comfortable taking out and those things that you feel that you need to refer to a practitioner. And it's going to be individual for everyone. It is as important to know when not to do debridement as it is to know when to do debridement. If you don't know the perfusion status in the lower extremity, don't do debridement. And I see this over and over and over in the long-term care setting. It happened with my grandmother. The practitioner and the director of nursing started collagenase Santal on a woman who is 94 years old, smoked since she was 12 years old, had diabetes for the last 34 years since she was 60 years old, and they started doing debridement on stable heel eschar on a bed-bound person. It's absolutely inappropriate. And they based their treatment protocol, including the debridement, on taking pedal pulses. Your fingers are not magic. I don't care if you do know your anatomy and physiology backwards and forwards. They were not feeling my grandmother's dorsalis pedis or her posterior tibialis. And I want you to think about for just a moment what they were feeling on this woman, because when I got the Doppler out of my car, went into the nursing home and did the Doppler, her ABI was 0.43. So were they feeling my grandmother's pulses? Of course not. They were feeling their own faint digital pulse because they had it documented as faint pulses. It wasn't my grandmother's pulse. It was their own pulses. So you cannot rely. There's no magic fingers. However, I do want to say this. Every person should have their pulses palpated. And then if you suspect something, then you're going to use your Doppler or some other type of methodology for measuring oxygen perfusion. It may not be consistent for the end of life situation. Debridement may not be the appropriate thing, or if there's poor potential for healing for whatever reason that you've documented, it may not be appropriate. Stable eschar on the heel, especially when it's vascular, there's vascular compromise. There's quite a bit of literature about this, particularly in the National Pressure Injury Advisory Panel had this to say. It says to avoid disturbing stable, hard, dry eschar in ischemic limbs and heels unless infection is suspected. And even when infection is suspected, we need to do debridement, but you're going to take off the tissue that's infected, but there's no blood flow. So you have to figure out, what can I do to increase blood flow to this wound? Remember, my grandmother had an ABI of 0.43. They had opened this stable eschar up. And now my biggest concern is, how are we going to get blood flow down there? And I have an answer that we used for grandmother that I'll share with you. And then the last bullet talks about debridement should only be performed when there is adequate perfusion to the wound. So you are between a rock and a hard place with these two statements. One says don't do it unless there's infection. But if you don't have blood flow and there's an infection, what are you going to do? Between a rock and a hard place. You need to know your anatomy and physiology. You really need to know your anatomy and physiology, no matter what type of debridement you're doing, but specifically if it's any type of mechanical, which we're going to go through, including sharp and surgical debridement. There needs to be an assessment before debridement, and apologizing ahead of time, I think there's noise. Okay, get rid of the noise. So during your assessment, prior to doing debridement, you're going to do your complete patient assessment. You're going to look at the intrinsic and extrinsic factors that may be affecting the wound's healing opportunities. You want to look at the medications, particularly anticoagulants. There was a case that I was the expert on that involved 4 nurses and 4 physical therapists in the state of Texas. And I had to find 2 of my colleagues, physical therapy colleagues, grossly negligent of their practice act because I could not tell in the documentation where they reviewed the medication sheet to find that this person who bled out and died after a sharp debridement procedure, that they did not see that this person was on Plavix, Coumadin, and aspirin, nor did they ask where the INR study was, which you would think the nurses would do, but it hadn't been done for 5 days. The INR had not been done for 5 days. And we found out after the person passed, and according to the medical record, that he was 5 times over anticoagulated on Coumadin alone. So it's very important that you look at the medication assessment, the medications for things that are going to impair wound healing, such as systemic steroids, and our medications that can complicate the wound treatment procedures, such as anticoagulants. You want to look at your appropriate laboratory test to give you a hint of what's going on in general. Do a good wound assessment and look at some of the social considerations for the patient's preferences before you do debridement. The National Pressure Injury Advisory Panel has some other recommendations that says debridement should only be performed when there's adequate perfusion to the wounds. I just mentioned that. And again, you're between a rock and a hard place if it's a heel and it's infected, and you're going to have to use your clinical judgment. If there's a methodology for you to increase blood flow, that would certainly be helpful. And I have a couple of hints for you in a few minutes. You want to perform a vascular assessment prior to debridement of lower extremity pressure injuries to determine whether arterial status or supply is sufficient to support the healing of this debrided wound. It goes on to say that you want to debride the pressure injury urgently in the presence of erythema, tenderness, edema, purulence, fluctuance, crepitus, and or malodor, which is, of course, the signs of infection. You want to debride the pressure injury of devitalized tissue and suspected or confirmed biofilm, and perform maintenance debridement until the wound bed is free of devitalized tissue and covered with granulation tissue. So these are some of the things that you want to think about. This is the simple to complex ladder related to our interventions that we can do for debridement, including autolytic, enzymatic, our maggots, your mechanical debridement, which is several different times, and then your ultrasound debridement, contact, your sharp debridement, and your surgical debridement. So autolytic debridement, we are using it's the natural degradation of devitalized tissue using that person's own endogenous enzymes, their own proteolytic enzymes. And what you see on the right is this is not pus. This is where autolytic debridement has taken place on this knee, and the person, and it looks like this, and it looks kind of ooey gooey, but we need to explain this sometimes to our patients. This is not a problem. This is this is a good thing. So we're going to use moisture retentive or moisture donating dressings to do the autolytic debridement. With autolytic debridement, you're liquefying and separating the viable from the non-viable tissue. The phagocytic activity, is supported with this moist environment. Autolytic debridement, it is conservative, it is selective. Now, selective in this context, it means that it is non-viable tissue only that is being impacted. Non-viable tissue only is what selective means in this particular situation. Not that you selected that particular tissue. Non-selective debridement means that you're going after viable and you're going after non-viable and unhealthy viable tissue, maybe tissue you think is infected. That is a practitioner intervention. As a physical therapist, even if I think this tissue is infected, I'm not going to take a scalpel or scissors or curette after it by my practice act because it is still viable. And every physical therapist will have to decide what they're going to do. And I'm pretty conservative about a lot of things having to do with debridement. You want to ensure that there's little pain whenever you do any type of debridement. Autolytic debridement, the most painful part of it is the dressing change. And it's good for slough, eschar, and scabs and crust. Now, it's not appropriate with an infection unless you're addressing the infection, either topically or systemically, or with arterial insufficiency. You don't want to start the debridement process when there's severe arterial insufficiency. And I question whether with severe arterial insufficiency, if you can even get the enzymes there for autolytic debridement to take place, and you might get some. So we want to be careful with that. So autolytic debridement, the indications are all wounds with necrotic tissue. It is beneficial for wounds covered with dry eschar. We want to cross-hatch, and I'm going to show you cross-hatching in just a moment. You do want to do cross-hatching to help facilitate either the autolytic or the enzymatic debridement process in the presence of eschar. And that's what you cross-hatch, eschar. It's kind of like tic-tac-toe. Contraindications for autolytic debridement include dry gangrene or dry ischemic wounds. You have to look at the vascularity, and you need a vascular consult when you suspect there are vascular issues. And it's contraindicated for an infected wound unless you're addressing the infection. So there are some issues with autolytic debridement that can take longer than other methods. And we have, the literature tells us if your wound hasn't improved in 2 to 4 weeks to do something different. Well, hopefully you're not waiting 2 to 4 weeks to see if autolytic debridement takes place. If it doesn't happen in 3 to 5 days, then you probably have a problem. Also, an issue could be you're putting over either an occlusive or a semi-occlusive dressing, and there's the potential for bacterial growth underneath that dressing, and particularly in the presence of the necrotic tissue. The necrotic tissue supports bacterial growth. There's the possibility of injury or re-injury when you put that dressing on with adhesive and you take that dressing off, particularly if it's macerated, if that autolytic debridement, that fluid has leaked out and gotten on the peri-wound area, has softened the peri-wound area, and now you're taking that adhesive off, you can strip and denude the peri-wound area. The person does have to have a functional immune system, and this is important to consider, particularly with our older population. As we age, our immune defenses begin to diminish, which is one of the problems with COVID, of course. So the older immune deficient patient may not get the best outcome with autolytic debridement. This is just a list of some of the different types of dressing categories that you can use for debridement. And Doc's going to give you a great talk on her topical lecture right after we finish this. Now, I just wanted to put into this talk a little bit about surfactants. We've mentioned it, and then I'm going to mention it a little bit more. Surfactants, they're widely used in detergents, emulsifiers. What just happened? Did my screen just change? Do I have the right screen up, Frank? I moved something, and I'm afraid that I changed something. Is this the right screen? Am I showing the right screen? Oh, you were correct before. Y'all excuse me. I moved something. Okay. So surfactants have been used as good, he says. Thank you, Frank. If you people in this audience, if you ever have to do a webinar, if you haven't done any yet, you always have to have a good IT team behind you. Always. You cannot do this without people like Frank. Thank you, Frank. Y'all be sure you give him a 5 on the evals. I think we need to have something for IT on the evals. So surfactants have been used in many, many things. The oil industry, hygiene products. When you wash your hair, you're using a surfactant. When you get those bubbles. When you wash your hands, you're using a surfactant when you get those bubbles. So we have some recent studies that have demonstrated that concentrated surfactants-based gels and dressings are appropriate for chronic wounds. Now, the mechanism of action, which was very interesting to me, it looks as if the surfactants help to sequester the planktonic microbe and biofilm. And Dot and Lee talked to you about the planktonic free-floating bacteria. And then once they get encased in that polysaccharide dome or slime or sludge, then it becomes the wound film. So this mechanism of action, it looks like it might help to sequester and break this up and help to prevent the biofilm reformation. It also reduces inflammation and can help with loosening the viable tissue to aid in the autolytic debridement process. Enzymatic debridement, it's gotten pretty simple from the perspective of we only have one to choose from, and that is collagenase. So collagenase is the use of a topical applied agent. One of the things that's interesting about collagenase is people talk about the expense of it, and I just want to mention this. Collagenate is a biologic. It's a biologic entity. They take the DNA of a particular bacteria, which I'll show you in just a moment, and they manipulate this DNA over months and months and months. It takes a year to make one tube of collagenase. So that's part of what's going on. So the indications for collagenase is for non-surgical patients. It's good for minimal slough, eschar if you've cross-hatched, and also if you have a bleeding risk for your patient. So the bacteria that is used, that is altered, the DNA that's altered of the bacteria Clostridium histolyticum, they alter the DNA to perfectly match the human DNA. So it's specific for denatured collagen only. The medication is hydrophilic, and there was a Dr. Falanga who did some of the early writing on collagenase, talked about it being useful for prolonged periods in wounds in what's called maintenance debridement. So some other considerations when using collagenase in the hands of a really astute clinician. Collagenase is a wonderful drug. It's a wonderful drug. But as a clinician, you need to know what you're doing and what other products you're using with it, such as silver. If you're using silver, you can decrease the efficacy of collagenase. And there is something that I want to show you. Can you see? Yes, you can see this email address right here, actually this website. You want to go here. If you're using collagenase, or you've not gotten the outcomes that you wanted to get, or you're considering using collagenase, you want to go to this website because it talks about compatibility with other products, with other skin cleansers, wound cleansers, the things like silver, how silver decreases the efficacy of collagenase, and one silver may have a more profound effect than another silver. So if you're going to use collagenase, please go to this website and read up on how to make it work better for you if you're having any problems. When you use collagenase, you want to have moisture in the area. You're going to put the collagenase on edge to edge with the entire wound. Whether you have viable or non-viable tissue, you cover the entire wound. The collagenase is not going to hurt granulation tissue. In addition, the collagenase, if there's a thin film of microscopic necrotic tissue, a very thin film that you can't see, collagenase will take care of that. So don't worry about putting it only on the necrotic slough. And it's not good for eschar unless you crosshatch, and we'll come back to that. You put it on about a nickel's thickness, about 4 millimeters thickness, and it's a daily application. Now we're going to go to mechanical debridement. So this is the application of some outside force to dislodge the necrotic tissue. And this is just a list, and we're going to go through each one of these together. And I'm going to start with wet to dry dressings. We're going to start with wet to dry dressings. I've done wet to dry dressings in my career. If you've been in wound care for very long, probably more than 10 or 15 years, you've done wet to dry dressings. We still get orders today in long-term care for wet to dry dressings from practitioners. Hopefully these aren't board certified wound care practitioners. Because whoever's going to do wet to dry, if you're going to do it, and there may be a place to do it on the test, there's not a place to do it. But if you have a wound 100% covered with slough, 100% covered with soft slough, could wet to dry be an appropriate intervention? Maybe. It's cheap, it's easy, it's fast. Doesn't take a lot of skill to do it, but it does take knowledge to know if it's appropriate or inappropriate. And as you look at this photograph right here, this is the inappropriate use of wet to dry. I had a physician in Dallas, Texas. I would go from hospital to hospital to hospital, doing both traditional physical therapy and wound management. And he loved wet to dry, but he always ordered it appropriately. It was only ordered on slough. It was never ordered post-surgically. Our surgeons, a lot of times we used to get orders post-surgically for wet to dry because they wanted to tear off the bacteria that could cause the infection. I get that, but oftentimes they were causing dehiscence of the surgical site because the fibroblasts and the keratinocytes were able to stay on the wound to keep the wound closed. It can be painful. It's non-selective. It's going to take viable and non-viable tissue, and it can be traumatic to granulation tissue, to new granulation tissue. Monofilament pads. This is something that came out a few years ago, and I really believe that this is an important intervention, particularly for my care setting, particularly for long-term care, where we don't always have the nurses and the practitioners who are skilled and sharp or surgical or even some types of mechanical debridement. So this is a polyester pad that you moisten, and you apply this pad in circular motions for 2 to 4 minutes. And what it does, I don't know if I can make this larger or not. Oh, I can, yay. What it does is you can see that these little monofilaments that are hanging down, that they are trapping, and you are taking out the necrotic tissue and the bacteria that is located right there on the surface, taking that out at the same time. So this is ideal for people who either by licensure or lack of experience, or they're just getting their experience. This is a great intervention. And this is one of Dot's photographs when she was doing some trials on this. You see the wound on the left. If it's dried out a little bit, that crusty stuff on top, it reminds me of creme brulee. If you love creme brulees, which I do, what I would do is I'd take my scalpel or curette, put my scalpel at a 90-degree angle, and would scrape this off. This is what the pad looks like after Dot used it on this wound for one intervention. Isn't that a great outcome? And those of you who are practitioners who come into our buildings, I love it that you're coming into our buildings, that you're doing the needed sharp and surgical debridement. However, it would be really helpful if you would order the monofilament pad to be done between your visits to help that wound get closed faster. Whirlpool is out of favor. We're not using Whirlpool any longer in general. People will say to me, well, can we use Whirlpool for this or that? And the answer is usually no. We have better modalities, and we're going to get ready to go to that, and that's the pulse lavage with suction. So in the 80s, it's when we changed from using so many Whirlpools, Hubbard tanks, to using different interventions for cleaning wounds. We do now have it in the literature that Whirlpool is contraindicated for chronic venous insufficiency. You don't want to put that leg in a dependent position with warm, agitating water in a leg that's already edematous. This is going to cause more edema. So that's part of why you want to do it. Also, you may be washing away some of the enzymes that you need for cleaning the wound. In addition, diabetic foot ulcers, everything in the literature tells you do not soak the diabetic foot. We are still having practitioners, I'm sorry to say, tell our patients with diabetes to soak their foot in Epsom salt. And I ask people all the time, have you heard this recently? And I'm hearing it less and less and less, but it is still happening. So what changed, and we have two versions of pulse lavage. We have a pulse lavage with suction and pulse lavage without suction. So pulse lavage is something that changed the profession of physical therapy and wound management. Before we had wound centers, the walking wounded came to outpatient physical therapy. That's where they came. Wound centers kind of took the place of the outpatient wound physical therapy, and most therapists were not brought into a multidisciplinary team. And if you have, I do know a few wound centers that still do have their physical therapist in there, and I'm really proud of them that they do, because we bring a different perspective. But one of the things that happened is these therapists supposedly was watching. We love to watch surgery. We love to watch surgery, particularly when we're going to rehab the person afterwards, and saw a total hip replacement or total knee replacement. I can't remember what it was. Saw the surgeon cleaning out the medullary canal to put the prosthesis in, and was thinking, wow, could we use this pulse lavage with suction for our wounds? Turn down the pounds per square inch of pressure, which was about 60 PSI. Can we turn it down? They did some research and found that if they turn the PSI down to 15 or less, that they can clean the wound and not cause it to damage any of the tissue or drive bacteria into the soft tissue. So the pulse lavage with or without suction helps to reduce the bioburden and actually enhances granulation tissue formation, because that water hitting that tissue literally upregulates and excites the fibroblasts and helps with the healing process. So pulse lavage with suction, there are a couple of things on here that are important. It is good for large or multiple wound sites. There are variable pressures. You want to keep the pressure, I have it highlighted for you. You want to keep the pressure less than 15 PSI. There are different tips that you can use. There are tips that you can put into a tunnel or an undermining, or there's the usual, what you see here is the cone-shaped tip. Dr. Lone, Harriet Lone, is a physical therapist who went to the company, one of the companies that made this device for surgery, and said, our wounds, they aren't all perfect circles. I need a cone that's malleable. So that's where the malleable cone came from. And my understanding is that Dr. Lone still holds the patent for this. The thing with using pulse lavage with or without suction is you will have to be in full PPE. Full protective equipment, personal protective equipment, because of the aerosolization that takes place and has the potential to get the bacteria out into the atmosphere. Although nowadays, the pulse lavage is having a plastic cover put over it, and so that helps with the aerosolization issues. Low frequency ultrasound came out in the 1990s. Again, one of these things that I think has the potential to change practice. It is a little bit expensive. Part of it is used in physical therapy. The non-contact low-frequency ultrasound is used more often in physical therapy. The contact low-frequency ultrasound is used more often in the wound care centers. And that's just that can trade off. It's just in general. So low-frequency ultrasound, it uses the cavitation process to change these gas-filled microbubbles are expanding and decreasing, expanding and compressing, expanding and decreasing, expanding and compressing. And that helps to separate the viable and non-viable tissue. And also pulse lavage, when we're talking about low frequency ultrasound, whether it's contact or non-contact, blows up the bacteria, blows up the biofilm. So it's wonderful for this type of treatment also. So the indications for low frequency ultrasound are locally infected wounds, wounds with impaired circulation, wounds that need debridement, irrigation, and topical treatment, and it's good for all types of wound etiologies. I've not done any research, and I need to do that. I'm writing that down on the pathergy effect. And Dr. Lee, if you know if there's a pathergy effect with low frequency ultrasound, I would really like to find that out. This is an old slide, but it's a good slide. It holds true till today. So on the left, you see a group of E. coli. This is the control. And on the right, the non-contact low-frequency ultrasound was put on and sonicated the E. coli, and you have 100% kill rate of the bacteria. And one of the questions I had for the companies that make the low-frequency ultrasound, I said, okay, I see that we've destroyed the bacteria. That bacteria is in the same wound as my fibroblast. Why is it blowing up the bacteria, but it's not blowing up my fibroblast? And the answer, it was just really lovely, a lovely answer. And I'm going to put it in my words. So Christmas balls, you remember the hard glass Christmas ball? So here's a hard glass Christmas ball. That is the wall of the bacteria. It is rigid. Here is a fibroblast. The fibroblast wall is malleable. So I'm going to compare that to a tennis ball. When you drop that Christmas ball, mimicking the bacterial wall, what happens to it? It shatters. When you drop your fibroblast tennis ball, what does it do? It bounces up. Sometimes it bounces back even higher. It gets upregulated. So this is what happens with the energy of ultrasound related to bacteria and related to enhancing wound healing with increased granulation tissue. Pulse lavage with suction does something very similar to that also. Related to upregulating the fibroblast, you get your tissue growth increases. And this is showing on the left, you're seeing where the cell wall was emulsified using non-contact low-frequency ultrasound. So when we look at low-frequency ultrasound, we look at the outcomes. One study found it comparable to sharp debridement in the terms of efficacy and tolerability. Others have reported an increase in the healing rates of foot ulcers, and it's good for slough and for biofilm. Biosurgery, the little maggots. I love maggots. I just think they're wonderful. People have a yuck factor with maggots, and I'm really sorry because they're really hard little workers. They're good for all types of wound etiologies with necrotic tissue in it. And also, it looks as if they would be good for necrotizing fasciitis. In 2004, they were given their own 510K. So the maggots and leeches both have 510Ks, so they're both medical devices. So this is looking at mama up on the top right. So what happens is the larva secretes collagenase, the same thing that's in collagenase. The larva secretes collagenase, and this process is not only the collagenase that they're secreting, it's also that the movements that they're doing, and they take their little mandibles and they sink those mandibles down into that tissue, and then they wriggle, and they sink those mandibles into that tissue, and then they wriggle, and they think the sinking of the mandibles helps with potentially tissue oxygenation, and the movement also helps with removing the necrotic tissue and maybe stimulating the wound bed. So there's 3 different things that are going on here. We've got debridement going on, disinfection going on, and wound healing being promoted by using biosurgery. Look at this little guy. Look at his little fangies. Isn't he just so precious? Whoops, sorry. I wanted you to see. I just think Dot and Lee used to live in Buffalo and says that he looks like he has his coat on for the Buffalo winter. So that's just looking at him.
I'm going to get a nice little grouping of maggots here.
Here we go.
On my Q-tip. I'm going to roll them off on the wound.
You hear the yuck factor going on?
There. Okay, so I'm going to cover these up. Now they're easy to deal with.
I think they're wonderful. There are medical grade maggots. Now, I'm going to have to change this slide because it looks like the company that had the maggots pouched may not have made it. They came from England. They went into Florida. So I'm not sure that they're here. Dot, send me a note. I think the pouched maggots are gone, but I think Dr. Sherman is still growing them in California, is my understanding. So if you give me an idea on that while we're thinking about this. Chemical debridement, this is your silver nitrate sticks, and there were some questions on the silver nitrate sticks. So let's go through this and then we'll talk about it a little bit. The indications for silver nitrate are mucous membranes, removing warts. For us, for wound care, hypergranulation tissue and epiboly are 2 of the reasons that we might use the silver nitrate sticks. They are 75% silver nitrate and 25% potassium nitrate, and they're on this rigid wooden stick for a purpose. The purpose is it is so important to put that silver nitrate exactly where you want it, to be very precise for where you put it, because you can't actually harm viable skin. The silver nitrate is soluble in all secretions, so you can control the strength. If you want to decrease the strength a little bit for some reason, then you can moisten it. You will, when you're working with it in a wound, say you're working with hypergranulation tissue, or maybe you're working with epiboly, that you will get an inflammatory response. It takes the wound back into the inflammatory phase of wound healing, wherever you've placed the silver nitrate. You want to let the family or any practitioners or clinicians that have worked with you that don't understand, hasn't seen you work with, or anyone work with silver nitrate, you will get a gray staining that seems to be disturbing to some people. And in the United States, you need a physician. Now, physical therapists in Texas use silver nitrate sticks. It is not specific in our Practice Act to use it, but it's not specific not to use it. So sometimes we have to go, when we think about what we can and can't do regarding to the law, sometimes we have to go with what's usual and customary training and competency. So what they do in Texas is you have to have a policy and procedure for the physical therapist, and my understanding is the nurses also, to use silver nitrate sticks. And that was going to be the answer. Someone asked me about physical therapists. Can we, by law, use silver nitrate sticks? Check with your Practice Act and find out if it's similar to Texas, that with training, competency, that we can use it, and with a physician order. So that would be my answer to that question. Selective sharp debridement. I've done sharp debridement my entire career as a wound specialist. It was one of the things I love to do, actually, and taught it for many years. So when we look at selective sharp debridement, we are looking at non-viable tissue. And this is also called conservative sharp debridement. Selective sharp debridement or conservative sharp debridement. You can use any one of those phrases. So the indications for sharp debridement include extensive devitalized tissue, where you see the signs of advancing cellulitis or sepsis, when there's thick adherent eschar. So that's what this is that you see here. This is your cross hatching. I need to move that. This is your cross hatching, where you take your scalpel, you take the tip of the scalpel or the edge of the scalpel, and you make parallel lines in one direction, depending on how much eschar you have, and then parallel lines in the other direction. And that opens up that hard surface. Collagenase cannot get through that hard protein cap. So this is one of the reasons. So there's two reasons for using cross-hatching: to put on collagenase and to facilitate the autolytic debridement process. Another reason for doing sharp debridement is as an adjunct in combination with other debridement methods. Usually we're not doing just one debridement method. Actually, you may do sharp debridement and say, that's all the only debridement method I'm doing, sharp debridement. But when you put that dressing on, if that patient's body is able to, they may help you do the autolytic debridement process also after having done sharp debridement. So most people use combination methodologies for debridement. There are some precautions related to sharp debridement, and that includes, and for surgical debridement, a low ABI or low TCPO2, gangrene where you know there's no blood flow, so you have arterial insufficiency. You want to be very careful before you start doing debridement, particularly in the lower extremity. If you can't ensure pain control, we don't want to be taking scalpels with to somebody. If you think there's going to be excessive bleeding, you looked at the chart, you looked at all the medications. That might not be a patient that you've been following daily, but you're going to look at the medications before you take a scalpel after someone with a chronic wound. If you don't know the diagnosis of the lesion, maybe you need to figure that out before you start doing debridement. And I think Lee probably told you about a case where he had cancer in an old chronic venous insufficiency wound. The tissue didn't look normal, and they did a biopsy, and sure enough, they had cancer. Stable versus unstable eschar on the heels. The literature tells us in general that we do not remove stable eschar. If you're going to remove it, you have functional goals. That person, you're going to get them back up. They're going to be ambulatory. They're going to go back to work. I had one patient in my career like that. He was on the operating table for several hours for a coronary artery bypass. He ended up having a heel pressure ulcer from being on his back through the surgery, and then on his back afterwards in ICU, and then on his back afterwards for a few days in the hospital. He came out with eschar on his heel, and he's come to me for cardiac rehabilitation. I need this man in functional shoes and good shoe gear, not in flip-flops. And so we had to, I sent him to physical therapy. Let's get that debrided, do electrical stimulation on him, get that wound closed as fast as you can. And when we get him in good shoe gear, then I'll get him on my tracker, on my treadmill to do his cardiac rehab for 12 weeks. So I have had that happen one time in my career. Patient versus unstable heel ulcers. I just spoke to that. Your unidentified structures. You don't know what the structure is, but you know it belongs there. You might want to think about what you're going to do before you take it out. If it's viable, we're not taking it out if it's viable. Terminally ill, it's going to depend on the goals for care for that particular person. Usually sharp debridement is not the most important thing, even when in the presence of a chronic wound, when someone is terminally ill. Usually we're doing palliative care in that case. Now, there's a star here, but I'm going to give you a disclaimer on this also. This has been on the test in the past. However, the literature is beginning to debunk this theory. And the note says that sharper surgical debridement may cause organisms to be showered into the bloodstream, resulting in bacteremia. So if you see it on something like this on the test, then you can answer this. It may not be on your test. The board may have taken it off. Reasons to stop debridement. You're fatigued or your patient's fatigued, particularly if your patient is a bedbound patient and you've asked them to roll over and stay in that position for a long period of time. You need to be careful because they're going to need to move. The patient is bleeding or you are bleeding. We need to stop. Pain cannot be controlled. We have to stop. You get to viable tissue. Now, if you're a practitioner, you can go beyond viable tissue. If you are a physical therapist or a nurse that's not at practitioner licensure level, then we are supposed to stop when we get to viable tissue, whether it's healthy or unhealthy. Locate a fascial plane. Oh, there's fascia. Well, that means that there's something in there, a muscle or an organ is going to be within that fascial compartment. You can name that structure, gluteus minimus. Oh, gluteus minimus. Oh, well, I went past the medius, and I know between the minimus and the medius, there's some arteries and nerves, so I better be careful with where I am. Again, know your anatomy and physiology. You have a high anxiety level. Every person, I think, on this webinar has had a high anxiety level, a gut feeling. Anytime you have a gut feeling, that is your inner whatever telling you the truth. Oftentimes your head wants to give you what they want to give you for instant gratification. Your gut will never lie to you. Your head will. If you have a bad gut feeling and you've got a sharp instrument in your hand, if you were able to, now if you're in surgery, that's one thing. If I'm bedside in that long-term care facility, I'm going to put that scalpel down, check my patient, check what's going on, and I'm going to follow my gut. So if you have a high anxiety level, don't know how you're going to document it, but remember, it's your intuition telling you something. Every time in your life that you ever not listened to your intuition, anytime you've not listened to your intuition, you've probably made a mistake. Hemostasis, prepare for it, particularly when you're doing sharp interventions. Pressure will stop most bleeding. Elevation of the extremities above the heart. Silver nitrate sticks, calcium alginate will help with little bleeders, not a lot, with little bleeders. Collagen will help with little bleeders. Lidocaine, vasoconstrictors such as the epinephrine anesthetic or hydrostatic agents such as topical thrombin. Now, the there's something called QR powder. That might be something. There's streptocaine. Kaolin comes out of China, and it is a mud that comes out of China and has been found to cause immediate coagulation. I'm not sure where we're going in the future, but we were using this for all of our soldiers. When they went out in the field, they took a kaolin pack to help stop the bleeding. And then maintenance debridement is the repeated ongoing debridement of chronic wounds to maintain the wound bed in a state of readiness to heal. Now we're going to talk about surgical debridement. Surgical debridement, and I thought I changed this. Okay, it's okay. Surgical debridement, look at the last bullet. It's within the realm of practice for the MD, DO, DPM, NP, and PA, the advanced practitioners, such as nurse practitioners and physician assistants. So I need to go back and put in my NP and PAs in here also. So there's sharp surgical debridement, there's laser debridement, there's a water type of debridement, hydrosurgical debridement also, which we consider surgical debridement. And when you're doing this as a practitioner, you're doing surgical debridement, you can get all of the unhealthy tissue, all the necrotic tissue, and the unhealthy tissue. So again, it's selective if it's non-viable tissue only. It's non-selective if viable tissue is included. It can be done in the operating room, which is going to be much more expensive, of course, or it can be done bedside. So surgical debridement has its advantages. For instance, it's good for, you've got a large wound and you need to get that debrided fast. The bedside or the clinic might not be the best place to do that. You may need to take them into the OR because of the amount that you have to do, and you have to do it, you feel like you have to do it fast. It is also appropriate for removing the infected tissue, as we mentioned before. It can be painful and it can be expensive if you're going into the OR. So in summary, you want to look at the etiology of the wound before you do debridement. Pyoderma gangrenosum, that's probably going to be on your test. You want to look at vascularity. There's going to be several test questions about vascularity. The patient's and family's preferences, their goals, that wound's ability to heal, the care setting you're working in. I prefer a little more conservative debridement in the long-term care debridement and the long-term care setting, because sometimes we don't have everything we need to take care of complications. The ability to identify that tissue. Is it viable? Is it non-viable? We need to know what the structure is that we're working with. So we have to have the knowledge to be able to do safe, effective debridement with that knowledge of relevant anatomy. And we have to have adequate lighting. If you're over 40, your lighting, your ability to see without bright light is diminishing. It's simply part of the aging process. No one gets out without losing some of their vision if they live long enough. You want to be able to explain the debridement procedure to your patients and residents. In many cases, some centers get a informed consent every time the person comes in. Sometimes the consent is in the global consent when the person comes in on intake. So that's going to be facility or company specific on how you get your informed consent. There should be management of pain and discomfort. There should be the ability to deal with complications such as bleeding. That's one of the, bleeding and pain are two of the most frequent complications. You want to recognize your practice act and try not to push beyond your practice act, those of us who are not practitioners, and have the appropriate treatment interventions and the appropriate dressings and whatever else you may be doing between the debridement process. This is a very old slide, but it's still relevant today. This person was on the operating room, operating table for about 8 hours for a procedure, and she got a pressure ulcer. a facility acquired, a hospital acquired pressure ulcer on the operating table. They are really cutting down on those now in hospitals with new types of tables and being aware of this and being penalized. They're not being paid for these pressure ulcers that are being acquired in the facility, whether they're avoidable or unavoidable, which I don't think is fair, but CMS doesn't listen to me very much. So sharp debridement, the betadine you see on there was not put in the wound, it was put around the wound. There was eschar on top of that to start with. Then they did the repeated sharp debridement. Now they're doing pulse lavage with suction and collagenase. That's what they've started there. They're continuing pulse lavage with suction and collagenase. They're continuing collagenase, and for all intents and purposes, it's closed. So this was using 3 different types of debridement to get the outcome of a closed wound. All right, ladies and gentlemen, I understand there's some questions, and Dot and Lee are going to come on with me.
Hello.
And then we're going to take a 5-minute break. Hello.
So here we go. Okay, Lee's behind me, but I think I know most of the answers for these, but he'll chime in if he needs to. So the first one is there any data for hyperbarics for diabetic neuropathy and reduction of neuropathic pain?
Negative.
I mean, if there is, it would be anecdotal, but there's no data to do HBO just for the relief of neuropathic pain. Okay, Pamela, this next one's for you. Have you noticed any long-term care actually administering an MDS survey to any of your patients?
Now, we talked about this. I had done some things. I thought, oh, that's HBO. They must not have taken it out. I'm sorry. I've already talked to Frederick about, I haven't seen them personally do it, but I have nurses who have seen the surveyor go and interview the family and the patient about their wound care. And one of the most important things they were asking about was pain management.
And the next one for you, additional options for physical therapists to treat pain from CDC guidelines 2016.
Oh, now that you read it, they might be, so any other options, I don't know what the CDC, in detail, what the CDC guidelines from 2016 say, but some of those things that were listed in looking at alternative methodologies for, using music, using stories, that kind of stuff. I'm not sure if that's listed in the guidelines. I'm going to have to look at that. I don't know the answer to that.
Yeah, interesting. This is more of a statement, but interesting. Topical covered ice works well for a few minutes before a procedure. Have we ever tried? And this person has found it works great. I know it does work. There is the freezing sprays. And when I was in junior high and we were piercing each other's ears, we used to numb up our earlobe with a piece of ice. We probably would not do that so much in our clinic. We don't have ready access to ice, sort of going to our lounge refrigerator and taking ice out. But it makes sense that because it just sort of temporarily numbs it because of the really icy cold. I guess you'd be careful on any kind of skin that is poorly perfused, but interesting. No, haven't tried that. Pamela, the next one's yours, but Lee and I could probably chime in.
Yeah, you're going to need to chime in for this.
What's that?
I was going to ask you to chime in because there are some.
Yeah, so I think it came up before. We do Lee does the debridement. And so it's the percentage of the wound that you debrided. If the whole, what you answered.
Yeah, you know what, and I don't send in the bills, but my understanding, and maybe don't take this as gospel either, but I believe that you have a wound, let's say the wound is 2 by 5 centimeters. So the wound is 10 centimeters in area, and you debride 50% of it. I believe that you're credited for debriding 5 square centimeters, not 10.
I will tell you that if some of these are great billing questions. If you're not familiar with Kathy Schaum's Wound Clinic Business Course, it's fabulous for really understanding the billing around, especially outpatient wound care centers. So, we document and then we let the coders and billers do their magic. So, and keep us out of trouble. So I wish that we could be better help, because she says help. This person says help at the bottom. But I would look for, I believe that the wound care business is going virtual. I'm not 100% sure, but Kathy Schaum's courses are phenomenal.
And actually, Kathy has been on this weekend with us to see how things work and how things go well and how things go wrong. And she was sending me emails yesterday and saying, "Oh my God, I don't know what's going to happen."
I hope you watch today.
There's a very good chance that it's going virtual. Her course is going virtual.
So the next one's yours. Can physical therapy apply silver nitrate with MD prescription for hypergrad?
In Texas, they can. It's going to be a state-by-state question. Oh, and then, and then is it billable by PT? And I don't know the answer to that.
You know what? The gray area for me is I thought most of the physical therapy CPT codes started with a 9.7, and I may be totally off base on that. And I believe the person that looked it up for us said it started with 1.7. But I would definitely just check with your coders to see if that's a billable procedure for physical therapy. So are you reading these, or do you want me to read them out loud? There's a longer one.
I'll do the next one. As a PT, how do you decide when? Oh, this is the one we talked about this one. To keep an outpatient that is not healing versus continuing to palliative care, to provide palliative care that includes selective debridement as tolerated to avoid recurrent infections to keep the patient out of the hospital. This is a long-term patient. I've referred to multiple doctors that cannot heal her of her bilateral lower extremity venous ulcer. So you said that she is palliative care, and I missed that. That didn't connect. So I'm wondering what's going on, if that has anything to do with why she's not able to heal. And again, is she getting the compression that she needs? If she's not getting the compression she needs, you're going to be debriding until she passes, because she has to have the compression.
Well, and you know, there's many reasons why somebody maybe they don't have adequate perfusion, yet they don't have dry eschars. And so you would want to carefully take out what necrotic tissue could, and they make a good point in there to prevent recurrent infections so that it doesn't become a breeding ground for bacteria.
Yes.
So yeah, lower extremity venous ulcers, especially in an elderly patient, are tough because you know, the whole compression thing may be difficult. So the next one is really just a compliment. So Pam.
And Heather, you've had phenomenal questions. Heather has had phenomenal questions.
Yes, you have, yeah. So if the next one is if pyoderma, this is a very good question too. If pyoderma is part of the differential diagnosis, but not yet certain, would you consider gently curating heavy slough off of the wound? You know, you could try that. I think we almost always err on the side of not really taking a sharp instrument, because how much is too much? If there's a bunch of coagulum and stuff sitting and you can gently ease it off, because sometimes it's easier to take it off with a curette gently. But just be careful that you're not entering into tissues that could have that pathergy response. You know, just for obvious reasons. So, you know, it's a case-by-case basis, but we generally wait till we have started treating them maybe with steroids before we start, you know, any meaningful debridement, I should say. And he says, you know, obviously no aggressive excision.
This next one is good. I'd like Lee to weigh in on this too.
What's that?
I'd want to hear Lee weigh in on this one too.
We talked about it. That's why I answered it.
Oh.
So, oh, you mean the vitamin A?
Yes.
This next one, yeah. Go ahead. So this is when adding oral vitamin A to a patient with chronic wound on long-term steroids, is there a usual amount of time?
Not that I'm aware of. This, again, is sort of one of those by the seat of your pants things. If somebody is on long-term steroids, you're having trouble healing a wound, you want to add oral vitamin A, and so you do so. And I'm not sure you need to have a level before you start, but you should get a vitamin A level from the lab, you know, some reasonable period of time after you start, and make sure that you don't allow the vitamin A level to go to toxic levels, and then simply continue the vitamin A as long as you're in the process of closing that wound. That's the only way that I've ever done it. There may be some more specific direction out there, but if there is, I'm not aware of it.
And it seems like you would want to be careful that you don't give it so much or so long that you're mitigating the reason that they're taking the steroids in the first place, like for their lungs or something. This one is for you, Pammy. Should we use, it's more of a contamination and infection control.
Yes,
do you want to answer that?
Well, I'm going to give it my best shot. So when we're using pulse lavage with suction now, we're all in PPE, and even the equipment, I don't know if you're using it, but sometimes the equipment is also covered And when we do things like debridement on the same person, we usually go from the cleanest wound to the dirtiest wound. Even when you do a dressing change, you usually go from the cleanest wound to the dirtiest wound. So if you have everything covered, I can see using the same pulse lavage unit on different wounds on the same patient. I wouldn't transfer that unit to another patient unless you have a policy and procedure for how you're going to clean it. But usually these are one person units is usually how they're sold.
Yeah, I hope that could get really expensive if you had to get a new one for each wound.
For each wound. And
yeah,
Dottie, is that what y'all do? Do you still go to talk about doing your
dressing?
Well,
we don't have pulse lavage. When we would use the sonics, the ultrasound, because of the speed with which it, we would probably use the same tip. I think if you're cutting into, we absolutely use a new instrument between wounds if we're doing debridement, but not necessarily, we don't do pulse lavage, so I'm not sure, but that sounds like a reasonable answer.
Well, and the other thing that I wanted to mention about when we're talking about, let's see, this was pulse lavage. Never mind. No. That was sonic. Okay.
Okay. Next one, this is you.
Have you ever used MetaHoney?
No, one more.
Oh, here you go. When PT debrides with a scalpel, do you document as non-excisional sharp selective debridement every treatment note, or could you document as selective sharp debridement? So Kimberly, this looks like it has to do with codes. And
yeah.
Do y'all have anything to say?
The 97597 and 598 codes, I believe, are the ones that she's talking about, and they come with their own descriptor.
Yes,
but
and it has to do with size. How much size?
I just see an abbreviated version, so I'm not sure exactly how it is. Again, I would tell you, you would learn a lot from Kathy Shamsing. Pammy, there was one above that. What is the frequency of the ultrasound that can protect fibroblasts yet kill bacteria?
It's going to be 20 to 40 megahertz. And we're going to talk about that. I'll show you that in biophysical agents. Yes, it's 20 to 40 megahertz. I'm sorry,
have you ever used
kilohertz. Oh, I gave you the wrong hertz. 20 to 40 kilohertz, not megahertz, kilohertz.
Yeah, I wouldn't have caught that. Have you ever used MediHoney alginate for autolytic debridement in patients where patient intolerant? Probably they're meaning intolerant of sharp debridement, and from our standpoint, absolutely.
Yeah.
We don't have the alginate one. I guess we do. That is the alginate that we have. So sure, if it would create that osmotic shift of fluid, which would help significantly with autolytic debridement.
That was
anything you want to add on?
Yeah, that was a great slide, Heather. Go back and look at that slide because Dottie talks about that in the slide.
So this is, I think, more of a statement. I'm a CWS nurse practitioner healthcare provider in California. As healthcare providers, we can order silver nitrate used for competent staff to use in addition to physicians. And I think that's an important point that she's making here. There's a lot that we can do in our roles, as long as it's in our job description, we're not breaking our practice act, and we have a physician order. But we want to have a competency in our file that we have shown that we can do so safely. So thank you, Carol, for adding that in.
That was good.
I think we have a few more. Maggot debridement, any tips?
They're not yet.
Maggot debridement, any tips? And now we've lost the ones that are in the bag, so they went back to Germany. And the group out of California, they have bags that you can put them in. If you use them free range, you have to build up a trough, so to speak, around the wound. I would definitely recommend using the little containers that they can be put in. But they've got new dressings that are drapes that won't smother the maggots. So look at Ron Sherman's site. Pamela, what is it called? Ron Sherman's site. Arch Therapeutics, or anyway, if you Google Ron Sherman and maggots, you're going to find a wealth of information. But to my understanding, that is the only source of maggot therapy in the United States.
That is true.
Yeah. So regarding the monofilament pad, what are the common brand names that you can Google? Actually, there is only one in the United States right now, and that is called Debra Soft. Debra Soft. I'll have a little bit more about it in my cleaning, but there were two. One of them left the market. There is another brand in Europe that's made by B. Braun, but it's not here in the United States yet. So pretty much Debra Soft is the only one that I know of. And I would be happy to be corrected, but I'm pretty certain about that. And can you tell us, okay, the email about causing bacteremia, we tried to find the source of that for debriding chronic wounds in a Mythbuster session that Lee and I were doing. And where this comes from is more with oral surgery, following hip replacements where you have hardware. But I asked Greg Schultz out of Florida this, and he said a lot of it has to do with oral surgery and heart valves, artificial heart valves, causing vegetation to grow. So certainly it's something to be thoughtful of. Actually, we might be able to, Fred, we might be able to, if we have your email, find some of the sources that we use and try to find direct correlation between debriding a foot ulcer and some sort of bacteremia. It's probably local versus systemic. So it was just, we had trouble finding the data source, but there are some issues around heart vegetation and implants. I have a hip replacement, so I'm still being made to take Keflex or Augmentin or something before I have any oral stuff done. Anything?
No, you know what? Fred, I've thought about this too. The issue of seeding, you know, even transient bacteremia with a full thickness debridement. And it seems like there should be more in the literature than there is, but I have not been able to find it. So I share that maybe bewilderment with you.
Tammy, you mentioned that PTs need physician order for silver nitrate. Do they also need an order for topical lidocaine? Everyone needs an order for topical lidocaine because it is a drug. And you know, Pamela, you weren't on when I brought this up before. You have mentioned, I've heard you say it 1,000 times. If a nurse says, oh, could you give him his pills after you're done? You can't hand someone medication, but you can use topicals, right? Like lidocaine or even triamcinolone if you're treating skin.
Topically, yes.
Okay, all right. And again, I guess it would be practice specific, state specific, but for sure, anything that has as a prescription, anything will require a provider prescription. When you do debridement, do you ever use an antiseptic on the wound base first? If so, what do you think is best? 100% of the time, and I'm going to talk about cleaning in a minute, 100% of the time we do. And then I very specifically chart cleanse with, and I named the name of we have a hypochlorous acid solution, cleanse with this solution before and after debridement. I think we need to be cleaning after debridement because even though he's done a great job of cleaning up, he's going to leave some stuff behind. So we need to re-clean. So I absolutely think that cleaning the wound well before debridement is absolutely the way to go.
I want to mention something real quickly. If anyone's looking for the biosurgery, it's Monarch Labs, like the Monarch.
Monarch Labs, that's it.
Okay. March 1.
Yeah, right. Thank you.
It's close.
I knew that.
How do you know how much to debride when you're doing it for hypergranulation, biofilm, or senescent cells? It's obvious with necrotic tissue. You know, I think it's just getting down to some punctate bleeding. And sometimes it's just a matter of scrubbing down to punctate bleeding. But if you can't see hypergran, just so you get it level. If you can do that in one sitting, because sometimes they're going to bleed. But I think just to get down 1 millimeter even or 2 millimeters is efficient.
And that is that's the way that I feel as well. Anytime that we're doing a debridement for anything other than visible necrotic tissue or foreign body or something like that, you know, it's just your best judgment when you're down to what appears to be the healthiest wound bed that you can create with your sharp debridement. You know you're removing some senescent cells, you know you're removing some biofilm, but you really don't know how much of that you're removing. So it's your best clinical judgment as to having created the best wound bed that you can create on that day.
So actually, our dear friend Kathy Sham just gave us a message here that in PBDs, and I think that's something department, it must be outpatient department, but anyway, consents must be received before every surgical procedure. So that might have come up. Thank you, Kathy. I hope you're happy that everything went better today.
Yeah, right.
Can Dr. Ritchie comment on tips to getting patients to tolerate and comply with compression wraps, assuming adequate arterial flow?
Well, yes. Okay.
Yeah.
Interesting point. I have had any number of people tell me, you know what, do whatever you want to me, but I'm not going to let you put a compression wrap on my leg. They've been to other centers, they've had compression wraps, and they've left those other centers. And I tell them, frankly, I tell the patient, if you'd like me to show you the literature, I will, but hopefully you're going to take my word for it, that if you have chronic venous insufficiency with ulceration and you have adequate arterial inflow, the standard of care nationwide is multi-layer compression. And if we don't do this, we're probably not going to get you closed. And, it hurts. When I go home, it hurts and I have to take it off. And the conversation that I have then is, well, the reason, first of all, if the wrap is not put on tightly, then it's not a compression wrap, it's just another sock. And I think that the reason most of the time that the wrap becomes frankly painful when people get home is that they go home, they sit in their chair, and they leave their feet and legs in a dependent position. So I encourage people, and sometimes I get these calls at 7, 8 o'clock at night, my wrap hurts. Please, before you do anything, get in your recliner chair or the couch or the bed, get your legs above the level of your heart, and I will bet you that within an hour, it's not going to be painful anymore. Again, all of this is predicated on normal arterial inflow, but Bob, that's a tough road. But I think this is one of those cases where you need the patient to understand that either you're going to provide the appropriate care or they're not going to get better.
The thing I would add is sometimes we have to keep trying until we find one that's comfortable for them. And we have options. We have the cotton-based 3 and 4 layer wraps. Sometimes if we start a little not quite so tight and get them to see the differences when we're measuring the foot, the ankle, and the calf at each visit, that they see good positive feedback that it's working. And then if they simply can't, then they have the juxtaposed strap devices, which usually we can find a happy medium, a comfortable place where they can tolerate that. I mean, I'm of the school that some compression is better than no compression, so we have to find that happy medium for them. Kathy Sham did answer back that said Leah's correct on the percentage of necrotic tissue that you debrided. I think that's what she's telling me, not the entire wound is when you're giving that measurement. And I think she's going to tell me what PVD is.
Thank you, Kathy.
In my world, PDB, it's a pre-departure beverage.
Pre-departure beverage. Okay.
Selected debridement is not sharp, the 975-975 code. You know what? I want to be clear that we should not be even giving you coding advice. That is definitely Kathleen Sham's area of expertise. It's your coders. Sometimes, we remember things off the top of our heads. Oh, the new term for hospital outpatient department is provider-based department.
Oh.
I didn't know that. And yes, you only get credit for the number of square centimeters for debridement, but not documented as a percentage. So thank you, Kathy.
Thank you, Kathy. There's a reason we don't do this. Yeah, there's a reason we don't do coding and reimbursement.
Yeah, that's her course, and it's. I mean, it is such a good course that you really, and the book that you get that has the follow-up information is priceless. So Kathleen adds that the word sharp does not help because both surgical and selective debridement can be performed with a sharp instrument, and this is very true. So do you want to describe the debridement by the level of tissue that was removed, and then describe the method by which it was removed? So thank you, Kathleen Shum.
Thank you.
All right.
Kathy.
And one more. Let's take this last one. When using maggots, can you predict which patients will be creeped out? No. I like the creeped out. Well, I use yuck factor, but we got to tell them. But I haven't used them that much. But some of them, if they're at least aware that if they have sensation that they're going to feel movement underneath there, hopefully they can tolerate it.
But I also think that, all of us have unintentionally used maggots. These folks come in, we take the dressing off, and I had a nurse in Buffalo that, boy, she could walk on air when she saw maggots. I heard a hoot come out of the exam room, and she'd come out of there dancing. She was so creeped out by them. But when you think about all the people who come in with inadvertent maggot therapy, how many of them tell you, I feel something moving inside my sock, or I feel something moving inside my dressing? So I think it's more the knowledge that they have the creepy crawlers in there than that they actually feel the motion. But anyway, I too am disappointed that we don't have more maggot options to use. I actually participated at a CMS session in Washington, D.C., trying to help get a billing code for the use of maggots. And CMS's position is that they didn't feel that physicians deserved to have a billing code because it was the maggots that were doing the work.
Okay, so I think this last one, and then we're going to have to get started again. But good grief, you guys have asked the best questions. It's really made us think, and it's been fun to be this interactive.
The other thing, Tiffany, we want all these questions. These have been fabulous.
Yeah, she's actually typing these all out from your chat room, so we'll have them. And we'll answer what we can answer here. But we do recommend venous ablation. Radiofrequency ablation is a commonly used way to collapse the superficial system. So I don't know if you misunderstood. It's stripping that I think you sort of see. Why don't you recommend?
Oh gosh, no, I absolutely recommend venous ablation in combination with appropriate compressive therapy. So the vascular and endovascular surgeon that I worked with in Buffalo for many years, he and I realized after, you all might remember that I referenced an article that Paston and Marston 2014 consensus document yesterday. And in that document, there are two recommendations. One is for ablation following wound closure to prevent recurrence. And there is another recommendation for ablation during the process of closure to prevent recurrence. If I recall, the strength of evidence for doing the ablation during active wound treatment is slightly less than doing it afterwards. But unquestionably, there is a role for venous ablation and closure in the superficial system, especially when you can document inline reflux from that vein to the open wound. I would add one note of caution, and hopefully this does not have to be a decision that you make, but in patients with deep venous thrombosis and occluded deep systems, you have to be or your consultants have to be very, very careful about superficial closure, or you can get into that cerulean albedolens and scenario where you occlude all of the venous outflow. So venous ablation in the setting of deep venous thrombosis is a totally different topic and one that deserves more caution.
Okay. Well, I think what we're going to do,
I was going to say, can we take these last few questions at the end?
Sure. Yeah, we'll be around. So we will, we'll continue to, because I'm sure more will come in, and we want to finish off the day. Let's finish the lectures, and then if somebody needs to go, they can go, and then we can continue to answer the questions. But we are absolutely committed. If they're patient specific, we're going to give you a private answer. But for those things that would help other people, we absolutely will get to this. So, All right, I think am I sharing my screen?
Yes.
Okay, I'm going to stop your screen sharing, Pamela, and you can mute, and I will get started on my lecture, which oh my goodness, I have to find. You guys, you know what? You've listened to, you have gone through almost 1,000 slides today. That's a lot. Let me just scroll down. I don't want to make you seasick here to my next slide. I'm always afraid to play on my computer while somebody else is speaking in case I should mess something up. All right, here we go. We're going to start with topical. Well, how did that happen? Hold on. Uh-oh. Well, I've lost my my mouse. Give me just a second. There it is. There it is. There we go. I won't go so fast this time. I think here we are. Topical management. Bingo. All right. Again, a fun one to talk about now. We've prepped up the wound. We've got it all cleaned and ready. And now we're going to see what we're going to put on top of it. So we'll start with wound cleansing, and I've said this a few times. I'm sort of militant about wound cleansing, and I have become more so in the recent, I'd say, 6 or 8 months because of some panels that I've been on and the opportunity to talk more about it. Wound cleansing is just something we have to do, and we were all trained different ways. If you look at the far left, you know, with all the gear, we definitely want to wear PPE if it's appropriate from a splashing standpoint. But we need to clean it like we mean it in terms of before we do any procedures, but especially in between dressing changes, because there's material that's been left on the wound for many days, and we absolutely have to clean that off. And so we've been taught in different ways. I'm a big fan of spray cleansers. I'll talk about that. But when you look at something like that far right picture, that is not cleaning, and I'll define what that is in just a moment. So our challenges with obtaining a clean wound really are based on some historical versus more modern dress to wound healing. I've mentioned that early this morning that 20 years ago, 30 years ago, was the first time I heard George Rodeheaver say, "Don't put anything in your wound that you wouldn't put in your eye." And again, there's lots of things we use in wound care that I witnessed in my eye. But it was really more thinking about toxicity. And again, and truly, when we have a healthy, clean wound bed, then we don't want to use anything that could potentially cause fibroblasts to slow down or die. But we, again, have to weigh and balance that with the risk and benefit that I mentioned earlier. Do we need to clean or do we just need to disinfect? But we always want to remember that bacteria are smarter than we are, and they're going to wreak more damage than maybe a rinse with a cleanser or something, a topical, when we have the presence of bacteria and especially necrotic tissue. Well, it depends on where we work. If they're at home, maybe they're showering the wound out. I'll talk about that. If they're in a facility like a long-term care facility or a hospital, maybe they can have a spray cleanser because it can be charged out to that individual patient. But in the clinic, we're a little bit handicapped because we can't use spray cleansers. I'll talk more about that because of contamination. And so we have to find the best way that we can clean within the area that we work. And so the other issue historically has been pain and trauma, and we don't want to hurt people. And so our avoidance of pain still prevails, and I will give you some specific suggestions on that. And so when we look at that little dribbling of the pink, the saline out of that little pink respiratory thing, we have to ask ourselves, are we cleaning or are we anointing? And if we're dribbling and calling it a day, we're anointing it, and it's not going to scare any kind of bacteria off the surface of that wound. Or here's another example. So It's beautiful here today. By the way, the reason we have such a power outage is we had a tornado about a mile away from us last night or Friday night that we didn't know about. But anyway, let's say it's pouring down rain and your car is filthy dirty because our car washes have been closed in New York. And so you know, if your car is filthy dirty and you go driving around in the rain, or you think it's going to really be clean, or when the car washes are opened up, you drive through where there's a surfactant that comes onto your car and gentle brushes clean your car. Well, of course, you're going to get a cleaner car with that car wash. And so wound cleansing is using fluids, devices to remove loosely adherent contaminants, devitalized material, remnants from the previous dressing change. And it must be done. And so it's part of a complete dressing change to get the wound clean. And so it's an integral part of the wound bed preparation that Pamela talked about by getting the surface debris off, reducing the bacterial load to the extent that we can with cleansing, and then hopefully reducing the potential for biofilm activity. But our challenge becomes, what do we clean with and how do we do it? So that's what what I want to talk about here. So how to clean. Absolutely, debridement is a fail-safe way to get the wound clean. As I already mentioned in the question and answers, we want to clean before, and I think Fred asked the question about using antimicrobial cleansers, and I absolutely do. And then we want to clean after we do the debridement. This is a really nice debridement done on the same day on this lateral foot here, and it was done very well. But you can't tell, but there's got to be some little remnants left behind in that wound. And so we want to re-clean before we put that dressing on. The rest of this cleansing, we're going to talk about each individual one. So part of it is in the delivery of the solution. Pamela, she probably talked about this a little bit, but we're going to irrigate a wound. We have to have enough force to break the bond of the debris that's sitting on the surface. And so a number to know is the range of 4 to 15 pounds per square inch of pressure. And how do you obtain that? Well, there's different ways. So the range is a recommendation that if you have a lot of debris and necrotic tissue and contaminants, that you go to the higher side. And if it's granulating and epithelializing, then we can irrigate to a lower side, like 2 to 4 psi. But again, none of us really have the ability to measure the pressure that we're delivering. It's sort of a guess. But there are some guidelines. One is using a certain size syringe and a certain angiocath. I will come back to that. And in one paper that I found, the recommended amount of solution is between 50 and 100 milliliters. I would venture to say most of us never use quite that much. So when we're irrigating, the delivery is what's key. And so it's going to be patient dependent, setting dependent. You may be pouring it over there, so you want to use plenty solution and hopefully gently be able to cleanse that site with a little gauze. There's delivery with syringes, catheter tips, as you see here. There are commercial devices, which I'll show you. And then there is the combination of a syringe and an angiocath. So 35 cc and a 19 gauge angiocath has been what's in the literature. I'll show you where that came from. There are commercially available pressurized cans with saline delivery that you can purchase or have ordered for the patient that will deliver a gentle stream. But again, we have to use enough of it in order to get the wound clean. So this whole 35 cc and 19 gauge angiocath, one thing I would laughingly say to you is go back to work and find one. We don't have any 35 cc syringes, and all of our angiocaths are even numbers, but it was sort of a guidance, and that actual recommendation came out of that emergency journal back in 1976. So, but you know, gave the idea of getting a little bit more pressure by having it in a narrower stream coming through the angiocath, and then of course the angiocath is safer because it's not a needle. So actually there was a good paper that was, I think, from Japan. Anyway, that looked at, it was an Indian Journal of Plastic Surgery, and it gave some recommendations in terms of the combination of the syringe and the angiocath. But you know, these are just guidances. Like, we know about the 3519, they said it delivers 8. 20 cc syringe and 18 gauge, that would be easier to find, delivers around 12. But the International Wound Infection Institute have this chart in their recommended guidelines for infection and wound no, this was a paper by Terry Swanson looking at assessment of and management of non-viable tissue. But this was just a chart that gives you some of the combinations of syringes and angiocath and what kind of PSI that you might expect. But, you know, since we're not going to use a gauge like the one you see at the top, you know, it's sort of a best guess in terms. We just need to feel like we're visibly getting that wound cleaner. And then, of course, anytime we're using any of these things, we need to protect our clothing. There are irrigation devices that are commercially available so that you can protect the wound and prevent spraying and splashback. Terry Swanson out of Australia said they bore a hole in a medicine cup and use that over a syringe, and that makes perfect sense to me in order to prevent the aerosolization and the splashback. The power devices, Pamela's talked about them also. I won't go further on that with the pulse lavage, contact and non-contact ultrasound. And then there's scrubbing. And, you know, scrubbing sounds archaic. It certainly has the potential to be more painful. We can scrub with gauze. I participated in a study with biofilm on tissue explants at the University of Florida, using my clinical hands to use as gauze versus a monofilm. And certainly we reduced bacteria better with a monofilm, but we did reduce it with gauze. And so when we are looking at trying to do this, the one thing that we have to think about is the person who lies beneath the wound. And so I always recommend to people, if it hurts, use topical anesthetics. Use lidocaine jelly, lidocaine solution soap for a little while. I wouldn't put ice onto an open wound. Well, maybe. I guess somebody does do that. But you have to have an order for it. But we will order topical lidocaine for our patients, for the home care nurses to use, as well as long-term care. It makes a huge difference. So, you know, we're all pressed for time. And if a anesthetic is lidocaine jelly needs to sit for 5 or 7 minutes to be effective, when I get into that room, I ask if it's painful to clean, and I'll go ahead and put my jelly on before I clean it, do my other assessment things, and because you can lift up the gauze once you put it on there and still measure, because you can see through the lidocaine jelly, and leave it on long enough, because then it allows me to clean the patient more adequately. So try it. You still have to use the amount of force that the patient can tolerate, because we don't want them to dread coming in to see it. So consider that. And then there is the monofilament, which I'm a big fan of. They are certainly more costly. You usually don't need to do it every single time you see a patient, but it is a way to get from here to here and from here to here with less trauma and being much more efficient. So what to clean with is certainly, again, the eye saying that don't put in the eye where you wouldn't put in a wound. And we have very specific cleansers designed for wound care. And so one of my favorites is a commercial cleanser, the ones that come in the spray bottles. And they're wonderful because you get the velocity of the spray, and you can usually adjust it from a stream to a spray. And then you also get surfactants, which I'll define in just a moment, surface active agents that help to break the bonds up. So commercial cleansers are great. And if we can get them for our patients at home, that's great, or in a facility. But again, we can't use them patient to patient and outpatient, because you're going to aerosolize and contaminate that little spray tip. So we don't want to be using those patient to patient. They're single patient use. And we want to make sure that we're using the right kind of spray cleanser. Those that are skin cleansers that are meant for incontinence should not be used on open wounds, because they have a high enough surfactant in them to emulsify stool. So that's going to be too strong for an open wound. So we want to make sure we're using skin cleansers for incontinence and wound cleansers for wound cleaning. So a little bit about surfactants. Pamela's already mentioned it. It's a surface active agent. It's something that will separate the surface tension from between two liquids or a liquid and a solid. So one of the ones, there's a few that we use in our everyday life. Our shampoos all have surfactants in it. That's what gets the oil off the shaft of the hair. Dawn dishwashing detergent, I'm addicted to this stuff. And when the whole COVID thing started, our grocery store shelves, and some of them are still just bare, and I couldn't find Dawn, so I had to buy an alternative brand, and it just, to me, didn't work as well. Fortunately, Dawn is back. But they have surfactants in them, and that's why Dawn works on pots and pans. It separates that grease off of the surface of your pan, making it easier to clean. So where the surfactants are used, you just may not have really thought about what a surfactant does. So the way they work is that the surfactants contain little monomers that have a water-loving head and a oil-loving or water-hating tail. And so in an aqueous solution, they sort of line up and they attract the moisture, they attract water, and then they trap it. There are some higher concentration surfactants that have a lot of these monomers, so they back themselves into a little sphere called a micelle, and then they're expanding and contracting, so it acts like a little scrubbing bubble that's not going to be harmful at the wound level. So anyway, it's a great way to get wounds clean, and something that you're probably already using if you're using some of these cleansers. So the commercial cleansers, again, do a great job. Most of the time, they're very well tolerated. I was cleaning a patient the other day, and I just irrigated him with our hypochlorous acid, and he almost came off the table. And I will tell you that I've never had anyone react to hypochlorous acid. I just never have. And so for whatever reason, he was much more sensitive to it. But then I got out, we have some of this that was from when we set the clinic up. They didn't realize we couldn't use it on patients. And I used it just on him. And actually, I put his name on it so we could use it again. But in any event, we can't use it on another patient, but he could tolerate that. So we need to find what will work for each individual patient. And there are different cleansers out there with different levels of surfactants. It just makes our job easier. So isotonic saline, saling's okay to clean with as long as we use it with the right velocity or the right PSI. But if you get a question on your test that says, that describes a very healthy, clean, granulating wound, and they give you a list of cleansers, normal saline is always the right answer. But in the real world, saline that will rinse off a wound.
Sorry,
well.
I couldn't hear what you said.
Siri's talking to me on my phone. It'll rinse off a wound well, but it doesn't do a great job of cleaning. It doesn't really impact biofilm or microbes at all. So if we're going to use saline, then it's best to use it with some pressure, with some gauze, with a monofilament, or put into a syringe. Now, what about showering? What about potable water? We many times let our patients shower. It depends on the location of the wound, our perception on the patient's hygiene, and the potential for contamination. Lee always describes to the patients about being careful about north to south contamination. But there was a study done, or some review in the Cochrane review, that looked at cleaning with saline versus tap water, and they found in the papers they reviewed that there was no difference in infection or healing rate. But what we do have to be aware of is what the source of the water is. Could there be contamination? Is it well water versus tap water? You know, I mean, there's so many things, and it's very region and location specific. But there's nothing better than someone being able to take a good shower. So even if they take a shower and then the wound is cleaned after they get out. But again, that's very patient specific. And of course, if they have a wound on the bottom of their foot, we do not want them walking into a shower. So some of the other cleansers or antiseptics, povidone and iodine, it is toxic at its full strength. Hence the reason we want to not directly pour it over a wound unless we're just doing it as a 1 or 2 time thing because we have, gross contamination. So it's better in a delivery system and a dressing that is a sort of time release. What about peroxide? This question has come up, and the effervescence, I had somebody ask me one time, will that help to disrupt biofilm? And so I went and asked my biofilm expert, Dr. Greg Schultz, and he said they have tried it on tissue explants with Pseudomonas biofilm, and it didn't do anything. So we do avoid hydrogen peroxide in outpatient or in chronic wounds. That effervescence will just pretty much fry the surface of the wound. The hydrogen peroxide is a naturally occurring reactive oxygen species, but the 3% commercial solution is absolutely cytotoxic. So if your child falls off their bike or you get some road rash or in the emergency department, they might use it to effervesce debris out of the wound. But as a continual use, we do not want to continue to use hydrogen peroxide. In fact, I laughingly say we have to make sure patients don't do anything that their mom told them. We don't use peroxide. We pick all scabs, and we don't let anything breathe. We don't leave it open to air most of the time. So we use it with caution, but it's certainly not something. And this is a good thing to query patients about. You've been going along and you've been like, why isn't this wound healing? And they say, I don't know, I'm cleaning it every day with peroxide. So, it might be worth querying them as to what they are cleaning with, because everybody thinks this is a great thing to clean wounds with. PHB, I spoke about in the antimicrobials. There are some commercially available cleansers with it in there. One of them also contains betaine, which is a surfactant, which will help to lift as well as provide the antimicrobial of the PHB. So it has the ability to penetrate difficult to remove coatings and debris in the wound surface. And it was originally one of the more common solutions that was used with the negative pressure that had the dwell. Hypochlorous acid, I think, is pretty commonly used in many, many wound centers. They come in multi-use bottles, and we can pour it into another container and take it into the patient. We frequently put it into a syringe with an angiocast to infuse or irrigate out tracts and things. So I find it does great things for odor. If you get those patients that have those fungoid toes that have all that mess in between them, I will saturate gauze and weave it between the toes while I'm doing other things and really get their toes clean. So it's a naturally occurring antimicrobial. It's what the neutrophil releases during the oxidative burst. So it's safe for human tissue use, and there has been some in vitro evidence with some different brands on biofilm. And then the old-fashioned ones, the acetic acid. You may see something about this on the test. So I think most people don't use too much acetic acid anymore. It's really not an antimicrobial so much as that it's so acidic that it doesn't allow bacteria to grow. But historically, you have seen it used with gram-negatives, especially Pseudomonas. It's great for odor. It's great for urine odors. And the 1% and 5% solutions concentrations have been used to attempt to reduce wound pH. But it is, for short periods it's fine, but again, it is going to be not good for healthy cells, so we want to stop using it as soon as possible. And then good old Dakin solution, sodium hypochlorite. A lot of people make this at home. Historically, and this is what you want to look for. Historically, again, acetic acid for gram-negatives, Dakins for gram-positives, and staph and strep, and other broad spectrum of organisms. But and it's not going to help healthy cells. So again, it's one of those things that we use it while we need it and stop using it when we don't. And then lastly, and I'll get off cleaning, but does this look familiar? I brought this up earlier, and I hope everybody's saying, yeah, I love to pick those things off. I think the sign of a really good wound nurse is that person who likes to pick scabs and pick scales off. But we got to get rid of this stuff. And there was a question earlier about potential contamination under a wrap. And these are the kinds of patients that we're wrapping. And I mean, if you don't think there's bacteria hiding in and amongst all this stuff, there absolutely has to be. This is one of my favorite little tools. The more cardboardy kind of measuring devices is good for starting to lift those scales off. But if we want to treat the skin, we got to get through the scales. So these are just some before and after pictures of taking just these big hunks of scales off, so that if I'm going to use an emollient, if I'm going to use a steroid cream or something, to put it on top of that dry layer of scales is not going to do the skin any good. So trying to get, and this doesn't necessarily happen in one sitting. It may take you a few visits to accomplish this, but the sooner we get those scales off, we can meaningfully treat that skin and get it in better condition. So Claire Morse is a clinician in the UK, and she had these pictures that she published. And this is a venous leg, a leg with venous insufficiency, you can see in really bad shape. And she's using a molecular camera that, when taken in a dark room or under a drape, it's the opposite of what you might think. Anything black is collagen or blood. Anything red is bacteria, and anything hot white is bacteria. The red is generally your gram, is a mixed bag, but your hot white is usually Pseudomonas. And so this is where she started, this is what the molecular camera showed her. She scrubbed the leg really well. She was actually using a monofilament pad to get the scales off. This is what happened. As some of it got spread around, she did it one more time. It's a pretty raw looking leg, but you can see a minimum of bacteria. So it's just, again, get after these things, try to get those legs descaled, and then you'll be able to treat them appropriately. So closing out on cleaning, I already said this, clean it like you mean it. Begin with your end in mind and think about it as you walk into the room. So if you need to, put something to take the pain away on, then you can do that. Or if you need to just soak scales, then you have time to do that. But you're going to base your cleaning on what you're seeing. Is it need to be cleaned, or do you need to disinfect it? And then that helps us to make that choice. And then we're going to.
Something I can help you with?
My Siri, he doesn't like what I'm saying. I'm talking too loud, probably. And so base your decision.
I'm not sure I understand.
Can you all hear that? I'm not sure I understand. So base your decisions on the risk-benefit analysis. So our decision-making for dressings is going to be based on the wound assessment, remembering that wounds are dynamic and they change all the time. So we're going to have to change our topical treatments to meet that need. We want our topical treatments to be evidence-based to the extent that we can. And then if we set our goals and decisions based on our assessment of the wound, then usually it's going to be the right one. So yesterday I showed a very similar list to this, and it was the outcomes that we want from dressings. So what we want our dressings to do is to fill space. We want to absorb the exudate, because by doing that, we're going to protect the peri-wound skin. We want to create a moist environment, which we'll talk about, protect and insulate the wound, reducing our dressing changes as soon as we can so we're not cooling down the wound on a regular basis, and then, of course, provide us with a bacterial barrier when needed. So the whole moisture thing is not new, and actually the whole concept of moist wound healing was sort of coming out when I became a WCN in 1980. But this was some work that was done back in the 60s, and the bottom line on moist wound healing is that George Winter made some wounds on the backs of domestic pigs. And some he covered with like a saran type of material, the rest he left open to air. The end result of that, the wounds that were covered healed more rapidly. They had less proteases that were involved. The cells coming off of the edge were able to migrate unimpeded in the moist environment. And if there's a scab there, then we're going to have that cell have to fight their way under. They have to move, produce a protease, lift it out of the way, migrate, lift it out of the way, and it's simply going to take longer. Additionally, moist wound healing is almost across the board less painful in terms of dressing changes as compared to, say, wet to dry dressings. This is just an example, a good example of moist wound healing. You know, a blister is a great model for this. This is a patient who had this blister on the bottom of his foot. And it was a pretty dense blister, so we might have left it alone, except for that black mark that was underneath there. And so when we debrided it away, what you see is it was completely epithelialized underneath there. A little bit of a divot, but there was, the skin cells had migrated under nicely. So in a blister, as with our moist wound healing, we're creating an environment where the cells are being bathed in the exudate and the fluid that they live in naturally. And so we want to try to mimic that environment. And so if we have too little moisture, it's going to desiccate and dry out the cells. If there's too much moisture, then we could create an environment for bacterial growth. And then, so what we're looking at is that just right balance to protect the skin and maintain moisture. So our ideal dressing is going to be one that manages that exudate appropriately. It doesn't dry it out, doesn't macerate. We want to be careful with occlusive dressing, so it's nice to have some ability for gas exchange. I'll bring that up again. We want it to be thermally insulating. Again, we don't want to cool these wounds down any more often than we have to. Conform to the wound bed. We want to protect from bacteria. We don't want to leave anything behind, and we want to clean well so we know if we're leaving anything behind, and we don't want it to hurt when it comes off. So we want to create the environment for healing. It needs to be relatively user-friendly. a lot of these dressings are being done at home either by a home care nurse who is well-meaning but may not be a wound care specialist and understand how to use a lot of different layers of dressings, or it may be a family member, a child. It may be a husband or a wife taking care of the patient. So we want it to be as easy to do, and by doing that, we're going to make it cost-effective, hopefully. It needs to be compatible with our support needs. If they need to wear a compression wrap, then it has to be able to stay on for a week. We need to know if it can be used in infected wounds, and then we want it to stay in place for the expected time. Now, I know Pamela showed this wet to dry dressing so we can avoid pain and trauma. That's going to be indiscriminate. It's not going to know what it's taken, if it's good or if it's bad. But I also like to caution about overpacking wounds. If we pack them too tight and put too much material into the wound, if it's an area under pressure, like a foot ulcer, a pressure injury, then it's going to actually add pressure. And you've probably all seen dressings you've taken it off, and especially with pressure injuries, where you actually have a bruised look to the area because of a thick dressing that was there. So we want to make sure we're fluffing but not overfilling. We want to protect the skin, and we have a variety of ways that we can do that. We have our skin preparations that I'm sure all of you have had experience with, and what these are polymers that have a solvent in them. Historically, that solvent was alcohol, but now they have alcohol-free solvents that when you spray, wipe, or coat it onto the skin, the solvent evaporates, leaves the polymer against the skin. So it's usually kind of a shiny look to the skin, so that when you lift adhesive off, it takes that off instead of a couple of skin cell layers. There are things called cyanacrylates. Cyanacrylates are also what that Dermabond, that skin glue is. These are a little bit different formulation. To my knowledge, there's only two on the market. You have the Marathon, that is sort of a blue. It comes in a little squeeze thing. They're changing their applicator actually. And then you have one that's part of the Cavalon series from 3M. So both of those dry, really successfully dry to a nice, durable coating on the skin. A lot of people in different parts of the world use this like in massive quantities to protect from incontinence. So we don't do that, but we do use it a lot on the edges of wounds, underneath negative pressure, and anywhere we're seeing excessive maceration. But it also is good for protecting from mechanical stripping. You can also use our barrier ointments. We use this frequently if we're wanting to overlap that wound edge because of using, say, a polyvinyl alcohol foam or some sort of foam that we want to try to flatten out that edge, then we'll many times use a zinc-based barrier ointment. But in this case, this fella had edema in his remaining limb. This was a transmetatarsal amputation. And he was draining like crazy, and we were using the most absorptive things we had at that time. And so we were just using the zinc-based barrier until we could get that fluid. And if you have that challenge, consider compression. You know, we don't have to just use compression for venous disease, but if you have dependent edema, as long as they have adequate perfusion, getting rid of that edema will reduce the amount of exudate. So as we look at dressings, I'm going to cover the primary dressing groups, understanding that there are 2,500 dressings on the market. There's different types and brands and sizes and shapes. So I'm going to cover the basics. At the end of this presentation, in your slides that you got, there are some additional slides that give greater information on these basic categories, with more information on the indications and contraindications, more than we're able to cover verbally in this course. But I do touch the highlights. I do go through the highlights of, of these dressing categories. So hydrogels. If we have a dry wound and we want to add moisture, then hydrogels are your go-to dressing. They are dressings that have a high water or a glycerin content and enables them to add moisture. That doesn't seem to be the bigger problem for a lot of our wounds, but sometimes it is. The most we use hydrogels is usually to deliver a silver actually into a wound bed that's a little bit more dry. Or if someone is using something at home that is a prescription, then we just use that for a temporary until they could get home. But it aids in autolytic debridement, and hydrogels come three ways. It comes in the amorphous, meaning the squeezable kind. It comes impregnated into a gauze. Now, you can impregnate your own, but the ones that come pre-impregnated are super saturated. So they really do a good job of delivering the hydrogel to the wound. But in the absence of doing that, you can just hydrate your own with the amorphous or tube-based hydrogel. And then there are hydrogel sheets of a variety of different kinds. Most, but not all of them, are relatively clear so that you can actually visualize the wound bed through it. And ironically, most of them have a little bit of capacity for absorbing a little moisture off that surface. Now, I will tell you, we had a young girl in the other day, and she had, ironically, she had some interesting stretch marks. She's pregnant, and they were splitting. And so we used the hydrogel because they were painful. And what I forgot to tell her is that it was going to form a little bit of collection of fluid underneath it. So she called the next day and said, you know, this doesn't look good. And she came in, and it was just the normal fluid that would collect underneath it, but I forgot to explain that to her. So just you know, a word from my experience. There are the surfactant dressings and gels, dressings that contain non-ionic or inert surfactants that help to clean wounds down at the microscopic level. There's some new evidence that when you have done good wound bed preparation, that these concentrated surfactant specifically doesn't allow the biofilm to reattach. And so they come in a dressing that has, when the exudate goes up into the foam, then it releases the surfactant into the wound bed, and then it absorbs it back out. Now, I will say that this company says you don't have to clean wounds in between, but I'm a zealot on that, and I think you do. So those are some of the surfactant dressings and gels. Our film dressings are transparent polyurethane adhesives. Anybody who's had an IV knows what one looks like. The one thing about them is that they don't absorb anything, but they are good for protecting skin. And so while it's rare that we would use it as the primary dressing, because fluid will accumulate underneath there and it's simply going to leak out. Years ago, we would aspirate it out, but that's a waste of time. We have better things now. And so we more often use them as secondary dressings to waterproof dressings in so that patients can shower. They can be used on intact skin. If you're watching an area that might be under pressure or friction, it will not only allow the patient to slide so you reduce that friction, but it also enables you to see through the dressing. Just remember, what goes on must come off. So you want to be careful where you put these and placed onto lower extremity on frail skin, arms or legs. I'm not a fan of using these things over skin tears because they can tear the skin more. And so what we want to do is, prep the skin if you have to use it, but there's a little technique that you can use to lift and kind of stretch the dressing kind of parallel to the skin, and it'll actually pop up. But it's still, even using that technique will and can tear skin. So be careful using it on anything that is very frail. Our hydrocolloids are intended to cover and maintain moisture. They won't add moisture, but if there's at least a little bit of moisture, then it will help create a humid environment that actually makes more moisture. So these are wafer-type dressings consisting of gel-forming agents. They adhere by themselves. They're mildly absorbing, but what they do is form a gel mass. I mean, this is quite a collection of the gel in that one. But they form a gel mass over the wound bed. And so when you take the dressing off, the gel stays behind, keeping it moist and making it for non-traumatic removal. It will help to promote an autolytic environment. And where the first ones that came out many, many years ago, this was like 1984 when they came out, were difficult at best to keep in place. They used to smell horribly also, but now they make them anatomically shaped, thinner with beveled edges, and so they are quite nice. And frankly, sometimes I forget about them because we don't use them that much. We have some, but we don't use it that much. But they're nice for very superficial wounds, especially on the trunk. Just like film dressings, if you put them on frail skin, it can be hard to get off, but they're nice for covering things, and patients find them very comfortable and help relieve some pain when you cover up those nerve endings. Then the foams, of course, is a huge category of dressings. Most of the foams that we use are polyurethane foam, just our typical, almost like a sponge, but polyurethane foam. The PVA or polyvinyl alcohol foam, like we see in antimicrobials, like we see, there is a new gelling fiber dressing, and I'll mention it, that is made from polyvinyl alcohol fibers. So PVA, in its dry form, and I didn't mention this earlier, is like cardboard. And so it needs to be moistened when it's in the foam, when it's in a foam. And so, and that's pretty obvious with the one that has the pigments, but we moisten it and then squeeze it out in order to make it soft. In fact, the white foam that comes with the most commonly used negative pressure device, that's a polyvinyl alcohol foam. And you notice they send it to us already moist so that we don't try to use it dry. Foams have multiple levels of absorbency. Many of them have a film on the top so it can't strike through. A lot of them have multiple layers. The advent of most companies having silicone-based foams has been wonderful. So it eliminates the need for harsh adhesives on people's skin. And so they're designed to absorb moderate to large amount of exudate, but of course you can use them to protect. You can use them to pad. We use them to pad sometimes with multi-layer wraps if we have a prominent tendon or something. So they have a lot of utilities. And they're often the secondary dressing under a more absorptive product. Another large category are the absorptive fibery type of dressings. Now, I can tell you that companies probably do not like the fact that I have these two things categorized on the same slide. It's just because it meets the same need. So calcium alginate are fiber dressings derived from seaweed that in its processing in making it a calcium alginate, when placed onto a wound bed, it becomes a sodium alginate because it exchanges calcium and sodium ions at the wound base or from the wound fluid. And so when it's dry, it's more fibery. When it's a sodium alginate, it's gelatinous, so it comes sliding out, as you can see in that foot at the bottom. So we also have the gelling fiber dressings, reportedly absorb a little bit more than calcium alginates. Both gelling fibers as well as calcium alginates are available with antimicrobials, specifically silver. The gelling fibers are either a hydrocolloid kind of material, which that's neither here nor there, but it's not an alginate. Then there is a gelling fiber that is made up of polyvinyl alcohol fibers, which has an amazing ability to wick out. So they're great for, and they come in dressings and they come in packing ropes. They're perfect for filling space and absorbing large amounts of exudate. If they, once they're used and if the exudate begins to slow down, they're going to stick. And that's when we say, okay, time to use something that's not so absorptive because the exudate has gone down. So as you can just see from some of these examples, they're great for packing spaces, but they may need to be used on a wound that doesn't have any space if it is exudating heavily. And then there are sort of a newer class of, and big class and growing class of dressings that are referred to as superabsorbents. I'm going to give you a site to be able to look some of these things up. But there's various forms, but most of them contain some sort of a polymer that locks in exudate, that absorbs more material, such as chitosan. Actually, chitosan is in one of the gelling fiber dressings, but something to lock in exudate. And I have just a few examples here and a few more coming on the next slide. But, and I'm not trying to be promotional about one particular one, but this just gives you a visual. The two at the bottom, I took a multi-layer wrap off of a patient one time and I saw all that and I'm like, oh my gosh, I even put extra chucks underneath the leg because I thought I'm going to be pouring this stuff all over the place. And you can see because of the locking ability of the foam that there was virtually no exudate pooled on that, and that's a good thing. So you know, that's just one of them, but these multi-layered or fibrous covers, there is either semi-adherent or non-adherent. They come in a variety of different deliveries in terms of whether they're in a bordered dressing. There's so many, it's hard to really describe them all, but I'll give you a website that you can look these things up. But basically it has vertical and then horizontal dispersion of the exudate into the dressing, so it's not sitting and pooling on the surface of the skin. And so it helps to wick some of that slough, debris, and bacteria off the surface. So again, here's just a couple of examples. This is just an interesting one, and it was a biliary fistula, but they put a little peg into the fistula, and then you can see how much is absorbed out. There are foams and things that have multiple layers, and the layers are meant to wick up and absorb and move the fluid laterally. So ask whoever your formulary says is the company that's on your formulary, ask them about their super absorbent. I'll bet you they have one, and it's really a godsend in our toolbox, especially when you're first starting to do venous leg wraps on somebody who's just dripping. It's a great way to get a few days out of that wrap and rechange it fairly frequently until we get the edema out, which is going to reduce the exudate. And then there's everything else. There are so many variations on dressings on the market. It's impossible to cover in one little session. But there are some that combine attributes, like you may have a gelling fiber that's covered with a foam as an all-in-one dressing. So again, be explorative. You can look up on the websites, and I'll give you some information on that to look at some of the options for, especially for exudate management. So leaving our standard dressings and quickly looking at collagen wound dressings. Collagen dressings do not absorb moisture. That's not what they do. They are a biologically derived material. The source can vary, and really we should be asking our patients about this source, because some of them come from cows, from pigs, from sheep, from fish, although that's an advanced therapy dressing, but they have different sources, and we want to make sure that the patient we're using it on doesn't have a problem with that particular animal. But in any way, collagen is in a mammal is the same regardless of the source. So collagen from a pig or a cow or sheep is going to be the same as the extracellular matrix fiber in collagen in our body. So it's the basic structural material of our body. So we don't use collagen to absorb exudate. Collagen is a great dressing to move to once you have achieved good wound bed preparation. It's pointless to put it over a bunch of necrotic tissue, but once we have a clean wound bed, it's a nice step towards having a temporary scaffolding. It's attractive to cells so they can migrate in and have a scaffolding to attach to. And this came up in a question yesterday. Collagen used on a hostile environment, the matrix metalloproteases will preferentially go to the collagen dressing and leave the collagen in the wound alone. So it's a great way to achieve less hostile wound bed, and then also to encourage cellular migration and encourage granulation. So in closing out on the dressings, there's some basic questions you can ask. Is the wound bed dry? Then we want to hydrate it, and we can use hydrogels, surfactants, hydrocolloids, and film dressings for that. If it's draining, then we need to absorb it. We can use alginates, fiber dressings, foam, or some of the super absorbers. And we have to think about this. Look at that slit up in the upper right-hand corner. As we take that dressing off, you can see the outline and what that exudate is doing to not only the maceration at the edge, but also the denuded areas around the wound. So we need to do everything we can to protect that. Is there space? Don't you want to just feel that? It's fat. If there's space, then we need to fill it in. This could be using moist gauze to pack it with temporarily, a calcium alginate or gelling fiber, one of the super absorbers, or a negative pressure wound therapy. And then lastly, if it's already filled in, then we just use something that we can minimize dressing changes, leave it undisturbed. If it's still draining, then we'll still use something to absorb with, maybe a hydrocolloid. So you can see your options there, but we want to minimize dressing changes so that we can allow the body to continue to close. So the frequency with which we're going to change these dressings, clearly if something has a lot of drainage, we're going to have to change it when it strikes through, or when we can see the evidence that it is getting or filling up a dressing. when the wound drainage contacts the edge of an absorbent island, for example. We need to change daily if it's based on the manufacturer's guidelines, but also if it's clinically infected, if we want them to watch it more carefully, or if we are experiencing peri-wound maceration or peri-wound irritation until that is resolved. In our low exudating wounds, we just need to maintain that moisture, and many of these dressings can be left in place 7 days if the exudate can be controlled and a nice moisture balance can be obtained and the skin can be protected. Now, I've said this over and over again. So there's a couple of websites. Wound 360 is part of HMP, but frankly, my favorite is woundsource.com. This is a group that you've probably seen a lot of advertising from recently, but it's a great place to go for dressing information. You can go to that website, you can put in self-adapting dressing, you can put in super absorber, and it's going to give you every one that's on the market. I don't know how they keep up with it, but while they have advertising on their page, they have everybody's. You don't have to advertise with this company in order to have your product in there. So they do a remarkable job of having everything in there. So they're a great source to go to if you're looking for, what can I use to hydrate a wound? What can I use to absorb a wound? What are some of the foams that are available? It's a great source for that. I want to just, as we leave dressings, again, remind us all that Medicare Part B and many insurance companies pay for these dressings. This has been since 1994, and so it breaks my heart when I have people come in and they're paying for dressings out of their own pocket. There is documentation that's needed. It needs to be a wound that has had debridement in some way. And if you have a full thickness wound, then likely it has had some debridement. It can be autolytic, it can be enzymatic. Any of the ways that Pamela talked about today is fair game. They need to know the size of the wound, and remember they need to see that depth because their computer's going to do math. And if you put a 0 in, it's going to say there's no wound there because it's going to be a 0. And they need to know where it is, and then most importantly, they need to know the exudate amount. There's rules to be followed. I'm not going to spend time doing it now, talking about it now so much, but just know that, for example, if you want a foam, you need moderate to large amounts of exudate. If you want a calcium alginate or gelling fiber, same, moderate to large amount of exudate. You won't get a hydrogel if you have moderate to large amount of exudate. So there are some utilization guidelines for how frequently it can be changed, but it's still a huge help to the patient to not have them have to buy their dressings. So leaving dressings, let's talk a little bit about active agents. These are pharmaceuticals usually, or devices that have Food and Drug Administration clearance to market for wound management or for active healing. And basically they are devices or things that help to manipulate the wound healing process by supplementing with active agents that are natural contributors to the wound healing process. Nobody gets a free ride in this business at all. They have to be shown to be safe and effective before they can get clearance for human use by the FDA. But because of that FDA clearance, then they usually carry some kind of reimbursement. One is a drug. This is a platelet-derived growth factor, specifically indicated for diabetic neuropathic ulcers that extend into subcutaneous tissue or below or beyond, and needs to be used in the presence of a good blood supply. Great for diabetic foot ulcers that have been freshly debrided. In fact, you want to do maintenance debridement with these ulcers in order to have the freshest tissue possible for the PDGF to come in contact with so it can attach to the cell. And it is a refrigerated drug, so we want to make sure our patients understand that. When we order it, I tell them, if it's not cold when you go to the pharmacy, give it back. And so we have to, I constantly remind my patients when they come in, have you had this in the refrigerator? So I'm not going to go through this, but so why PDGF? Again, I showed this in a bigger chart yesterday morning. Lots of cells produce PDGF. These are the cells that PDGF acts on, which are most of the cells required for wound repair. And then this is the cellular response. So you can look at that on your own. But I will tell you from the standpoint of the test, it's either going to be called a PDGF gel or PDGF. It may even use the generic name, which is becaplamine. But it will, if you see it as a recommendation for something other than a diabetic foot ulcer, that's not going to be your choice. So just be on the lookout for that. So you put it on and then on a thin layer, about the thinness of a penny, after cleaning the wound. Cover it with something to keep it moist. And the package insert says to change it in 12 hours. And that's just to make sure that the wound is moist. If you can create a moist environment, you can change it on a daily basis. But it does need to be dosed at least on a daily basis. And then we have the cellular and tissue-based products, which is an exploding area of wound care. And I used to try to cover most of them. It's simply impossible. So I talk about it more generically. So these cellular and tissue-based products, or CTPs, can be classified as either cellular, meaning they contain living cells, or acellular. They don't have living cells. They're biologically helpful, but they're biologically inert. The source is from all different things. Some are animal. Again, there's one that's fish, cod to be specific. And then there are some that come from various parts of human body, cadavers, placenta, foreskin, and umbilical cord. But they're not grafts. They don't take, they're not skin grafts per se. There's no vascularization or integration. They are simply wound coverings to promote wound healing. Some of them can make that claim, or for wound management. So the cellular devices are manufactured to leave the cells in. And so when placed onto the wound bed, then the cells can interact with the wound environment and then synthesize other growth factors. They may be able to, since they will synthesize collagen, and they can sort of get into the wound and sense what the wound needs. And so there are some that are neonatal foreskin source. There are those that come from placenta. And the placental products also have mesenchymal stem cells, which are the basic stem cells of most connective tissue. And so they can also be active in cell differentiation and promoting the ingrowth of different, or the attraction of different kinds of cells. And then the acellular definitely, brings something to the table in that it provides a nice scaffolding that is very attractive for cells to migrate into, support cellular ingrowth and granulation tissue formation, and then they support, tissue growth and help to contain and control and support and protect growth factors. So when we think about all this, and I'm sorry I can't spend more time on that, but there's got to be 80 or more on the market, and I get really confused. And, I can't keep up with them all. But when we are thinking about selecting patients for these don't come without a cost. But they're worth it. They are worth it. But we need to document well. We want it to make sure that we've tried other things and that either they have failed other things or predictably they're going to be hard to heal. So we may use them from day one. Some of them are available to do that. So we want to know what kind of wound it is. Some of them are very wound specific, like they may only be indicated for venous leg ulcers or diabetic foot ulcers. So we need to document well. Consider your atypicals, but consider that patient who nailed their leg on a dishwasher door, yet they have venous insufficiency. And so it's not the dishwasher that is the cause of the wound. The wound healing is being held up because of the venous insufficiency. So we want to make sure we're putting the cause of the wound in there. We want to have it prepared. If we're going to put these things on a wound that's ill prepared, it's simply not going to work. So it's going to be a waste of money. So we need to do good debridement, make sure we have the biofilm. Some of them are specific for reducing biofilm. So we want to make sure we've got that all under control before we put it on, because it's simply going to gobble it up. It's not going to work. They have to be able to offload. They have to be able to be compressed if they have a diabetic foot ulcer or a venous leg ulcer. Again, it's simply not going to be effective. And then we want to be able to tell the patient, and many of the companies have reimbursement help for you on this to be able to vet this out. But we want to be able to tell the patient if they're going to have a copay. But with that said, I think sometimes we make financial decisions for people. They may complain about their $15 copay every time they come in. And so if we find out they have a $200 copay on a device that we want to use, they're not going to want to do that. Well, offer it to them. They may be very interested in paying for that because they see that we believe in it and they see the benefit of it. But we have to tell them what that their part of it is going to be. Additionally, then we can document that we at least had the conversation and offered it to them. So in closing out on my part on this, I'm going to get to negative pressure, and that will be my last part of this, is to identify the different tissue grafts, because this was in the blueprint for the ABWM. And so, and remember, auto, anytime you see the word auto, it means it comes from self. So an autograft is something that comes from the patient's own tissue. It will be a full thickness or a split or partial thickness skin graft. An allograft is like a cadaver graft. It means it's come from the same species. And then a xenograft is one that comes from an animal. And then last but certainly not least is negative pressure wound therapy. This is an active management system. I think you shouldn't have worked in wound care and not be exposed to negative pressure, but it provides subatmospheric pressure to the wound bed through some sort of an interface. Mostly we see interfaces that are some sort of reticulated open cell foam. We used to see some that had gauze based. I think pretty much all of the ones that are on the market use some sort of foam. So it's been around for 30 years. It's in its third decade of use. We use it to remove exudates from all kinds of different types of wounds, and including surgical wounds. There are specific ones for surgical incisions. I'll show you some pictures in a moment. And it simply helps facilitate wound contraction and granulation tissue formation. The contraindications, some are direct and some are relative. If we don't know where drainage is coming from, then we don't want to put that suction on it. If it's filled with necrotic tissue, it's not ready for negative pressure, so we need to have it debrided. As I mentioned earlier, know what neighborhood you're in. If you have exposed blood vessels, any kind of organs, tendons, or nerves, it doesn't, especially tendons and bone, you don't necessarily need to avoid using it, but we would want to probably protect it with a contact layer. Wounds that are malignant, we wouldn't use it on. Unexplored fistulas, and we don't use it for fistulas, but there are fistula devices that you can bypass or surround a fistula. Osteomyelitis is not a contraindication, but it is if it hasn't been treated. So untreated osteo, and then of course, anybody that potentially could bleed heavily, we want to be careful. So these are just the benefits. It's going to help increase blood flow. It helps significantly to reduce peri-wound edema, helps stimulate granulation tissue, cell proliferation. It takes the bad stuff out and brings in the good. I used to call it like a good husband or boyfriend. Takes out the trash and brings in the groceries. So it takes out bad fluid, but it encourages the perfusion of good fluid. By changing the dressing, we reduce the bacterial load. It helps contain exudates, so there's less soiling on the patient. Helps us to reduce dressing changes, and so by doing so, reduces cost. So the peri-wound edema bit is a big deal. Reducing bacteria and possible disruption of the biofilm when we remove the foam are probably the key things that we see happen with negative pressure wound therapy. And so the peri-wound edema is a big deal because in normal tissue, you have all, and I know this is rudimentary, but I may be. So you have capillaries that are adjacent to each other in normal tissue. And so the distance that oxygen has to move from that capillary is adequate to perfuse tissue. When you have a lot of edema in the tissues, then those capillaries are spread out. And so distance perfusion is less, and so you're not going to have as well as good, the perfusion is not going to be as good. So you reducing peri-wound edema and decompressing those tissues will help bring those capillaries closer together so you have better perfusion. And you see the end result of this when you look at the tissue changes. So there's two things that happen. One is the macro strain. This is the pulling of those edges together, and it actually enhances the level and the rate of contraction in lax tissue. But the workhorse is the microstrain, affected by the interaction of the foam with the cells on the surface of the wound. And let me show you what I mean by that. So this schematic is the wound. This is to indicate that open cell foam that almost all negative pressure devices have. And so what I'm going to do, and if you look at a piece of foam, you've all cut it if you've done this, you can see that there's little struts, if you will. And so looking at this area here closely, you can see that those little struts are pushing down into the tissue. It's that pressure that stretches the cells and sends message and signaling in and excites the cells and causes them to replicate more rapidly. This is a study that I think was done at Harvard, but anyway, this is just showing the same wound where just the film dressing or the drape of the negative pressure was here, and this is where the actual interface of the stress of that dressing came in contact. Now the blue lines are drawn by the person who made this picture, but you can see an increase in the vascularity in those where the foam came in contact versus those where it didn't. So what should we see? These are two wounds that were 2 weeks apart. If you're seeing this and you're not seeing when I'm teaching people clinically, I say look for this footprint. There should be a look to the tissue if the patient is wearing the device. If we don't see that, we need to pack or get a better contact of the foam in contact with the wound, or ask the patient if they're actually wearing it. And not in a judgmental way, but maybe they have to work. Maybe they can't take that to work with them, so they're wearing it only when they're at home, and that's simply not going to work. So we want to look for that look, improved color, a certain blueprint, certainly more granulation tissue that indicates that it's working. And so there's a variety of different devices on the market. That we have the bigger machines that are used and attached to beds and things, and for hospital use and facility use. And then we have the more portable devices that are used for ambulatory patients and outpatients. I believe these are also used in long-term care as well. And then we have, as was discussed in the Lunch and Learn, we have the single-use negative pressure devices that some are specific for closed incisions. They have newer ones that are going to help reduce edema around orthopedic surgeries, for breast surgeries to reduce, mastectomies and things to reduce edema, and then those that are for smaller, lower exudating wounds where it's either in a cartridge that is more like a syringe, sort of a plunger deal. I discussed that today. And then there are the devices that the containing device is actually the dressing. So for closed incisions, for people who are working, for people who are ambulatory, who can't tolerate maybe the one that's wearing on their shoulder is going to make them off balance. If someone's going through rehab, some of these smaller devices, once the exudate is down, are going to be an ideal solution for them. And last but not least, with negative pressure of any kind, we have to have safety as our first thought, that we are looking for bleeding, looking for foam that's sticking, or dressings that are left behind. We must, because many times we in the wound center are sharing a patient with home care or long-term care, and we need, especially in large wounds, we need to know how many pieces of foam were put in there. And so some of them have stickers that you can put on, but if you are putting it on, help the next person by writing on the dressing, if you have to, how many pieces of foam. There have been, unfortunately, pieces of foam that have been left behind, sometimes for years, that the patient develops an abscess around. They go into surgery and find this piece of negative pressure foam that was there from who knows how long ago. So we want to be very careful that we're getting everything out. We want to think about, and that causes toxic shock, that's what that is. But we think about the tubing, get it out of the patient's way, making sure that it's not a trip hazard. And from this FDA thing, patient non-compliance, I hate that word, but patient non-adherence, it might be that they're well-meaning and well-intended, but they're turning it off. Some of them make noise. They may turn it off so they can sleep at night, who knows? So just make sure our patients are using it the way they are supposed to. We are the ones that have to be the stewards of safety for that. So anyway, I am finished, and I know we're a little behind, but you guys have asked the best questions today. I think Pamela's going to come on now. She has one more presentation, and then we'll close it out. Let me see if I have any questions. I may have questions. Okay, let me answer a few of these questions. So when Dakins is used at what strength? For the most part, Dakins as well as acetic acid are used quarter strength. You can actually buy Dakins pre-packaged. I heard you are not allowed to use skin prep before applying Santal on the wound. That is absolutely not true. Santal goes in the wound. Skin prep goes on the skin. I guess I don't know why somebody would say that, but no, you can certainly and should. use Santal around the wound if you're use a skin preparation on the wound if you're worried about exudate or if you're going to be applying tape, which many times you are. So there is no contraindication for Santal. I will say this about collagenase, and since it's the only one on the market, there is some compatibility, and I believe that Pamela mentioned it, but you can go to santal.com/HCP, which is healthcare provider /compatibility, and you'll get the whole list. Every 4 months or so, they look at newer products that come on the market to look at compatibility, but there is no issue with compatibility using skin prep on the wound around Santal. Those scales and plaques are often adherent to the patient's tissue, and if you pick them up, will often cause bleeding. So do you recommend something else to apply? You can soften them up. I will soften them up many times with hypochlorous acid, and you are 100% correct. I tell patients that I'm a professional picker and that they should not do this. But if they're firmly adherent, then of course you wait until you can loosen them up so you don't, peel skin back. Many times they're so dry, it's really easy to get them off. I've heard people use shaving cream. They'll moisturize their legs thoroughly and then wrap it with a moist towel. There are various ways. And remember, you don't have to get it done in one setting, but it should be your end game. What you're trying to do is get it lifted off. But there's nothing specific that will emulsify the scales. It's just something that you might try to get them softened up. What is your opinion of lachydrin 12% for gross xerosis or scales? I think it's great. I think that's the urea product. It's a prescription, if that's the prescription strength. But yes, it works very well. Many times these are people that were wrapping, and so we don't carry lachydrin in our clinic, but a lot of times we're wrapping these people. So those solutions, those creams and lotions are good for daily application. But yes, horrible dry skin or xerosis or scales, it's very, very effective. Were you saying that the presence of the scab was interfering with cell migration? Yes, it went in the George Winter model. That dry scab inhibited the cells from migrating with the same speed at which they migrated in the moist environment. You know what, if you have scab on a healthy individual, if you watch that scab and don't pick it off, you're going to see that it starts to lift at the edges. I jokingly say we pick off scabs, but scabs many times serve as a good environmental dressing, and we leave them alone. So the scab, though, if the wound surface is dried out, it is definitely going to inhibit cell migration. Do you recommend amlactin or lachydrin type of lotions for descaling? I haven't used them that much, so I can't speak directly to them, but yes, I do know that they help with hyperkeratotic and dry, flaky scaled skin. You favor commercial hypochlorous acid wound cleanser. In your mind, would Dakins and the spray accomplish the same goal at less cost? Sodium hypochlorite and hypochlorous acid is a matter of toxicity. And I'm not so well versed, other than I know that hypochlorous acid, the ones that are on the market, are non-toxic. Dakin solution in a 0.5% or 0.25% can be. And so, again, it's risk-benefit. If all you have are Dakins, and you have a wound that needs antimicrobial, then use it. And then just stop using it when you're done. Because so many of our patients that are just coming to us for dressing changes, like weekly, have had a wrap on, I like to clean the peri wound and the wound with hypochlorous acid because I'm not going to harm the healthy tissue, and I get a good cleansing of that peri wound skin so that my next wrap does not, I reduce the chance of the contamination from the edge. Thought that PDGF could be used for diabetic ulcers with PAD for angiogenesis. So the recommended wound that you would use PDGF gel is going to have adequate flow. If they are totally have severe occlusive disease, is probably not going to help. As long as there's some circulation. Now you're asking about angiogenesis, and PDGF is in the VEGF family, so it could encourage vascularization. But with that said, you want to have at least some semblance of vascularity so that if someone has the potential to heal, then they probably have adequate blood supply to use the PDGF gel. So can you speak briefly on the use of cadexamer iodine? And the question is about Hydrofera Blue. There's a couple of other pigmented foam dressings that are on the market, but specifically Hydrofera Blue. I like to use these on wounds that I know have contamination, and I use them in different ways. Cadexamer iodine, we know, is effective against biofilm. So if we're really thinking we have a heavily coated wound, we'll use cadexamer iodine. And if we, sometimes it depends on the drainage, the location, that will drive our choice. My personal preference with the pigmented foam dressing like Hydrofera Blue, I'm a personal fan of the classic that you have to wet. I cut it to fit. If I have thick edges, I'll coat it with a zinc barrier and then overlap the edge. It'll help flatten it out. But I like the way polyvinyl alcohol as a general rule, both in the foam that has iodine, the pigmented foam like Hydrofera, as well as the PVA gelling fiber, because it has this wickedly good absorptive ability. So when I have something that I need to flatten out or need a good absorption, then those are the kinds of wounds that I like to use them on. Also, decide to use products with silver in them. Do you have a time frame? I think a time frame is really use it for a couple of weeks when you think that you have an overgrowth of bacteria, and then if you, then stop it. But while we want to practice, good usage of, the stewardship with antimicrobials, we all have patients that as soon as we stop using an antimicrobial, they seem to recolonize. So some people, maybe it's just because of them, their wound or their environment, need to use them long term. But for the most part, the recommendation, that's going to be very patient specific. The recommendation is to start early, ramp up, use what you need to do to get the wound in the right space, and then ramp down and use something that can stay in place longer. What challenges do you see, if any, using hydrochloric acid with wound, the negative pressure? I don't see any challenges really. You're going to be cleaning the wound. If you're talking about the one with installation, I don't have access to that. That's an inpatient thing. So I'm cleaning these wounds in between my negative pressure dressing changes. And any benefits with the foam tissue use? I'm not sure what's being asked there. Any benefits with the foam tissue use? Perhaps, Dina, you could be a little bit more specific, and we can answer that at the end. So I think we're going to go ahead and have Pamela. I absolutely need to answer this last question. With recombinant PDGF, is there still some concern about risk factors for skin tumors? There never was risk factors for skin tumors. There was a box warning on the package insert for bicaplermin that was placed on there in 2008 because of a study that, a small-scale study that looked at a group of patients using bicaplermin and found that those who had an existing cancer, 2 or 3 of these patients died sooner from their cancer. So they said, oh, we better protect the patient. Actually, that box warning was lifted in November of 2018, I believe it was. So it's no longer, the FDA did remove a box warning. That takes a lot. And so it is not a threat. Certainly you would not use bicaplermin on an existing cancer, skin cancer, but if they have a history of cancer, then it's not a contraindication and it's no longer a box warning from the FDA. So with that, Pamela, my dear, I am going to turn it over to you.
All righty. I'm taking over. I love to be in control. All right, let's see. Let's make sure I hit the right one. Frank, watch me. Make sure I do the right thing. I bet I need to switch. Do I need to switch, Frank? Aha. How's that? Got it? One more time. Is that right, Frank? Please. One more time. All right. I'll switch one more time. Is that it? Yay. All right. Frank is reaching sainthood in my eyes. Only a few people in my life have been given Pamela sainthood, and Frank is very close, I have to tell you. So what we're going to do now is we're going to talk about biophysical agents in wound care. A few have been mentioned, such as negative pressure wound therapy, HBO. Dr. Chris Attinger out of Alexandria, Virginia, talks about, he did an article and he talked about when do we want to add adjunctive or alternative modalities beyond dressings, beyond the basics of good wound management interventions. And in his article, he talked about if the wound area is reducing in size 10 to 15% per week, then that represents normal wound healing. So that means that you probably don't need to change anything. You're on a good trajectory. However, if not, then you might want to use some alternative or adjunctive modalities. Now, Dr. Attinger was talking about cellular and tissue-based products, that kind of thing, primarily, maybe HBO. I'm spinning it to mean all other types of adjunctive modalities that you might consider for wound management and to enhance non-healing wounds. So some of the indications for these energies include debridement. We've already talked about low frequency ultrasound. Contact low frequency ultrasound does immediate debridement. Decreasing the bioburden and biofilm disruption. You might use it for edema reduction. We talked about using the pneumatic compression devices for edema reduction for venous insufficiency and lymphedema. And all of these energies, their purpose is to facilitate that stalled wound healing process. So this is just kind of a list of them. What is it we want to look at? Are we going to look at the electromagnetic spectrum, the mechanical or kinetic and acoustic spectrum, the positive energy, such as oxygen therapy and positive pressure, also pneumatic compression, and also positive negative pressure that you might see with, you have positive and negative with pulse lavage with suction, positive only with pulse lavage, and negative pressure with negative pressure wound therapy. So all of these energies change what's happening locally, in some cases systemically, with HBO therapy. Now, as you look at this list, I want to mention, we've already discussed what we said that Whirlpool, the things that are white in the list, the things, Whirlpool, rare indications, very rare indications. Hyperbaric oxygen, Lee's already spoken about, so I'm not going to speak again. He gives you a great talk. I am going to mention topical oxygen. And this is the only place it's going to be mentioned. Topical oxygen is not hyperbaric oxygen. And I think Lee already's mentioned that. This is a local delivery process termed continuous diffusion oxygen. And with this oxygen therapy, it looks as if we have some current studies that are showing favorable results, and CMS is listening and taking comments from the medical community to determine if this modality is going to get a coding, if it's going to be eligible for coding and reimbursement. As far as I know, and if Kathy's still here, Kathleen Schaum's still here, she may be able to tell me, but at this point, I don't think there's any code for us. However, it has been approved by the FDA as a class 2 medical device to heal difficult wounds. We used this many, many years ago, and it's come back, and it's coming back differently. So I'm going to start with my favorite modality, and that is electrical stimulation. I've been using this modality for 40 years. I use it to this day. Here's my device right here. I give them for Christmas presents. If you're one of my good friends, you get a eStim device for a Christmas present if I think you need it. It's it's good for closed wounds, sprains, strains, edema. We're going to go through all of this. It's just a fantastic modality. It is one of the most cost-effective, therapeutic, efficacious modalities in our arsenal. It's been used, I've used it personally for over 40 years. My first battery operated eStim device came from Japan in 1978. My father brought it back from me. I was in physical therapy training, and he called me and says, "What do you think about this?" I said, "I don't know, bring it, let's see." And that was my introduction to the battery type. Before that, physical therapists were using very large pieces of equipment to do the different types of electrical stimulation. We now have strength of evidence A, double-blind randomized control studies in humans the reason we had problems getting the strength of evidence A is because there's several different types of currents. There's TENS, transcutaneous electrical nerve stimulation, which is a little bit shallower current. Then there's high volt, which is a deep current. There's interferential current, there's rushing current. So there's several different currents. The interesting thing is all of the currents help. All of them help. Remember, you are and your patients are an electrical entity. So, and what happens, I'll tell you what happens in just a moment. Don't want to get ahead of myself. I get so excited about E-stim. So what we usually do with electrical stimulation is we usually use the current below the threshold for a muscle contraction, unless strengthening is one of the things, or muscle re-education is one of the things that you're using this energy to do. In the Paralyzed Veterans of America states that electrical stimulation qualifies as a standalone intervention and no longer classifies as an adjunctive therapy. So in the VA system, the therapists, the physicians, the nurses, you can put on E-stim, according to what this says, as an early intervention. You don't have to wait the 2 weeks, and we'll talk about the 30 days, and we'll talk about the 30 days in just a minute. In addition, now this is new information from the National Pressure Injury Advisory Panel, and that is that when continuous electrical stimulation and intermittent E-stim is given to the bilateral gluteal muscles, and that's compared with the treatments found to reduce pressure around ischial bony tuberosities, that it looks as if we're getting significant increases in tissue oxygenation using E-stim for people who are immobile in their chairs. In addition, the NPIAP, the National Pressure Injury Advisory Panel, talked about some of the multiple studies on prevention for pressure ulcer injuries using electrical stimulation. And again, it was talking about the intermittent tetanic. That's where your muscle is contracting. It gives you these little micro offloadings that take place and deforms the soft tissue just a little bit. And you reduce the ischial interface pressure in somebody that's seating just a little bit. We do need more studies, but it looks very, very positive, not only for healing for pressure ulcer injuries, but also for preventing pressure ulcers. So it says in the National Pressure Ulcer, we have to remember to do injury and not ulcer. When you've been doing it for so long, sometimes it's hard. The National Pressure Injury Advisory Statement says, administer pulsed current electrical stimulation to facilitate wound healing in recalcitrant stage 2 and 2 or 4 pressure injury, strength of evidence A. So when you're looking at electrical stimulation, what does it do? Well, let's think about a chronic wound. What's happening to the electrical impulses in a chronic wound? When you have an acute wound, you cut your arm. This is an acute wound. It sets up what's called the current of injury. It is actually a theory. Much of what we do is theory in medicine. So it sets up a current of injury because each cell, the fibroblasts, the neutrophil, the keratinocytes, they all have a current. Each cell does. With the chronic wound, that current, it's flat. There's very little current. So when you cut yourself, you have an acute wound, the current of injury is set up to tell those cells to move and what they're supposed to do. All of that goes away when you've got a chronic wound. So this energy sets up and mimics that current of injury and to get the cells excited again. So as you see here, this is one methodology. We'll talk about how you put electrical stimulation on. You can have your 2 electrodes, such as you see here in this photograph, and here's my 2 electrodes here. You can bracket the wound. If the skin is intact, you can actually go on top of a bruise or a strained joint, a muscle or a tendon that's been strained. Some of the processes and some of the physiological responses that take place is you actually get increased perfusion in macro and micro circulation, both of them. It improves the fibroblasts to be doing their jobs for enhanced collagen and DNA synthesis. You actually end up, they have found that you have an increased number of receptor sites for the growth factors to interface when you use electrical stimulation. You get increased migration and proliferation of the cells at the wound site. The energy, the electrical current is calling in the cells to help the wound to heal. And it's particularly your neutrophils, your macrophages, and your fibroblasts, some of the 3 of the primary cells that we need for wound healing. It increases the collagen deposition. It decreases edema like you would not believe. I've had 2 patients with gout, with severe gout, which is, of course, is a form of arthritis. It's an inflammatory disease, which most of our diseases are. They're inflammatory. And both of them had within 20 to 30 minutes, they were at a different level of function after using electrical stimulation. Oh, I've got it in the living room. I have it in a flip-flop methodology. I have it in a stocking methodology. I've got it in a glove methodology for delivery of the current. So it doesn't matter where on the body it's located. If you can get the current there, it's going to help. So it can be delivered, as I said earlier, low intensity, high volt, transcutaneous, but the one we use primarily for wound management is high volt currents. So these are the different ways that you can apply it. You can put the electrodes in the wound bed. You can put one of the electrodes, the active electrode, in the wound bed. This is from Luther Cloth, my good friend Luther Cloth. This is one of his patients. You can bracket the wound like this. You can deliver it. Here's a stocking delivery system. This lady's already lost her left leg. She's lost her middle toe. She's in long-term care in Austin. I was working there not too long ago, and we were trying to leave her a leg to stand on so she can do her pivot transfers from her bed to her wheelchair, wheelchair to commode, wheelchair to shower chair. With both legs gone, when people lose both of their legs, there is a portion of their dignity that in their mind is often removed from them. So we're really trying to leave her a leg to stand on so she can do these transfers. And she literally did keep her leg until the end of her life. So examples of indications for electrical stimulation is certainly pressure injuries, venous insufficiency, leg ulcers is also going to help with the edema related to venous insufficiency, and for lymphedema also. Arterial insufficiency ulcers, when we have my grandmother, I told you the story about my grandmother. She had an ankle brachial index of 0.43. We weren't going to get wound closure. So we did the stocking delivery system and got her wound closed in 6 weeks with a stocking electrode, which to me was absolutely amazing. I've not used it on anybody with an ABI so low. It's indicated for burns, surgical wounds, closed wounds, such as your muscle tears, your sprains, and your strains, which is what physical therapy in general uses electrical stimulation for. I'm not seeing it used as much, and shame on us. It is a phenomenal intervention to help our patients with all of these soft tissue injuries. So because of the strength of research, in 2002, CMS announced that the E-stim coverage for arterial venous pressure and diabetic wounds is appropriate if the wound has not responded to what they consider it to be a chronic wound, and that is 30 days. And as Dot, I've heard her say before, I'm not sure if she said it in the course, sometimes this weekend, I don't know if she said it this weekend, sometimes the day that wound is made, it's already chronic because of the person's body. But they are saying that we have to use wound interventions that are usual and customary for 30 days before we use these adjunctive modalities, including electrical stimulation, HBO therapy, and some other interventions, even our cellular and tissue-based products. My understanding is it has to meet the definition of a chronic wound. So CMS coverage of electrical stimulation, this is your national coverage indications. It says that the use of E-stim and electromagnetic energy, which is like diathermy, for the treatment of wounds are considered adjunctive therapies and will only be covered for chronic stage 3 and 4 pressure injuries, arterial ulcers, diabetic ulcers, and venous stasis ulcers. Now this is related to wound care. This is not related to what we traditionally have used electrical stimulation for. These chronic ulcers are defined as ulcers that have not healed within 30 days. E-stim electromagnetic therapy will be covered only after appropriate standard wound therapy has been tried for at least 30 days and there's no measurable signs of improved healing. And that 30-day period starts, this is important, that 30-day period starts while the wound is acute. So say Dot and Lee saw the wound for a week or two, and then the person needed to come back to Texas. They got stuck in New York because of COVID, and now they're coming back to Texas, and they still have that wound, but they started E-stim 2 weeks ago. I get to start my count with when Dot and Lee started. I don't have to start the day I see the patient when they come back to Texas. So these are some contraindications and precautions. We're not going to put it around malignancy. You don't want to accelerate the angiogenesis process around a malignancy. If somebody has not they have osteomyelitis, and they have had no decrease in their infection symptoms with the starting the antibiotics, then if it's untreated osteo, we're not going to start that. According to the contraindications, I do have a question in my mind about that, that if one of the reasons something may not be responding to medication is because it doesn't have blood flow. We have a diabetic foot ulcer. We're giving IV antibiotics or oral antibiotics. Best antibiotics in the world has no blood flow. How's the medication going to get there? E-stim improves the delivery of oxygen. I think the concern is, are we going to spread the infection? My concern is, can we get the blood flow to be able to deliver the medication to the infection? You're not going to put it over an implanted electrical device or in any patient with a pacemaker. Even if there's a pacemaker, say at the heart, of course they're at the heart, and you have a wound down at the foot, I would call the manufacturer of that pacemaker to ensure that that 4 or 5 foot distance for the electrical stimulation. Remember, this particular one is run on batteries. So is there any chance that that AA, or I think this may be a AAA battery, is going to affect that pacemaker on the chest? Don't take that information on yourself. Please call the pacemaker manufacturer, Medtronic or whoever that might be. You're not going to put it over the heart region specifically, or the carotid sinuses, or the larynx. You're not going to put E-stim over a near active bleeding or transcerebral application. God, if I thought it would improve the blood flow to my head, or my neurons keep firing as fast as they used to 15 years ago, I would try it no matter what the contraindications are, but I don't think it's going to help. Acute arterial occlusion are over the uterus of a pregnant woman. Of course, like so many things, we don't know what's going to happen with pregnancy. There should be precautions are listed as children under 3-year-olds using in areas of impaired sensation. I have used this many times for people with peripheral neuropathy from diabetes, and have gotten actually an improvement in their peripheral neuropathy symptoms. And you're not going to put it on top of a skin irritation. So this is just a short case study of a 67-year-old gentleman that came into our facility in Austin. The facility staff didn't want to take him in, and I'm curious, so why don't you want to take him in? And they said, well, he's a physical therapist. He's going to be difficult. So my question is, do we have a bad reputation as difficult patients or people? I talked him into bringing him in. We brought him in now. He's already lost his toes. He's had a transment amputation. On his right leg, this dressing right here, he has a 70% failed graft, that he has this wound on the anterior aspect over his anterior tibialis. He got that wound from TED hose. I hate TED hose. They're worthless. They don't do anything for edema. If you're doing it for DVT prevention, absolutely wonderful, great, but it is absolutely inappropriate for dependent edema or any other type of edema. So this gentleman, they put the TED hose on him. They didn't change it for several days. And he ends up, because he has arterial insufficiency in both legs, with a medical device related pressure injury from the TED hose. Every person in long-term care, we get an order from the practitioner, apply TED hose. Please don't do that. That's not what they need. Unless it's related to DVTs. If it's related to edema, TED hose are worthless. So with that said, he's lost his toes. That has dehisced. He has a heel pressure ulcer from facility acquired in the hospital. So we've got 3 wounds on this man. All 3 of them are being impaired from wound healing because his ABI is only 0.51. So the podiatrist, and I really appreciate this podiatrist, had ordered platelet-derived growth factor because the facility was going to call this a diabetic foot wound. Well, it's not, but he wanted the heel. It's not a diabetic foot wound. It's a heel pressure ulcer in the presence of the comorbidity of diabetes. So we started the debridement. We started using the PDGF. We got him and we did the electrical stimulation 6 days a week. My physical therapist assistant came in on Saturdays because I was so afraid that this man was going to lose the rest of his foot and that we may end up with amputations on the other side also. So we treated him fairly aggressively, and we saw him 6 days a week. And we got him completely healed in 6 weeks. Electrical stimulation should be a first line or adjunctive treatment and should be used in combination with other moist wound therapy interventions. So here are some of your E-stim studies right here. Go online if you want to try something just really look up the studies. We have a physical therapist in Canada, Pamela Houghton is her name, has done phenomenal studies on this particular intervention. Now we're going to move on to ultraviolet light. When you look at the light spectrum, there are interventions on both ends of the light spectrum, the ultraviolet side and the infrared side. And it's so interesting. We lost our infrared light, any reimbursement for infrared light, and it's coming back. It's coming back strong. Infrared light is coming back strong. So I hope we revisit this with CMS in the not too distant future. So when you look at this and we look at the wavelength for light, the components of ultraviolet light that give us some of the wavelength that we need to improve wound healing is 180 to 400 nanometers. And we have UVA, UVB, and UVC. The one we're going to talk about right now is UVB that gives us our sunburns, but it's UVC, the C component, that has the ionizing bacterial and virucidal properties. So these help to, that does two things. The UVC, it has its bactericidal effects, and it also helps with wound stimulation due to an antiseptic inflammatory response that takes place in the tissues. So the studies for UV light started back in the 1940s, and we've actually had some pretty good studies that show improved healing for pressure injuries and venous insufficiency ulcers. And it also helps to produce that mild inflammatory response to help to accelerate the wound healing. So this is just one of the devices that I found online, found a picture of it, clipped it and brought it over here. So UVC will help with a topical bioburden. It does not penetrate beneath the surface, but you might want to consider using it topically. It's safe and effective for developing surface infections. You can use it where there's poor circulation. If there's no circulation, the antibiotics that you give a person is not going to get there. It's a replacement for topical antibiotics. And we are having some concerns now related to antibiotic stewardship, also for topical antibiotics. When you're, there's some species specifically that the UVC kills, and I'm going to show you that in just a moment. So again, it helps with a mild inflammatory response to help with wound healing. It can be used while you're using systemic antibiotics. You can use this in conjunction with that. It is consistent with the best wound care practices. Now, this is an old slide, but it's an important slide if you're considering ultraviolet. And there are centers that use a significant amount of UVC, burn centers. We have had burn therapists in this course, and every one of them I've talked to now for the last 5 years say they use UVC in the room, in the patient's room, when a burn patient leaves. And all the patient rooms are for burn patients with large surface area burns. They're all private rooms because they want to make sure there's no cross-contamination related to infections. So all of the people I've talked to in the last 5 years, the first one was about 5 years ago when we had this group, they are using UVC light. They have a big machine, and when the patient leaves, they're getting ready to bring another patient in. They bring this huge machine in, this UVC light, and irradiate every surface in that room, every surface before the next person comes in, to ensure there's nothing left in that room that could cross-contaminate that other burn patient. For instance, C. diff. How long does C. diff stay on the surface of a hard surface? 4 months. So we have to really be sure that we're cleaning things correctly. And I'm mentioning C. diff because another physician asked me to come give this talk on biophysical agents to his physician wound group. And when I got done, he came up to the podium and said they were having such a problem with C. diff in their hospital that they got one of the large units and they started treating all of their rooms with this UVC light and eradicated C. diff from their hospital. So there is definitely a place for this when we're talking about a bioburden, either on hard surfaces or in wounds. Now, Teresa Conacher. Dr. Teresa Conacher, the only cellular biologist, physical therapist that I know, truly a brainiac, she did some studies on her piggies, on live pigs, and she found that irradiating the light for 45 seconds for Staph aureus did 100% kill rate for the Staph aureus. MRSA, 90 seconds, 100% kill rate. VRE, 45 seconds, 100% kill rate. Now, group A strep, not so much, didn't get rid of all of it. But this was very impressive to me when you're thinking about some of the antibiotic resistance organisms that we're seeing. So we're going to look at mechanical and acoustic whirlpool. Again, we're not doing that very much. High frequency and low frequency ultrasound. When it comes to debridement, you can go back to the debridement section to look at that. So, but let's talk about for wound healing, not just debridement now. So we know that ultrasound, it's a mechanical vibration of sound waves above our ability to hear it that causes the tissues to oscillate or vibrate and actually upregulates the tissues. It's been used in wound care for over 50 years, and it has been shown that low intensity ultrasound can reduce the wound size by 1/3. And these are some of the devices that we have now. Now, on the far left is your traditional high frequency ultrasound that you learn in physical therapy, I don't know, 202, something like that. And this is done in megahertz. You heard me say, oh, not megahertz, kilohertz. This is done in megahertz, which is 1,000 times faster than low frequency ultrasound. And we're using 1 or 3 megahertz. If you want to go deeper to muscle tissues that have been, our tendons that have been damaged, you're going to use the 1 megahertz. The smaller number is not intuitive, but the smaller number of megahertz goes deeper than the 3 megahertz. That's more shallow. Then the next one you're seeing in the middle, here is our non-contact low frequency ultrasound. We have both non-contact and contact low frequency ultrasound. And though they have similar outcomes, they actually do different things. With low frequency non-contact, you're not touching the wound. You are blowing up the biofilm. You are stimulating the cells that are important for closure. And they've actually done some studies as something totally unexpected. They found that low frequency ultrasound can help resolve help resolve deep tissue injury before it opens into a full thickness wound. And that was an accident that they even found this. And they have been able to repeat the accident and now have studies showing that non-contact low frequency ultrasound can help resolve DTI or help them to be not as bad once they do open. And then we have the contact low frequency ultrasound, which is the one, I know that Dot's used it. I know Lee's used it. I'm hoping that they're going to get one in their new center in Saratoga, New York. And it is fabulous because it blows up the slough, not blows up, that's not the word I want to use. I'm going to say kind of emulsifies the slough immediately. You don't use it on eschar, you use it on slough, but you get immediate debridement. And it's also, the energy is also going to blow up the bacteria, and it's going to upregulate the cells for wound healing. So this is your high frequency and low frequency ultrasound as something to think about for your wound healing arsenal. This is some of the things that they do. The traditional, when we have a closed wound, these are things that happen with a closed wound and an open wound. It has increased the mast cell degranulation, increases the vascular permeability for better blood flow, especially local blood flow, increases the mitogenic growth factors, increases the macrophages and the fibroblasts to the area, increases capillary density, calcium uptake for the fibroblast, increases the collagen synthesis, and increases tensile strength and the elasticity of the collagen. It's indicated for locally infected wounds. It's good for wounds with impaired circulation, those wounds that need debridement, irrigation, and topical treatment, and it's for all types of wounds, and there's a list for you. So that was ultrasound. Intermittent pneumatic compression, we've really already talked about it. It can be a mainstay for the management of chronic venous insufficiency and ulceration, and can also be used in lymphedema, but is not recommended to be a first-line intervention unless there is absolutely no choice. And consider that if you put this on for someone as a first-line intervention with severe lymphedema, that there's the potential for damaging the intact lymphatics and lymph nodes. And this is just showing venous insufficiency and lymphedema treatment, some of the different types of compression that we have. And look at this chambers. What they're trying to do here is to mimic the lymphatic flow with all of these chambers. That's what they're trying to do. That is specifically a chamber for lymphedema. Now, I don't think we've told you this yet. The American Board of Wound Management has literally sat in this course because they do recommend this course. They do not contribute to the course. They don't give us their actual questions, but they do let us know that if we're right on with the topic. They don't give us the actual test questions. That would not be fair, but they let us know if our topics are correct or not. One of the things when they sat through our course, and they've reviewed all of our questions, by the way, so a lot of the questions that you're going to get at the end of the course are very applicable for this exam. One of the things they said to do was to be sure to have in your compression section that you never put the compression force, in millimeters of mercury, because that's how it's defined, in millimeters of mercury, higher than the patient's diastolic blood pressure. So it's very important that, and I know somebody's going to ask me why, but you need to look it up and tell us why. I can't remember. But there is a reason that we do not put the millimeters of mercury for compression higher than that person's diastolic blood pressure. So that has been put in green for you and starred. Usually the ratio is 90 seconds compression, 30 seconds relaxation to allow the vessels to refill. You want to do the, once you do the intermittent pneumatic compression, that person needs to put on their compression sleeve or their compression stocking immediately, unless for some reason you're going to be putting on a 2, 3, or 4 layer wrap on them. But otherwise, once they pump, they haven't healed the valves. The valves are still incompetent. As soon as they put that leg down, you're going to get reflux. So before they put that leg down, they need to put on wherever the sleeve is going, be it the lower extremity, be it the upper extremity. Precautions for compression, of course, in acute DVT. Congestive heart failure is one of the biggies, either a remote bout that's been treated or a current, of course, an acute bout of congestive heart failure. And you want to ask the patient in their history, be very specific to ask about a history of congestive heart failure. And so I'm going to let you read this list. I'm not going to go through it with you. I do want to say that these are known as type 3 pumps. You might want to put a star by that. And again, the second bullet on the right, it says the multi-chamber programmable devices with calibrated pressure is best for lymphedema treatment after the initial manual lymphatic drainage. And the reason is at the bottom bullet, it says that it reduces the danger of damaging the superficial lymphatic structures. Pulsed irrigation with or without suction, please see the debridement section. Again, that is an exogenous energy that we use to help us with our wound management. Negative pressure, Dot gave a fabulous lecture today at our Lunch and Learn, and then she also gave us a review in her topical lecture. So what do you need this energy to do? Do you need it to debride? Consider your contact low frequency ultrasound. Consider pulse lavage with suction. Do you need to decrease the bioburden and help with the chronic inflammation that we have in these chronic wounds? Electrical stimulation, pulse lavage with suction, low frequency ultrasound, negative pressure wound therapy will all help with this. Do you need to decrease the edema? Compression, negative pressure wound therapy, electrical stimulation. And do you need to facilitate stall wound healing processes? Consider any of these: E-stim, low frequency ultrasound, negative pressure wound therapy, and pulse lavage with suction. Some of you may be sitting there thinking, well, this is a physical therapy modality. Why is she even talking to me? I'm a physician, I'm a nurse practitioner, I'm a PA, I'm a medical social worker. Well, let's talk about who can apply these. A medical social worker with a nursing degree. So according to the National Pressure Injury Advisory Panel, these energies should be directed by and under the supervision and management of a skilled, licensed professional, educated and trained in the safe and effective selection, application, and monitoring methods for this energy. It doesn't say it has to be done by a physical therapist. Now, physical therapist, I understand that you're saying, that's my modality. But I have to tell you, there are a lot of places that PTs either are not invited to, or it's not feasible from a financial perspective, or absolutely have no interest. Many therapists have no interest in wound management. They want to do their orthopedics or their pediatrics. When you don't have someone like that, then your physician or your nurse can learn to do this. The reason this has been traditionally a physical therapy modality, we take calculus-based engineering physics to understand the physics of these energies on the human body. So that is the background for why usually physical therapists do it, and it's in our wheelhouse of modalities. If you're interested, physicians, nurses, physician assistants, nurse practitioners, if you're interested, you can learn to do this and make a difference for your patients. All right, so we are at the end here. If you have some questions, we'll look at that.
I've been looking at them, Pammy, so let me go to, you know what, I need to correct one, because do you ever, you're talking about one thing, especially when you're speaking and you're thinking about something else?
Yes.
So someone had asked this question, but do you ever do that? someone had asked a question about what can you put on to prep the scales and make them easier. And I was trying to think, and so I was thinking about urea. And so then a question was asked about lacthydrin, and that is really actually ammonium lactate, and it comes in two strengths, the 5%, which is over the counter, and the 12%, which is the prescription. So forgive me for saying that it was urea. That was just on my brain for at that moment. All right, so let's see
One thing. I got a question. Lee,
Yes,
do
ma'am.
you think the day's over or something? I was just washing your clothes. You're in your shorts.
Yes, ma'am. And I'm not going to stand up until I'm sure that this video monitor is off.
All right. Okay. Yes, Dottie, please proceed.
You actually went out and washed the
I was out washing the car.
So, okay, let me get down where we stopped. Okay, so there's a question about, do you know about the bolster method with negative pressure? And I assume what you're talking about is the bolstering of skin graft recipient sites, foot fitness skin graft. And yes, I'm very familiar with that. It's a common way to bolster down skin grafts to improve your acceptance. Now, the other bolster method that may be talked about is where you put it on top of the skin to push tissue planes together. And I'm also familiar with that. What we will usually do is put in, if it's a narrower track, we'll put black gum or white gum in depending on how narrow. And then we start to slide it out, and then you bolster on top. And that helps with those fresh tissue planes to attach together better. So I'm not sure what bolster method you're talking about, but those are the two things that come to mind when I see that. So Pamela, can you explain the stocking mode to deliver electrical stimulation?
Go to another question for you, and I'll be right back with that.
Okay. Let's see. I don't know if there are any. Well, I can answer this one. If you don't recommend head hose in a long-term care facility, what do you recommend? So the problem with head hose is that if you hold one up, it's shaped like a leg. And I would challenge you to find a leg that's shaped like that. So I recommend something soft. There are tubular bandages. One is tubie grip, and the other one is tube grip or something like that. There are a couple. They're cotton sleeves that have circular elastic bands in it. And so they provide and some of them, they have them that are leg shaped, sort of leg shaped. They provide like 8 millimeters of mercury as a single layer, but they're softer, and they're not likely to create an injury, and they're easier to get on and to get off. So that's why we generally don't recommend head hose, because they are not even used that much in acute care anymore for thromboembolic devices to prevent, embolus on someone who's on bed rest.
So, and just a quick addition there's really never been any literature to support that anti-embolism stockings actually prevent embolism. That's why we don't use them anymore. But the other thing is, depending on the patient's diagnosis in long-term care and their insurance, you may be able to get one of the Velcro closure garments if they have edema and a wound. And those are so beautifully, easily put on by staff that they're, in many ways, an ideal solution for compression.
Very good point. Okay, Tammy, this was your question. Can you explain the stocking mode to deliver E-stem?
There it is. It's a stocking, and it has two. Can you see?
Kind of.
You can see okay? All right, so here's your.
Move it over in front of the camera. There you go.
Is that better? So this is a stocking for a large leg. This is a larger leg. Here is a glove. You have anybody with Raynaud's, or you're trying to do some wound healing for the hand? This is a glove delivery system. And you have a neutral place. Whenever you do electrical stimulation, and y'all won't be able to see it, but right in the middle of these, between my fingers, there's a neutral place, because you have to have a positive and negative electrode to deliver your current. So this is a stocking, and this is a glove. I also have flip-flops, and then we have the methodology for using the electrodes for very specific application.
Okay.
Hello, Maggie.
So the next one is meet Maggie. So the other one is about E-stem also. Another one is about E-stem with silver residue. Does this include simply the tissue staining that you sometimes see? And that's usually going to be with nanocrystalline, or simply don't use it at all with silver dressing.
You cannot use it at all with silver dressing because the silver in the dressing enhances the electrical delivery. It's metal. So if you're going to use silver, it's very important that you rinse the wound, cleanse it really, really well of any residue before you put the electrical stimulation on. You can use the electrical stimulation before or after the silver, but be sure you have no silver residue in that wound bed.
And this is one last one. If y'all have any other questions, hopefully type them in. And you know what? If you have questions when you're studying or when we're done, don't hesitate to email us. But this is the last one. So regarding using UVC, is this for in-clinic use? And what is the hazard to the patient or the staff?
Well, for either one, you have to be careful that you don't shine the light, of course, in the eyes. That's one of the issues. You'll have little goggles to wear. For the patient, there's something called a minimal erythema dose that you're going to test the UVC on their skin to make sure they're going to be okay, that they can use it okay. So there's a few things that you need to do for safety reasons, but there's not any major contraindications.
Okay. Well, I think we've answered all the questions. Again, don't hesitate to contact us. What you see on the screen right now is our email addresses. I think Pamela's going to close out our program with what is remaining. But from our standpoint, thank you so much for joining us. I hope that this has been really a fun group with the amount of questions that you've had. I know it ran us over a little bit, but I hope we answered them successfully for you to your satisfaction. So anyway, good luck, stay safe. If you're taking the test, let us know how you do, because I know you're going to do great.
And thank you for me as well. And once again, a privilege to be here with all of you this weekend. And my hat's off to Tiffany and Frank and company for making this thing fly, to all of you out there, wherever in the country you happen to be. So stay safe and well.
I wish you all could see them, but anyway, they've been our behind-the-scenes people that have been helping us to run this all weekend long. So we absolutely do thank them. All right, Pamela, take it away.
All right, bye-bye. A couple of closing things. One of them is, you see the test-taking strategies is the next section. So this is self-study for you. For those of you who are going to take the test soon, please look at that. For those of you who are trying to decide which test you want to take, it lists the 3 and one more. There's 3 accredited board certifications. That's the exams you want to take. Don't take any of them. There's all these wound boards that are popping up all over the place. They're probably great courses. I don't know. I haven't taken them. I'm going to take one at some point in time so I can speak intelligently about them. But you want to be sure you're taking a certified and accredited board certification. What you did here today, I could say, oh, I could give you a certificate. You've done 17 intense hours, and I could give you a certificate and say you're board certified. That's what some of these groups are doing. That is not what this is after you do a test. All right, so there's 3 board certification, and then there's one more, and Lee's not here to talk about it, but look at it, and it's a physician group that is putting together a board certification that's going to be very, very good. They've been working on it for about 5 years, and all 4 of these are listed. That one's not accredited yet or approved by the MD and DO groups, but it's coming. It's going to happen. The next thing we wanted to mention to you is you have been sent questions. We call them the black and white questions, or the multiple choice questions, and there's about 160 of them. You really want to go through those questions if you're going to be taking a board exam. The other thing I wanted to show you real quickly is if you're going to be taking the ABWM exams, the American Board of Wound Management, the CWS, CWCA, or CWSP, you want to be sure that you get these flashcards. These are some of the best study material, and someone said this yesterday, and I hope she's still here. This, not only does it give you the question, you have 4 answers, which is how your exam is going to be. It also gives you the rationale for the right answer and the rationale for why the other answers are wrong, which is exactly what the lady said yesterday that helps her with studying. This group is I'm studying mine right now because I have to do my CWS exam this year. And then they just had their new book. This is the ABWM CWS, and they have the CWCA and the CWSP. This is the new one. Be sure you get the 2019 version of these. Now, I didn't like the one as much that they did prior to this one. I think they did a much better job and organized it much better. So this is another study item that you want. And then in the test taking strategies, we also have some of our favorite books, and there's more. So if you have any questions about the course, about how we might be able to support you to become board certified, we're here for you. This has been a passion of ours for a number of years, and we want to thank you for being here. We're so grateful, and I'm so grateful to have the people with whom I get to work. Thank you so much. Bye-bye.